check test 1 2. All check check. All check. All check test 1 2. All check. All check. All check test 1 2 3 check. All check. All check.
नाही नाही मी तिकडे येणार पार्टी येणार आपण इथे काय नाही स्विच करा ओके आता येतो लॅपटॉप लैपटॉप पे जरा स्ट्रीमिंग और लैपटॉप का स्ट्रीमिंग और लैपटॉप का जरा नीचे नीचे फुल स्क्रीन है क्या था 41 एक्सटर्नल कैमरा त्याच्यावर कुठे आपल्याला कॅम 5 राजू त्याला कुठं काय का बरं स्ट्रीमिंग हे टाका ना लॅपटॉप टाका ना लॅपटॉप टाका ना लॅपटॉप हा लॅपटॉप
तसं आहे ना बा फॉन्ट तसं आहे ना
चेंज करा ना एक्झॅक्टली समजून येईल मला क्लिअर दिसत नाही बघा फॉन्ट बरोबर नाही पीपीटीच बरोबर नाही
हे काही करू शकत नाही रे आपण आयुष्यभर
हाच राहून द्या
हे काय ऑनलाईनमध्ये सगळं हे पडत ना कळलं का
लाईव्ह दाखल
hello, hello, check, check, hello. Check, hello, check, hello. Hello, check, hello, hello. Check, hello, mic check 1 2 3 4, check, hello, hello, check. Mic check 1 2 3 4, check. Hello, hello, check, check. बरोबर आहे? Check, hello, hello, check, check, check. Check, hello, hello, check, check, hello, mic check 1 2 3 4. Check, hello, mic check, hello, hello, check, check, hello, hello, check. Check, hello, check, check, hello, mic check 1 2 3 4, check, check. Check, hello, hello, check. Check, hello, check, hello, mic check, hello, check, check, hello, hello, check, check, hello, check, check, hello, mic check 1 2 3 4, check, hello, hello. शिशनला बोल, शिशन या ॲपचा ऑडिओ कमी केलाय आणि ते गेन वाढवते मी सेट केलं check, hello. Check, hello, check, hello, check, hello. कारण याच्यामध्ये काय होतं की हॅलो चेक हॅलो ओके. Check, hello, hello. Check, hello. Check, hello. हे जे इथे ठेवून दिले सगळे एक टाकलं ना बाकी सगळं फॉर्मॅट केलं कार्ड फॉर्मॅट पण ठेवलेले हे कलर वापरायचं नाही हे तीन वापरायचे दोघे कार्ड पण आपल्याच आहे ना काय गेलं गेलं चालून जातं ते थोड्या वेळचं कसं आपलं काय मोठे ते दोन स्विच ऑफ करून ठेवून दे माहिती. गुड मॉर्निंग. गुड मॉर्निंग. हॅलो चेक
नेक्स्ट त्यामुळे करेंगे
हां इथले इथे द्या ना
हां चालेल और एक कमी करेंगे
आशिषला बोलून हे आहे ना कॉपी करून घेतो पहिला
हां
तुमचं सेकंड लेक्चर आहे ना
पहिला लेक्चर
हां द्या ना प्लीज सर एक नंबर हां हे तुमचे 2 नंबर आहे
नेक्स्ट करा नेक्स्ट
व्हिडिओच नाही ना काही हां मग काही
अच्छा बस लॅपटॉप
या विच लॅपटॉप मॅक
वो डाउनलोड कर दिया
हां मी कॉपी केलं
कर दे
एक जण
डाउनलोड कर लेंगे क्या
हां हां बेटर बेस्ट तुमचं इथे केलेलं मी 2 नंबरचं तुमचं आहे ना
नाही याचं झाल्यानंतर ते 2 नंबर किंवा मी क्लिक करतो
हां नाही ते मी देणार ओपन करून देणार
हां
तुम्हाला
चालेल इथं थांबताना तुम्ही
हां अशी ऑपरेटर असलं नाही इथं हे तुमचे पेंट आहे
नाही मला आता हे सगळं एक मिनिट मला आता बघ ना कसं होईल नेक्स्ट
किती अपडाऊन
एक काम करा हे थोडं पुढं पाहिजे सर
पेंट
हे बघा
ते पॉवर जास्त
सर हे थोडं असं पाहिजे असं बोलताय
अशी ऑन कर
हां थोडं
तुम्ही पेंटर तिथं पेंटर
ये नहीं पेन ड्राइव ये
व्हिडिओ द्या
हाँ नहीं वीडियोस नहीं स्लाइड है
एक ही इसमें बराबर जाएगा शॉर्ट पे रह जाएगी
ओके सर
पेंटर
एक सेकंड में
सर ते पेंटर
त्याला हे लागतं ना तुमचं काय म्हणतात हां ते एच डी बोलतो
सगळं एच डी में
तुमच्याकडे
हां करू ना ॲक्च्युली तुम्हाला हा रेफरन्स आहे इथला मॉनिटर
ते लावून बघा ते बघा ते इथून मारलो ना
हां
हे पोझिशन जाते आलं बघा
ठीक आहे हां आलं PPT ऑन PPT ऑन कर
बस झालं पीपीटी मग होतं दिसतं ना तिथं
हां, दिसतं. काही काय problem नाही.
म्हणजे दॅट बिकम्स इझी
कल तू
त्यांच्या पीपीटीमध्ये ऑडिओ नाही ऑडिओ नाही आहे त्यांच्या फक्त नॉर्मल आहे
हां हां
बाकी जे टाकले प्रिंट त्यांच्यामध्ये
हे हा ड्राईव्ह आहे हे 2 नंबरचे आलं पेज हे तू एक तुला जी आहे ना मी लिस्ट पाठवतो प्रोग्रामची बस आहे येस ठीक आहे सेकंड अच्छा सेकंड त्यांनी याने दिलं
फिशरी नैनो का है मेरा सेकंड वो 15 वाला है
हां
ओपन आहे
हे पण आहे ह्या सरांनी दिला
नहीं पहला नीचे नहीं वो नीचे वाला
हे आपका ही आहे ना तो लोड हुआ ऑलरेडी
नाही नाही आप पेनड्राईव्ह ओपन झालं
ते कॉपी करा आणि तिथे एक दोन कर
ये फाइनल फिशर गोदरेज इसको कॉपी करो
ऑलरेडी सेकंड लेक्चर म्हणजे मैंने दिया
कल का है वो सीट फाउंडर वो भी आज आपने कल दो
कल दीजिए सर
वो कल देते हैं
जैन आपका
फाइनल फिशर गोदरेज बढ़िया
सरांचं नाव काय फोल्डरला नाव विच लेक्चर
नाही माझं पहिलं नाही माझं आप डाल दीजिए ना
So name actually numbering टाकून सरांचं नाव नाव सेकंड नंबर टाका
ये देखो
अब फर्स्ट ना
हाँ मैं बस
हे फर्स्ट
फर्स्ट है
तुला मी एक हे पाठवलं
नाव काय कौन सा आपका ये ऊपर
रेक्टम है
कॉपी पेस्ट के मारो कट नहीं किया
तुला मी हे पाठवलं व्हॉट्सअपवर तुला पाठवलं
एक बार ओपन करके देख लीजिए
आपसे रीनेम करेंगे या सर्कल नेम डाल दीजिए प्रॉब्लम शीट में पाठवलं
ओके सर
एनी वीडियोज एनी
नहीं नो वीडियो थ्योरी टॉपिक दिया सर ने मेरे को 5 वीडियो ठीक
राईट डाऊन दे एक नंबर क्या सिरियल नंबर टाकून दे त्या सरांचं नाव टाकून दे सर
डॉक्टर विकास से लिख दीजिए उसमें जो अपना टाइटल है
हॅलो.
कमी कर.
अरे ये राजू, इसको भी ऑनलाइन करेंगे ना? यस सर।
लॅपटॉप चालला ऑनलाईन होता. हां 5 नंबर.
Good morning, everyone. Good morning, everyone. A very warm welcome on behalf of Godrej Memorial Hospital, International Society of Coloproctology and Surgical Society Thane. It has been a very, very long time since we have met like this, and it's very nice to see you all bubbling with lots of energy. We'll start with the start the session with Dr. Vikas Jain. Dr. Vikas Jain will talk about the surgical anatomy of the aneurysm. Dr. Vikas.
My talk rectum anal canal first talk. हाँ दे चुका सर ऑलरेडी
दिया नहीं अपना इंट्रोडक्शन.
चल ये है ना आपको.
या तुम बोल देना.
See, for this session, the moderators are Dr. Shanti Kumar Chipte and Dr. Kanekar. Sir.
Very good morning to all of you. I am thankful to Dr. Jatin, Dr. Chivte sir and Dr. Ladukar sir for inviting me to present this basic and the first talk on coloproctology, the rectum and anal canal. So everything has been said before, but since not all listen, we have to keep going back and begin all over again. That's what a French author has told. And again we have to revise the anatomy, and that is the backbone of all the surgeries and innovation in coloproctology. So first is I will start with rectum, then anal canal. Rectum is the lower dilated portion of the large gut, lies in the pelvis. It is in between sigmoid and anal canal. The rectum is devoid of tinea coli, circulation, appendices, eupiploid and mesentery. They are all basic. I am just touching the basic and just revising you what you have learned during your MBBS and post-graduation day. So it is not straight in man, it is curved anterior-posterior and side to side. It begins at the continuation of the sigmoid colon. It is at the level of S3 vertebra and 2 to 3 centimeter in front and just below the tip of coccyx. That is anorectal junction. Length is around 12 centimeter and breadth is 4 centimeter, and it has various curvature, anterior-posterior as well as lateral curvature. Anterior-posterior curve is basically posteriorly convexity on the back side, and lower part it is convexity on the front side. The curvatures on AP, it has a lateral curvature also. There are two convexity on the left side and one on the right side because of the presence of the wall. Then peritoneal relation, if we see the peritoneal relation of the rectum, anteriorly in male it is the rectovesical pouch, and the upper 2/3 of the rectum is intraperitoneal and lower 1/3 is retroperitoneal. Posteriorly throughout the rectum is retroperitoneal. All this, each and every reflection has its anatomical importance as well as surgical importance. I will tell you later. In male, it is rectovesical pouch anteriorly, that is 7.5 centimeter above the anus. What is the importance of it? Because whenever we go for suture rectopexy and now the Chivte's technique for the rectal prolapse, we always have to understand that the suturing should be done below 7.5 centimeter if you going anteriorly, otherwise we can suture the peritoneal structures. In male, it is 7.5 centimeter. Laterally on either side is the pararectal fossa. In In female, it is the rectouterine pouch of Douglas, that is again 5.5 centimeter above the anus. 5.5 centimeter, that is important landmark. We should not give stitches above 5.5 centimeter, otherwise we can touch the peritoneal organ. On either side, in the upper side is the pararectal fossa. Relations in front, I have learned. Then below the rectovesical pouch is the anteriorly is the rectovesical fascia of Donenwiller, that is a tough fascia, and posteriorly it is the fascia of Walder's. This fascia is very important in malignancy because once it crosses the fascia, the stages of the disease changes. Similarly, in female is the rectouterine pouch, then rectovaginal fascia. This is thin fascia. General relation posteriorly, if we see, all the sympathetic and parasympathetic nerves are there and with the ganglion. Laterally, pararectal fossa in the upper third, in the middle third, pelvirectal space and levator ani muscles, and lower it is ischiorectal fossa at the level of anal canal. Interior of the rectum has a mucosal folds. Various mucosal folds are there, temporary as well as permanent. Temporary folds are there in the lower part. They are longitudinal fold, but that disappear on distension. So that fold are not very anatomically important. The permanent fold are basically formed by the Houston walls. What is this walls? This is the reduplication of mucous membrane formed by the submucosa and thickening of the circular muscle. This Houston wall is very important, and anatomically there are various 4 or 5 walls are there, horizontal semilunar walls. So the first and the third wall is constant, and second and fourth are not constant. The first wall, if you see, it is at the rectosigmoid junction, that at the level of S3 vertebra, that defines, and sigmoid is converted into rectum, or the rectum starts at that level. It is 12 to 14 centimeter above the anal canal. It is on the right side. Then again, the third wall is the most important and consistent. It is at the level of 8 to 9 centimeter, and that is called as Nileton's sphincter. The importance of this is it divides the rectum into the upper and the lower part. What is the importance of upper and the lower chamber is, upper is the pre-allantoic hindgut, while the lower is the endodermal cloaca. So upper contains mainly feces, and without the reflect act of, if the motion is there in the upper, there is no act of defecation start. But if the motion crosses that below that level, that is in the lower chamber, then basically the process of defecation starts. Second wall is 2.5 centimeter above, but they are not very important. Basically, they are define the curvature of the rectum. Now, importance of this valve is what I have told. It supports the weight of feces, prevents the passage of instruments. The importance is while doing the instrumentation in surgical anatomy, while going the rigid sigmoidoscopy, if we smoothly passes through this valve, the injury to the mucosa and the valve will be avoided. Now the arterial and venous drainage. The arterial supply is basically from 5 rectal artery, the superior rectal, middle and inferior rectal, then few sacral vessels. So mainly superior rectal artery, that is main supply of the rectum, that is coming from the inferior mesenteric artery or termination of the inferior mesenteric artery into the superior rectal artery. That is the principal artery of the rectum. It supplies the entire mucosa and the upper musculature. It straight arises from the plexus. Then middle rectal artery is the branch of the internal iliac artery, and it supplies the lower part of the rectum. The inferior rectal artery, basically the branch of internal pudendal artery, it supplies the perianal skin and the sphincter ani. There are other arteries, are the medial sacral artery that supply the posterior wall of the anorectal junction. It is direct branch from the aorta. Why this artery and then venous plexus? They are two set, internal rectal plexus and the external rectal plexus. So they form the annulus hemorrhoidalis, because this venous and the arterial drainage and the capillary system forms the main feature for hemorrhoids. So the most important part, this is again the part of porta systemic communication at the superior and the inferior rectal vessels, because they directly draining from the internal iliac to the IVC, and while superiorly it is the branch from the it drains into the inferior mesenteric artery. So in case of portal hypertension or cirrhotic patient, the portal systemic anastomosis, and now we are seeing the cases. Initially we cannot define as they are hemorrhoids, but they are rectal varices. So lymphatic drainage are along the vessels, and in the upper part they drain into the internal iliac, common iliac or pararectal node, while in the lower part, that is most important, and in anal canal it is goes to the superficial inguinal lymph node. Nerve supply is through sympathetic and parasympathetic nerve. Sympathetic L1 and L2, it stimulates the sphincter and inhibits the musculature. So sympathetic is basically leads to the constipation over sympathetic activity, while parasympathetic overactivity leads to diarrhea because it inhibits the sphincter and stimulates the peristalsis. So that is importance for the drugs. So whatever we have learned, there are various supports of the rectum. One is the levator ani muscle that is from the pelvic floor, and that is the most important support of the rectum. Then anteriorly, posteriorly Waldear's fascia, laterally the lateral ligament of rectum, rectovesical fascia of Denonviller, pelvic peritoneum, perineal body, and the pelvic and istiorectal fat. Now comes to the anal canal. Terminal part of large intestine around 3.8 to 4 centimeter in length begins at anorectal junction and it has anterior wall shorter and the posterior slightly longer. Anteriorly perineal body, male urethra and the bulb of penis. Why these are all important? Whenever we go surgery during the anal canal and while doing the suture mucorectopexy, if we go deeper in the suturing, then we can injure the various anatomical structures. So it is very important to know the anterior, posterior, lateral and all round relations. Same what we have learned in rectum. So anal canal is divided into 3 parts. The upper part, pectinate line divides the upper part into the intermediate part, and the third is the Hilton's line. Upper muscular part is 15 centimeter in length, which is the shaded area. It is endodermal in origin, lined by semi-transparent mucous membrane, and it is plum red in color. Simple columnar or stratified columnar epithelium. The upper part has the column of Morgagni. The most important is there are various longitudinal folds are there, mucosal folds are there. It is formed because of the reduplication of the mucous membrane. It contains the radicals of superior rectal veins. So the upper part importance is because of the injury to this part lead to anal fissure. Because of the glands are there in the upper part, so the chances of infection and the source of rectal abscess or the fistula is commonly at this fold only. So the upper part is very important, and always we have to look for the source of infection in all the cases of perianal abscesses. The upper part and middle part is divided by the fold of dentate line or pectinate line, that is a whitish line that divides the upper into the middle part, and it is the crescentric mucosal fold. It connects the lower end of the anal column and it divides the upper surface and the lower surface. So the importance of dentate line is all the developmental as well as the arterial and the lymphatic drainage are different above and the below the dentate line, and almost all the 85% of the disease starts above the or at the level of dentate line. The upper muscular part is presence of the anal papillae, epithelial processes are there, and they are remnant of the anal membrane. Sinuses are also there, that's what I have told. Because of the sinuses, because of the glands, the infection starts usually at this recess. Intermediate or the area of pecten, it is 15 centimeter. It is ectodermal in origin. The above is the endodermal in origin, that is painless, but the below is the endodermal in origin. Because it is painless, so whenever the disease start in the upper part, usually it is painless, and when the patient, it crosses the dentate line, then only the patient have the features of pain, and then only patient have all the symptoms. The lower part is basically the continuation of the anal skin, that is 8 centimeter ectodermal origin, true skin with pigmentation. Corrugation is basically because of corrugated cutis ani muscle. Coarse hair are there in between. Then the intermediate area of pectinate, is the color contrast between the bluish pink mucosa above and the black skin below. Same anatomical structure in AP view. Now comes the musculature of the rectum and anal canal. The outer is the longitudinal, it is thick, anterior thick band and posterior thick bands are there. This longitudinal muscle is continue as the internal sphincter. So this longitudinal muscle continue as the internal sphincter, while the external sphincter is formed by the puborectalis or levator ani muscles. So it has various parts. I will come. So conjoint fibroelastic sheaths are there, that is formed by the levator ani as well as the longitudinal muscle that divides the internal as well as the external sphincter, and that is forming the septa, and the intersphincteric groove is formed by this. So medially is the that is the conjoint fibroelastic sheath is there in, and that divides medially into the internal sphincter and laterally into the external sphincter. So internal is the thickened lower circular part of the rectum. It is involuntary because it is the continuation of the longitudinal muscle of the rectum as well as the large bowel. While the external sphincter, basically it has 3 parts: the superficial, subcutaneous, superficial and the deep part. And they are striated muscles, they are voluntary muscles, they are the voluntarily control the sphincter. So deep, superficial and subcutaneous part. External sphincter is supplied by the inferior rectal nerve, that is perineal branch of S4. It controls the subcutaneous is the perianal, then superficial, and the deeper is laterally. What is the importance of this external as well as internal sphincter? What we have told, it is the external is the voluntary muscle, it is non-voluntary muscles, it is supplied by pudendal nerve, it is supplied by autonomic nerve, parasympathetic as well as sympathetic. Muscles is very important to identify while doing the internal sphincterotomy. The internal sphincter is pearly white in color, that is easily identifiable. It is cord-like structure that is just to the mucosa. So in summary, the anatomy of the rectum is measures approximately 12 to 15 centimeter in length, divide into the lower, middle and upper third. Blood supply consists of superior, middle and inferior rectal artery. Lymphatic drainage follows the artery. Anal canal, internal sphincter is composed of circular, non-striated, involuntary muscles supplied by autonomic nerve, while external sphincter is composed of striated muscles and supplied by pudendal nerve. Extension of the longitudinal muscle support the sphincter complex. Space between the sphincter is known as intersphincteric plane. That is again very important in the sphincter. What we see, the internal sphincter is round, while the external sphincter is a slit oval shape. So if we go for the anatomical importance, what is there not in there in this slide? If we go for the posteriorly, the internal sphincterotomy at 6 o'clock, there is always a slit because of the round shape of the internal sphincter and the elliptical shape of the external sphincter. So there is always a gap is there, and that leads to the false defect. So the internal space between the sphincter is known as intersphincteric plane. The superior part of the external sphincter fossa fuses with the puborectalis. muscle which is essential for maintaining the anorectal angle and that is necessary for continence. The lower part of the anal canal is lined by sensitive squamous epithelium. Blood supply is through the superior, middle and inferior rectal vessels, and lymphatic drainage of the lower half of the anal canal goes to the inguinal lymph node. That is again very important. So what I have told in the beginning, a French author, what here again we have to learn and learn and relearn. Thank you.
That was really a fantastic presentation, Dr. Vikas, and thanks for revising the anatomy. But we'll take a break now, and I'll invite Dr. Sapatnekar sir to kindly light the lamp. Okay, we'll do a formal inauguration. Dr. Chivte, President ISCP, Dr. Ladukar, Dr. Prashant Rahate, kindly join. Dr. Hemant Patil, Dr. Dilip, Dr. Rajiv, Dr. Kodwani, please join, sir.
पर्सनल लोन मतलब मानी
ऍड येतो ना यूट्यूबला.
शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः
Hello, I'll request CEO of the hospital, Dr. Sapatnekar sir, to say a few words. Sir.
Thank you, Dr. Jitin. ISCP, in collaboration with Godrej Memorial Hospital, we are holding this camp. I'm very glad about it. I'm also glad, I must mention, in the interest of patients, that cardiology, cardiothoracic surgery, neurosurgery is all glamorized. This is a branch which there is avoidance. Take for example, water supply and sewage disposal. Water supply, the PSM people will attend. Sewage disposal, when it is there, it is avoided. Any time digestion process is being taught, right from mouth up to small intestine is fine. Large intestine is avoided and missed. So this part has to be revisited at the broad level. As I said, sewage disposal, that's a major problem all over the world. And whereas at human level, the lower end, that has to be discussed, that has to be kept in mind. I had teachers who had said that unless you do minimum 5 per rectal examinations, you should not be allowed to do second surgical term in second MBBS. That time we felt it's very odd. Later on we realized its importance. So doctors, they know it, all are experts. This being a camp held, and the publicity, the donations, all this happening, the patient should not avoid telling. That's the trouble with so much of not mentioning the topic. If one suffers from headache, one tells it. But lower end, if there is any problem, it is not told, it is not discussed, it is hidden, and therefore delay in diagnosis. And we know delay in diagnosis leads to complications. So earlier the diagnosis, the better. The topic therefore is very important, and ISCP has taken a lead, and a free camp is being conducted. I am very glad about it. I declare it inaugurated.
Thank you so much, sir. And thanks for your nice words, and thanks for emphasizing the importance of anorectal surgery. Now I'll like Dr. Chivte sir to say some words, if he wants to say.
Good morning, everyone. CEO of this hospital, Dr. Ladukar, Dr. Ate, Dr. Nitin, Dr. Shanti, who has come from the Hyderabad. I think I need not to tell this crowd that what is the importance of the colorectal things. See, whatever we are achieved in our dissection hall for anatomy, that is not very useful when you are operating. Discussing on the diagram and discussing in anatomy hall is same. So every surgeon, while he is operating, he is learning anatomy every day. So I request all the people that we should see patient while operating with this view. That is one. Second thing, ISCP is bound to give something new and something regularly to people. Now our body has decided that we will conduct classes, regular classes, teaching classes for the residents of the surgery all over the Maharashtra first and later on India. So this is a new thing what we are going to start it from this. And this is the inspiration taken from the Godrej Hospital and Dr. Nitesh. Thank you very much. I declare that we welcome all of you, and you will enjoy at least these 2 days, and you will take something with you. Thank you very much.
Thank you, Chief Sir. Now I'd like to invite Dr. Kodwani sir. He has come all the way from Tumsur and he is the recipient of lot many awards, one of them being Excellence in Medical Field, some Bharat Bhushan Award, and he'll be talking about management of fishery nano.
Good morning to all those who are sitting here in the offline conference, as well as being a hybrid conference. Good morning to those also who are present here virtually from their OPDs, from their living room and from other parts of their house. So friends, first of all, I would like to thank Dr. Jitin for arranging such a nice conference after a long gap of COVID pandemic, and surely everybody will get a lot of good feast on proctology. And as my earlier speaker, Dr. Vikas Jain, has nicely put the basics of the base, I will continue it further with clinical topics. And I am bringing you the greetings all the way from the rice city of Tumsar and Team Kodwani Hospital. Friends, the topic given to me is fishery nano. Start. And what is a fishery nano? Start is a tear or a split in the anodome just distal to the dentate line. Then this is the pictorial diagram of fishery nano. This is the classical triad of chronic fissure. I will come to that later on. The classical triad of chronic fissure is explained by the proximal apex of the fissure is having hypertrophied anal papilla. The distal apex of the fissure is having sentinel skin tag, and the fissure with heaped up scar edges and visible internal sphincter. These are the three cardinal signs of chronic fissure, which I'll come to later. What is chronic and acute? This is the photo of fissure in nano. This is at 6 o'clock position. Now, as I said, the types of fissure. There are two types of fissure, depending on the age of the symptoms. The acute fissure, these are usually caused by mechanical force which are generated by the passage of large bowel movement through an anal canal, and which is too small to accommodate it safely and easily. And as I said, there are fissure, mostly they are posteriorly lined out at 6 o'clock. It's in 90% of the cases. The another postulated theory as far as the occurrence of fissure is concerned is the decreased blood flow, or it is the increased mechanical stress that may account for the propensity of these fissure to occur at 6 o'clock position. That is the theory of ischemia. And also the repeated injury, it may be the hard stool, or it may be increased frequency of the stool which is watery in nature, that results into the development of chronic fissure. Now this is another type of fissure which is superadded with the fungal infection in the anal area. Now coming to the clinical evaluation, the symptoms itself, they are telling about the nature of the disease. It's a pain, like a sharp cutting pain, as if somebody is passing some sword or knife or blade into the anal area whenever the patient passes the stool. And sometimes it's a streak of blood, it's a red, bright red blood, streak of blood which is coming over the stool, and it is associated with anal spasm, and this pain continues for pretty long time. In some cases the whole day pain is there, but in most of the cases usually the pain persists for 2 hours even after the defecation. And for that reason, the patient afraid to go to the washroom, the patient starts limiting the diet so that he or she may not need to go to bowel very frequently. Now, how the clinical examination is very simple. On the physical examination, it's very difficult. Patient guards himself or herself for the examination, and simply by splitting the buttock, it's very painful. And on examination, you can see there is a split in the enoderm. It's about 1 centimeter, 1.5 centimeter. Most of the time it is in the posterior midline and just distal to the dentate line in the anal verge. Now in chronic fissure, as I said, there is a triad of hypertrophy of anal papilla at the proximal apex of the anal fissure. The anal fissure is seen with the thickened epithelium and visible internal sphincter, and there is a sentinel skin tag. Most of the time what happens, because of this sentinel skin tag, the patient mistakes and says, I have got bawasir, I have got piles, किंवा मला मूळव्याध झालेला आहे, because they don't understand the difference of hemorrhoid or fissure. That we have to evaluate. And there is a long history, there may be long history in chronic fissure. As I said, the patient has to be taken in lateral decubitus position, and gentle spreading of the buttocks will be very painful to the patient, and patient will be guarding, patient will be safeguarding कि डॉक्टर साहब मत करो, हो गया, दुखता है, छोड़ दो. So, and in these cases, the digital rectal examination and proctoscopy has to be avoided. If at all it is to be done, it should be done in OR under the anesthesia. Now, telltale sign is that mere spreading of the buttocks causes a great deal of discomfort accompanied by obvious anal spasm. That's what I told you. The sentinel tag is often indicative of chronic anal fissure. Now, as I said about the diagnosis, now coming to the management part. The management part, as I said, is divided in two parts, is the acute fissure and chronic fissure. Depending on the time scale of symptoms, the acute anal fissure, it has got the history of less than 6 weeks. But once more than 6 weeks fissure is there, it becomes very chronic and very difficult for the medical line of management. That's why the management has been divided into two parts, in acute fissure as well as chronic fissure. Now for the acute anal fissure, the non-operative treatment usually helpful, and most of the cases, almost 85 to 90% of cases, it heals. The non-operative treatment consists of rich fiber supplement diet, the stool softeners, generic water intake. The lot of water patient has to take so that the bulk of the stool will be soft, it will not be hard one. Seeds bath, this is very important. The warm water is to be given to the anal area twice a day, and also after every passed motion the seeds bath has to be given. Now some doctor may advise for some medications like hydrogen peroxide, some betadine or Dettol, but in my view simple warm water seeds bath is sufficient. Also local anesthetic ointment will come to that part, and some diltiazem will come to that later on. For the chronic anal fissure, which has got the history of more than 4 to 6 weeks, they respond very less to the medical line of management, and for that patients the surgical procedure is to be advised. Now there various surgical procedures are there, out of which we will discuss some. The surgical procedure of choice is lateral internal sphincterotomy. The cure rate is almost 95 to 98%, but some along with some complications. If surgical procedure is done in too much hasty, too much in a bigger way, in a bigger sense, the incontinence may occur. But if surgical procedure is inadequate, the recurrence of the fissure may occur. The complications are incontinence to the flatus, swelling, as well as fecal incontinence. Now coming to the surgical management, the primary goal in the treatment of chronic or non-healing fissure is to decrease the abnormally elevated resting tone pressure. As you know, 80 to 85% of the anal tone is coming from the internal sphincter. Internal sphincter is responsible for the resting anal tone. The normal anal tone has to be between 40 to 60 millimeters of mercury. In case of anal fissure, the resting tone goes above than 90 millimeters of mercury. Our goal is to relieve this pressure. The surgical procedure, various procedures are, first is anal dilatation, second is lateral internal sphincterotomy, third is fissurectomy, fourth is flap advancement. Now, what are in the different options? Coming to the first, anal dilatation. This manual anal dilatation for the fissure was first reported in 1964, and the various methods for this anal dilatations are used, like 4-finger method, balloon retractors, rectal dilators, pneumatic balloon dilators. But because of lack of standardization, lack of inconsistencies with these the procedures, so this has got a bad repute, and the chances of tear of the internal sphincter, haphazard tears, soiling, incontinence, this has got into the bad repute. Now, this method has also criticism owing to its complications like incontinence and diffuse haphazard damage of the sphincter, which I have already told. Now, second is the lateral internal sphincterotomy. This was introduced by Eisenhammer in 1950, and initially it was through the bed of the fissure, at the 6 o'clock position, but because of keyhole deformity, it's a groove-like deformity, the people have changed the site, and now laterally at 4 o'clock, at 7 o'clock, at 8 o'clock, the people are now preferring for the lateral internal sphincterotomy. The lateral subcutaneous sphincterotomy was popularized by Notaras in 1969, and this is associated with the less functional complications. This is the open lateral internal sphincterotomy. You can see the internal sphincter has been brought out with a small incision. Now, complications of the open sphincterotomy. Lateral internal sphincterotomy is thought to be the gold standard procedure for fissure, chronic fissure in ano. The only, most of the time the complication is like incontinence. If it is done at a larger scale or a complete internal sphincter has been torn, the chances of incontinence are there. So, I will come into the detail in my next slides. What to be done, at what level, at what extent the sphincterotomy should be done. The inadvertent division of external sphincter also affects the overall healing. While we should not touch the external sphincter, it's only the internal sphincter we should go for division. Now, coming to the medical line of management, as I said, in acute fissures, the medical line of management should be tried first. Apart from the fiber diet, stool softeners, plenty of oral liquid intake, the medications like GTN, topical nitroglycerin, this is more helpful. This has got the promising result, about 65% it has got the healing rate. Also, nifedipine, calcium channel blockers like diltiazem, this also relaxes the internal sphincter and reduces the internal sphincter tone. And from the last few years, the infiltration of the botulinum A toxin have come a long way, but the chances of recurrence with the botulinum toxin are there. So, and moreover, it is costly also. My take home message is division of internal anal sphincter for the length of fissure is associated with less functional impairment as compared to the division of internal sphincter up to dentate line. So, we should not divide the internal sphincter up to the dentate line. We should keep it restricted to the length of the fissure only, so that the chances of incontinence should not be there. Thank you. One more thing I would like to add, as internal sphincterotomy, there are two methods. One is open sphincterotomy and another is closed sphincterotomy. This is the picture I have shown of the open sphincterotomy. With the 11 number knife, I have gone at the between the internal and external sphincter groove. I take out the internal sphincter and divided it with the cautery. Another method is close internal sphincterotomy, which usually the people do with 11 number blade, or what I prefer to do is the cataract knife. That is a close internal sphincterotomy. As far as the results, both are same in the open or close, but the patient compliance, recovery is more in the close method of sphincterotomy. Thank you so much.
Thank you so much. Thank you, Kodwani sir. Very nice and elaborative lecture. Any questions from the house?
Yes.
Any questions from the house? So one thing we learned that we should avoid anal dilatation at all cost, and this is the procedure which has to be shunned. And this thing, for the next session, may I invite Dr. Prashant Rahate sir and Dr. Ladukar sir to kindly chair the session.
See, usually it is called manual anal dilatation. In short, it is a mad dilatation. That's what we thought it earlier. But after seeing results of internal sphincterotomy, even though you make tailor-made, means up to Fisher size, that will have more recurrences. And if you do up to dentate line, you will have more incontinence. Up to 7% liquid stool can be leaked. I am not saying it is totally gone. So we gone back to, there are certain papers. You do manual anal dilatation, but measured one. In female, it should not be more than 4 centimeter any time. And in male, it should not be 4.5 centimeter. You will say how you will measure, not by fingers, but you should have measured dilators. And you dilate when you are dilating with that only. Then minimum problem is there. Minimum leakage of the gas is there, minimum leakage of the loose stool is there, and this will have small breaking points, but they heal later on. When internal sphincterotomy do, we are making a big gap. Again, after doing internal sphincterotomy, again you are putting your 4 fingers and dilating it. So that is not restricted. So this is my, little suggestion, and it has come back anal dilatation later on also. Thank you.
Sir, as far as what you said, it reminds me, to my experience, what I do, usually I go for close internal sphincterotomy with the cataract knife. Before putting my knife, I judge the tone of the anal sphincter, although the patient is under anesthesia, but you can feel the tightness of the internal sphincter because it is involuntary muscle. And after dividing with the cataract knife as a close internal sphincterotomy, I do assess whether the tone has reduced and whether it can accommodate my 4 finger without any much of the pressure. If at all it does not accommodate 4 fingers, it means your division is inadequate. You search for some fibers, you feel for some fibers, and if at all you need to make it dilatation, you do it very gently. What I call this as a controlled anal dilatation. So the haphazard rupture of internal sphincter is not there.
No, when you are saying you are doing tailored, sphincterotomy, some fibers are going to be there.
True.
So you cannot say that I am doing total sphincterotomy. If you are doing total sphincterotomy, you have to face incontinence.
Incontinence, very true.
So it is better.
Huh.
You do whether tailored these things or not, but this is coming back. You do major dilatation, whether you do sphincterotomy or not.
True. So it should accommodate at least 4 fingers very easily. So that should be our point.
So, Kodwani sir, usually as acute fissure patients are having severe pain,
True.
Patient will stop your examination. In my observation, what happens in other condition which usually anorectal abscess will be missed in some cases. How to deal such? Patient will come, we will think of fissure, but later date they will come with abscess.
See, in case of abscess, if it is a burst abscess, the pain has to be already been relieved because of passage of the abscess, number 1. If the abscess has not been drained out, there has to be some swelling, number 1. Number 2, there won't be like sharp cutting knife pain and bleeding history in case of abscess is there. So history is very important, as well as physical examination, simply by splitting the buttocks for examination, will give you the picture of fissure or anal abscesses there.
We'll end the questions here. We'll take up the questions in the tea time.
Thank you so much.
You heard about the various types of fissurectomy and sphincterectomy. The next topic is about laser fissurectomy by Dr. Godrej. He has come all the way from Solapur. Thank you, sir, for coming. And as you are aware, the laser has come in a big way. So is Dr. Godrej. Dr. Sir.
My previous two speakers have covered the anatomical part, and Godrej has covered the pathophysiology of the fissure. Now the old methods, that is examination of the patient, is very important. Without examining the patient, one should not conclude the pathology. Even though it is painful, the general practitioner or physician or in regular OPD, nobody will assess the anal tone, or at least it is very important in the beginning only. If that you have to treat conservatively or it needs the intervention, is very important. To cover all these things, now next year. So the sphincterotomy has come in the picture with open method or the closed method. But the laser sphincterotomy is very precise, very useful. And as the anatomy part and the pathophysiology has already covered, sphincterotomy of the lateral intersphincterotomy is a procedure that used to cut the internal sphincter by either by open method or by laser. So it relieves the spasm at the sphincter point, and it also heals the tissue properly by increasing the vascularity. This is a anatomy already told. The laser fiber is to be passed in between the internal and external sphincter where the dimple is felt. Through that, the laser fiber is to be passed very precisely and very accurately. You can cut the internal sphincter with a good experienced hand. Laser sphincterotomy for chronic and acute fissure is used. The laser source is adjusted for the required settings. Laser tip is adjusted, length and the bare fiber. The laser tip is inserted into the natural opening in the anal at the mucocutaneous junction at 3 o'clock position between the internal and external sphincter, and it moved medially from medially to the laterally till the feeling of giveaway sensation. This relaxes the tight anal sphincter muscles you can experience during the complete cut of the internal sphincter. This elevates the pressure, reduces the pain, allow the fissure to heal, simultaneously simulate the mucosa to regenerate and regenerate. The chronic fibrous scar and the fibrotic granule tissue is also debrided with the laser spray. The precaution during the surgery is very important. Before the procedure, the laser settings are to be adjusted according to the need. The maximum permissible exposure, the level of laser light to which the person may be exposed without any risk of injury. Operator must calculate depending on the output power, watts, irradiation timing, and the process, how much time it is to be required. The local heat generate needs cooling and cold ice fingers after the procedure. The post-surgical care to ensure the safe and good recovery, a patient has to keep following things in mind to follow them. The stool softener has to be used after that, high fiber diet, keep the anal area free. After the bowel movements, the wound is to be cleaned with running water or with the seeds bath. Get back to normal work activity immediately, so there is no need for the hospitalization with adequate hydration, and follow-up instruction is to be followed. My topic is the precaution you should take after the laser lateral sphincterotomy. The complications of the laser, if the fiber is misdirect, the fiber is overused over time, and direction of the fiber is very important. The perforation of large blood vessels, surrounding vital structures, eye damages, skin damages after prolonged use. Another complications like fire explosion, gas embolization, atmospheric contamination due to fumes are also possible. The risk involved, the surgery rarely turns into a complication situation unless it is used very judiciously. It may cause infection, it develop the infection, bleeding may occur, difficulty in passing urine may occur because of the close proximity of the viscera. The anal fistula may develop, soiling and leakage may develop, but this can be avoided. The laser is contraindicated in pregnancy, area of impaired sensations, infections if there is abscess or any early necrotic changes. The hemophilia cases, it is to be avoided. Now I will cover the how laser machine is to be guided, how the beam is to be used, what precautions you have to take to prevent the complications and proper precaution that we have to take. The beam is direct, it follows the nature of the light, it travels in a straight line. The laser light will be partially absorbed, raising the temperature of the surface or interior part of the object, potentially causing the alteration and deformation of the tissue material. These properties which have been applied to the laser surgery can also cause tissue damage. Judiciously it is be used, it will damage the tissue where it is required and where it is indicated. The laser effects on the tissue depends on the power of density of the incidential laser beam, absorption by the tissue, depth on the wavelength, the time of the beam held on the tissue, the effect of blood circulation and heat conduction in the affected area or in the surrounding area. So the correct control of the laser parameters must for the good results. There are the three mechanisms by which the laser works: photocoagulation, photovaporization and photoablation. In photocoagulation, laser hits the tissue 50 to 100 degrees, denature the protein and other biomolecules, shrink the mass, water expelled, heat generate, loses integrity, cell die or tissue at the site only damages by photocoagulation. And in photoevaporation, the tissue temperature is above 100 degrees, water tissue boils and evaporates, water evaporates, 70% of the body water is boiling and changes the tissue into gas, complete removal of the tissue. In photoablation, high power lasers are used, but that is not required in this laser spectrotomy. Before using the laser machine, you should observe the standard precautions as the guidelines are given by the international agencies and the standard performance, the standard procedures, the American National Standard Safety for the laser use, occupational safety and health administrations are important. The Atomic Energy Regulation Board has certified the machines, then only it is to be used. Safety in the design and application of the laser is very important. We must follow the instruction by the manufacturer. The engineering control, the machine should have a good interlocking. Overuse should be stopped. The automatic, the laser beam enclosed, the beam should be enclosed. So the laser follow the light mechanism. It travels in a straight directions. To avoid the spread, we have to enclose the beam with a protective material. The type of the lasers and wavelength and average energy of the power are to be very strictly followed. The administration part is also important. The standard operative procedures which causes the hazards, the control measures, and authorized person should take the training. Laser protective barriers, entry way warning lights, and international laser warning labels should be applied in the premises. The laser should be operated by the authorized and trained persons only. Access to the laser operation area by the visitors is avoided. Warning signs to be posted at the entrance. The laser area must be posted with the appropriate signs. Remove unnecessary material in the OT like the steel, the rings which reflect the laser beam. The laser safety eyeglasses which should be appropriately used, allow the vision without disturbing the vision. The protective goggles are to be used and which are protect the eyes from the damages. The skin protection using the protective clothing and the shield. Do not inhale the laser fumes with high surgical masks are to be used. These are the signs boards to be applied in the theatre and outside that. Operation theatre guidelines, where the possible, the beam path must be enclosed. All windows and doors of the laser rooms are to be made opaque. The laser system must be disabled after the use. Any element must be done lowering the intent. If any unwanted fuming or the charring process observed, lowering of the intensity of the source is compulsory. Never judge the tip by open eyes. The screen curtain must be used at the entrance of the laser room. User never view the beam directly, the level on the horizontal plane only. The fire extinguishers must be installed. Keep inflammable material away from the beams. Secure the optical components to the table. Prevent the stray refractions. Interlocks and automatic shutdown process should be checked. The laser safety officer is responsible for that. These are the laser protective barriers. The goggles are to be covered not only from front but from the side also. The assistant should also use, the anesthetist should also use the protective goggles, and any assisting person should also use the protective goggles. The purpose of it is a best weapon with a well-trained persons, and it is a very delicate process by which you can only cut the internal sphincter with a judicial use of the laser, and it is very useful, gives the very good results, avoiding the complications. If you take the proper care, proper training, this is one of the best method which can cure the anal fissure very accurately and long time. Thank you very much.
Thank you.
Thank you, Dr. Godrej. It was a very elaborative, and fortunately you covered that laser part also, the technicalities, and few things about the operative procedure. We have to avoid the areas of the hemorrhoids while doing sphincterotomy, internal sphincterotomy, and 6 o'clock and 12 o'clock is also to be avoided. Particularly in females, 12 o'clock is totally contraindicated because it can very well cause the rectovaginal fistulas there. Why this 6 o'clock and 12 o'clock is to be avoided? There are two reasons. One, the sphincter is very weak at that position, so it doesn't heal properly, and it leads to the keyhole deformity. The second reason of why this 12 o'clock and 6 o'clock is to be avoided is this particular area is a watershed line area for the arterial supply. Both the areas, the right and left areas of the sphincter, they are well supplied by the arterial supply, as we have seen it from the anatomical coverage in the lectures. But that area is the watershed line area. The right and the left, both the arteries, they don't meet there, and that is the reason why it doesn't heal properly. So weak sphincter and the improper blood supply there leads to the various problems. Even it can lead to incontinence also. So that is all in the this thing. Yeah.
As far as the management of the fissure is concerned, whether the sphincterotomy is done by a open technique or a closed technique, it doesn't matter much what the crowd says, because if it is done by the laser or it is done by the cataract knife, I don't feel that there is a difference. But sometimes there are cases where there is a fissure, but on table when you see that the sphincter tone is absolutely normal, what is to be done then? This patient is having fissure, but sphincter tone is normal.
It needs the fissurectomy only, or the flap procedure.
Yeah, that becomes the contraindication for sphincterotomy.
Yes, sir.
Fissure.
Yes. Sir, one more question. Sir has told
why always 3 o'clock?
Less blood, sir. There is less anastomosis of the blood vessels. And it is
3 o'clock the hemorrhoidal vessels are already there.
2
so
o'clock.
Always chances of injury to the vessel is there.
No,
why not 9 o'clock?
This laser has got the 9 o'clock is very difficult to operate because
Sir,
we are right-handed.
Right-handed person, as we are going the sphincterotomy from medial to lateral, it is always easier on the right side at the 9 o'clock.
We have to move from medial to lateral.
Yes, sir.
With the right-handed person, the handling of the medial to lateral is much easier rather than the 9 o'clock position, which is difficult. But if you are well accustomed to that, you can perform it. What I am using, what the standard textbook has mentioned, the 3 and 4 o'clock position is safer that.
Any other reason, sir? Means
For?
for 3 o'clock only.
No, the purpose
No,
is to you have to relax the internal sphincter.
It is not 3 o'clock. We have to avoid the vascular area where the hemorrhoids are very common. 3, 7 and 11 o'clock position where the hemorrhoidal branches are there. We have to avoid that area. That will not cause hematoma or the site of the sphincterotomy. That area is to be chosen. That is the principle. What I feel. It is not 3 o'clock. It is 2 o'clock or in between. It is ideally 1 to 2
with
o'clock.
fissure with sentinel piles at 6 o'clock. Fissure with sentinel piles, sentinel skin tag. So we remove the skin tag at 6 o'clock and then sphincterotomy to be done at 3 o'clock only.
Only, not 6 o'clock.
Or should we divide at the level of skin tag?
You can go obliquely towards the 3 o'clock, but in between 6 o'clock and 3 o'clock you can do it. And there is always three components of fissure in chronic fissure: the sentinel tag, the fissure itself, and above that is the dentate papilla. All these three are to be removed in a chronic fissure. But if it is at 6 o'clock, leave that area like that. Don't do sphincterotomy there, because that can create incontinence or it can create a keyhole deformity. Go slightly towards the right or towards the left of the patient and do the sphincterotomy there.
What is the setting?
7.5 with intermittent mode. Yes, but continuous mode after the experience you can use it. Still you feel the giveaway sensation. One more question, sir has told the use of the cataract knife and the open or close method by the surgical method. See, laser has got the coagulation and cutting factor, and also the precise cut as required can be used. Any cutting with the knife should bleed a lot. By pressure it may not stop with the pressure, but after laser, if you apply the cold ice fingers and pressure for some times, it gives the excellent results. No hematoma, no bleeding, no any post-operative pain, and it gives the excellent result with a proper training and the experience.
For how much time you have to apply that
This
ice
is only
pack?
2 to 3 seconds only. 1, 2, 3 seconds.
The ice pack.
What?
Ice pack, that ice finger.
Ice finger is to be, the ice finger can be kept immediately after the procedure and let it dissolve after 10 to 15 minutes, because there is a latent heat which will generate in the surrounding tissue, may also causes the slow damage to the surrounding tissue, which can be prevented by the ice. And it is must. Ice is to be used, because the temperature 100 degree, even the latent energy, even after the procedure finish, if you just palpate it, it will feel the hot. So to prevent that latent heat spread or the damage or near the stay the heat there for the more time can be avoided with the simple application of the ice bags or ice fingers.
Yes, Dr. Kodwani.
One thing I would like to add, Vikas had asked if there is a sentinel pile at 6 o'clock and you are doing sphincterotomy at 3 o'clock, why not to go for 6? One thing I would like to add, sentinel pile has to be removed for the patient's compliance. If you don't remove it, पेशेंट को अगर थोड़ा भी दर्द होगा, यार डॉक्टर ने तो कुछ किया ही नहीं, जैसा का वैसा है. नंबर 1. नंबर 2, आफ्टर रिमूविंग द सेंटिनल पाइल, you go for the lateral internal sphincterotomy as per your protocol. It is either 3 o'clock or 4 o'clock, but not at 6 o'clock. As I said earlier, Dr. Prashant also said, it will cause a keyhole deformity. One more thing which I want to emphasize, in case of chronic fissures, we are talking about this chronic fissure. As I said, there is hypertrophied epithelial mucosa. What my way is just a gentle scooping of the fissure bed, so that this will remove the debrided epithelium and that will again fasten the healing and epithelialization of the fissure bed.
Dr. Kodwani sir, if the chronic fissure is there, if you debride by either scope or by any method, it will bleed more and it will cause the more fibrosis. But there is a laser debridement. The spray of the laser on that tissue will damages the unwanted fibrous tissue and enhance the healing. Even the sentinel spile, if there, it can be removed, or only at the tip, at the base of the sentinel pile. If you just put the laser beam there for 3 to 4 seconds, it will slowly absorb, and it is a painless thing. And to granulation tissue and the healing is much better than the surgical debridement. Laser debridement is much advanced. It evaporates the granulation tissue or infected tissue much better than the surgical debridement. Surgical debridement, surgical curating will cause the more fibrosis, and the fissure become more chronic and it will not heal. But this is our experience. But previously we also used to debride.
Thank you, Dr. Godrej.
Laser is much useful.
One last question. What are the complications of the laser procedure for fissure which you are not encountering in the conventional?
Yes. The complications with overuse of the timing, overuse of the energy sources, it travels in a directions. If it unknowingly, it can penetrate to the more surface, causes damage to the external sphincter also. It may cause the damage to the blood vessels, and it is all is to be avoided with the experience. Judicial use, minimum power, less power, more time, less power is much better. And with the experience, you can learn it. The moment you feel the giveaway sensation, you should stop the laser applications. It is very judicially used, and it is to be used after training only. Even you can check on the some live the meat part, how much it will causes the damage outside the on the animal level, or the you can try with, you can assess yourself how much damage can be done with how much the wavelength is used and how much time it is used. And it is very simple procedure if you use it in a correct manner.
Yeah. Thank you, Dr. Prakash sir.
Thank you.
Yeah. Yeah, please.
Sir, should I answer?
Yeah, please.
Sir, post-operatively we have to use the anal dilator as a precautionary measures, and some the sphincter relaxing ointment are to be used, and the patient should be trained such things. No, after that few days still the healing occurs.
Reuniting of the sphincter muscle, again there is a chance, because it is
No, but why there will be reuniting of the sphincters? Because it is a circular muscle, it will spring out, and there the two ends of the cut internal sphincter, they will be away.
They will be away, sir.
If you are not doing it sufficient and in a good way, there will be no recurrence.
Okay.
No uniting of the internal fibers.
The etiology, if you know, you can avoid those etiology. And the post-operative care and the long term, we have to teach the patient to, the moment the symptoms start, they should. Oh, sir. Okay, thank you.
Yeah. Thank you very much, Dr. Godrej sir. Yeah.
Thanks, Godrej sir. Now may I invite the father figure for all of us, the person who has invented transanal suture rectopexy, the person who is recipient of the Rajiv Gandhi Award, Dr. Shri Shanti Kumar Chivte sir. He is also the president of IICP.
पाणी आणून ठेवशील
येत होतं 2 मिनिटं
माझं ओपन कर
तुमचं आहे ना
चिवटे
हे आहे ना तुमचं पेशंटचं
रेक्टा प्रोजेक्ट ओपन या बरोबर
On a lighter note, thanks to the laser, the patients can have eyes candy from the other side also.
Yes, sir.
Yeah.
Okay.
Okay. Dear friends, now we have come, from lower end, let us go little higher about. And when higher end falls out, we have to make it, fix it at the same area. Basically, let me tell you, there is nothing like innovation in the human body. What we are doing, we are reconstructing what God has given same way. In prolapse rectum, from where prolapse has fallen down, we are going to stuck down there only. So there is nothing innovation in that. For this operation, background is suture rectopexy. Suture rectopexy, particularly posterior suture rectopexy, which is done by open laparoscopy or robotic method. In this particularly, they are dissecting lower part of the rectum up to levator ani and pulling this rectum higher up and fixing there. So always there are two parts. One is suturing of the rectum to the presacral fascia. Second is fixing or creating fibrosis due to raw area. These two factors have been already there in the posterior suture rectopexy. But in these cases, one thing that for this procedure, you require very high fitness for the patient. And particularly these cases have been advised, these procedures advised for the patients who are having good fitness, particularly young patients. Second thing, when you are dissecting rectum, if you go posteriorly, neurological problems can be there. That too, autonomous nervous system can have a little dysfunction. Something like they can create neoconstipation, they can have urinary or sexual dysfunction. And these procedures cannot be done in weak, frail or very old cases. Now, diagnostic problem of prolapse rectum, you will laugh at me. Why you should have diagnostic factors? Usually patient tells you, sir, something is coming out. Why you should doubt him? No, I think all surgeons, before doing anything, they should understand how much it is coming out. So, many times it happens that when you are examining, patient is not able to bring it out. Mind well, same thing happens when you are going to do MRI defibrillator. Many times patient doesn't strain that much. So this can be have as usual classification or internal, external prolapse and other thing, but these all are prolapse. If they are internal, again they are divided. But what I would like to suggest you, on clinical examination, if you put your finger inside as you are doing per rectal examination, always you try to put your finger to the highest level and ask patient to strain. While straining, something touches to your tip of the finger, usually it is intersescipient apex. Second thing, by chance there is nothing comes and touches to your finger, put your finger posteriorly on the sacral aspect and try to press it on that and try to pull it down. If something comes on your finger like a frill of your curtain or frills, or you hook this tissue coming down, that means there is some intersession is there, and it will depend on the level. If it is higher, less amount of tissue will come, and usually in old age 1 to 2 centimeter may come without having any pathology. But always frill test associated with the constipation score, associated with the finger evacuation, associated with the patient's complaint, something coming down. Now this is what pictorially I shown, whether it is in lateral position or lithotomy position, your finger should press on the sacrum and pull it. This is what you will see picture on your proctoscope. A plain rectal mucosa will be always seen where there is no intersession or prolapse. But convoluted or wrinkled mucosa will be seen where there is intersusception or prolapse. You can see internal prolapse, you can bring it out with sponge holder or using sponge test or something coming like intercession on the lateral border, you are seeing it. See, we have studied a little bit about Prill or hook test with the MRI defecation. I submitted about 50 cases for the MRI, and about 10 to 15% cases it was negative when we found sponge test positive or we could pull rectum during the anesthesia. So these are the drawbacks of the MRI. So you should not grant whatever MRI says. You should grant what your patient says. More particularly, I will give value for constipating patient for the digital evacuation. This procedure, whatever we call as a new or old, whatever is there, but there is nothing else but anatomical restoration has been done with something different way than what you were doing earlier. Instrument requires a special self-illuminating proctoscope is there, a long needle holder more than 25 centimeter. You will require additional needle holder of laparoscopy just to use as a holder of the needle, not for pusher. Then not pusher is required, and you require PDS number 1 on 40 mm round body needle, or even taper cutting also you can be used. Proctoscope, I already told it is 20 centimeter long, 4 centimeter in diameter, 1/8 circumference has been cut to a window through which you will operate, a slide to cover that, and self-illumination I told you, either you can put a fiber optic light in that. Window is used for the operation, and slim long needle that is used. This is the proctoscope where blue bar you can remove and use that thing. This is the view inside, and light source whatever is can be given, you are seeing it there. So very clean vision you can see. Only thing, you cannot record with this. While recording, usually I put endoscope of 4 mm 30 degree or laparoscopic 5 mm 30 degree, so you can record it. For recording purpose, this proctoscope cannot be used. Procedure as usual, bowel is prepared. I don't know, I prepare for piles also. Spinal or saddle anesthesia. Saddle with minimum 5 to 6 minutes sitting position after giving anesthesia. That will reduce risk. We have used in a patient who has got a left ventricular factor up to 30. We have used in a patient of 95 years where people have just done Thayer's and left it because nothing can be done. So such patients we have operated, and we are operating without much problem with the saddle anesthesia. Once patient is kept in lithotomy, we give steep head-low position. It serves two positions. It reduces blood supply, and when you are reducing the prolapse part of the rectum, it helps there. If you have little protrusion down, it may come out. So it is better. That is one factor. Once that prolapse is outside, whatever external prolapse is there, you can wash it with this saline. Maximum you can use Metrozole also. And after washing, we will see video also. After washing it from inside, outside, and then you can push it inside, and this will be retained with your proctoscope inside. Once proctoscope pushed it inside, then our main aim is there, going through the rectal mucosa to the rectal wall and fixing the presacral fascia. In this, let me tell you, we are not going to fix a fascia about 3 centimeter, 4 centimeter. We have to take a just bite what you take in posterior rectopexy and fix up the rectum. But still some part of rectum will come, some part of the fascia will come. I will see this thing particularly during our seeing video. And this we start usually, this proctoscope doesn't go higher up of the rectosigmoid junction because of sacral curve. sacral curve obstructs it and it doesn't go usually beyond S3 level. And that is our point. Rectosigmoid junction is there at S3 point, so we need not to go higher up also. So we start from there, or you can say at the maximum point of the prolapse, or wherever your proctoscope goes, from that maximum point you should start. And then we put 4-5 sutures. This is, I am giving just description, so you can concentrate on video when seeing. See, where lower portion in posterior suture rectopexy, they used to dissect out and create a raw area. In these cases, we are not creating any raw area. So you will feel everything is frank to come down. No. What we are doing, we are inserting a 20 centimeter long Chibas needle in retrorectal region. In the, you know, always posterior rectal fat is there. In that fat this needle goes and we inject foam sclerosant in this region, so it will give instant fibrosis to you. So you need not to wait for 6 months or 6 weeks or anything. It gives instant fibrosis. I'll tell you what happens. And details, you know, at least I use 4 milligram is 120 milligram of the sclerosants with 6 ml of air, or you can increase if you want larger size, if larger height of the patient is there, then you can use more air in that, so it will spread more. This is, you know, this is one part of prolapse you can see. Okay, observe it very carefully. This is the prolapse. Okay, you have seen that portion? How that has come? See, we see always prolapse is a prolapse coming down something. No. You are a surgeon, you should have very keen eyes and you must see what is coming. That prolapse is coming right from the side by side, it is as if it is protruding walls of the rectum. Did you see, or you want to see again? So this is second one. You are seeing inside something that is coming and side of the wall, you can put your finger in that. So this is the really interception becoming a prolapse of the rectum. Okay, you understood these two differences, or you want to explain? Because there is nothing to explain in that. Now, as I told you, we are giving good wash to, without touching it, we just spray water in that because touching will cause bleeding. So we don't want to touch, except as of we are pushing the lumen, so we will wash further also. We reduce this prolapse to the complete, and then this proctoscope is little different. It is was initial part. So this we push it inside. Now you will know. This proctoscope will keep your rectal prolapse at the site only. And once you are seeing posterior pouch there now, which is usually happens. In this now, this needle, are you seeing this needle? We have pushed it. Mind well, I am telling you very precisely, this needle is 40 mm needle, round body, and you are holding this needle, because while showing sometimes I will explain this also to you. You are going to use longer needle holder, but you are not holding this needle at the tip, even though you are going at the depth. If you do keep this needle at the tip, it will wobble. And once this you are pricked and it wobbles, it will create bleeding inside. So this structure should be firm and fixed, as if somebody is holding stretched. So how you will keep this rectum stretched? You put your proctoscope to the maximum, push it little high, and then press it down. So rectum will be above to the sacrum. And once you do that, rectum is fixed now. You take a needle holder in your hand, keep the needle in the center of the needle and use at least 1 centimeter of the needle for holding it. And once this grip is very tight, now you have fixed rectum and fixed needle holder in your hand with the needle and how you should use it. Usually, my friends, we have forgotten how to use curved needle. Right in the beginning of my house post, my teacher told me, when I was using curved needle in semi-prone position and I pulled it, he said, Gadwa kutrela urtus kai tu. My teacher is very great, and I still remember, when you are using curved needle, use in prone position and twist it. That is all you required. But if you put in semi-prone position, you are bound to push it. And once you push it, needle will go beyond the edge of that proctoscope and you will keep on searching. Many times I also searched. Let me tell you, dear friends, you will not be new thing. So this should not happen. So you should keep your hand in prone position, hold needle holder like that, and once you touch to the rectal mucosa, just turn it. Once you are holding 1 centimeter in the needle, only 30 mm needle will be there. So it will not go anywhere else, but it will come out. So let us see now what happens. Okay, you are seeing this needle is coming out from the other end, and this is laparoscopic needle holder which holds that needle, because laparoscopic needle holder is not strong to push it inside. Now we will release needle holder from this side which was strong, and just we are turning. You are seeing, no pulling, just turning. And once you turn, there will be a traumatic area, and after that, I am sorry how to put notch or another thing I have not put, but this knot pusher we have used it. Earlier I used to use knot outside and then push it slowly inside, and used to take nearly 10 minutes for one knot. So this has become very easy. I should thank my laparoscopic friends, they have taught us. So this now proctoscope, slowly it has slided up. Did you see this? So we have gone above again. See, whatever margin we get, we want to do that. We want to fix it also. And you don't feel that rectum is coming out of the thing. Once you have put down, pre-sacral fascia has come in that. Even though this side rectum comes up, you don't worry about that. And once you tie these things, now 3, 4, 5, 6 sutures you can put right from the apex of your proctoscope or apex of your prolapse, and then this will be nearly completed work. See how this need, and I am not going to show you all because it is similar work, you know. So these 4, 5, 6 sutures what we have put, we have told you it's right from the S3, it comes to coccygeal level. Okay, now we are creating sclerofoam. This is created, other picture is created, but during operation we don't create like that, we create with the gloves and other things. And this is the needle, this is Chiba's needle, 20 centimeter long, 20 gauge. I put it blindly, and I'll show you how it is accurate. I kept nearly 1 inch from the coccygeal tip and go upwards, but I'll not pierce to the rectum. Now you are seeing this Chiba's needle on sonography already you have seen, and now we are injecting it, and you have seen under sonography, no, Chiba's. So this is injection we are giving, and we will show how this injection affects there under sonography. Nearly 10 cc of sclerosants. See, there is no bulge in that, because that God space, holy place is very big one. You are seeing how that black is flat, retrorectal fat. So once we are injecting, it is increasing in size, and you are seeing shining, that is the needle. Usually air should shine, but it goes in the fat, so it is not shining here. Do you agree with me? You are seeing retrorectal because our portion is rectum, lower portion is presacral fascia, and we are injecting exactly in that recto. And there is, mind well, this fat is also covered in small fascia, thin fascia, so it will not spread all the way. It will spray whatever envelope that the fat is there, that much only. So it will not cause any nerve damage or anything. So now we are seeing how injections are being given, and fat area is increasing, and this will create instant fibrosis. See, this is what post-op picture, and now you are seeing that And this is what you created. You are creating, fixing the rectum to the presacral fascia. You have given small bubbles are there. You are given these things, and you will create a suture sacrorectopexy with that.
Sir, can this needle be pushed transrectally? Myself here.
Yeah. Yeah.
Can the needle be passed transrectally?
Yes, yes, you can do that also. Whatever is possible, you can do that. Now, I agree with you, and I used to pass it. I'll tell you, I was not very accurate earlier, and rectal mucosa in prolapse is a very lax one. I used to pull up with the Babcock and put the needle underneath to be accurate retrorectally. So now we have, I should thank my interventional radiologist and my son. They taught me how exactly you can go, and you can see yourself how you are in retrorectally. So this has been during practice, and you will see two things you should keep in mind. One, when you have pushed needle, before injecting you aspirate it. If no blood comes, you are not in presacral fascia. And while injecting, if there is no local bulge, you are not in the wall of the rectum. Retrorectal position, that is a gap. Holy place is there, space. It spreads, it doesn't bulge. So you should have these two criteria if you don't have transrectal probe of ultrasound. Now post-operative, my friends, there is no pain to the patient. Usually even I don't advise paracetamol to them, except if anal dilatation I have done, we give some paracetamol. We keep 48 hours after operation, not on the, means at least 3 to 4 days, patient will be in the hospital. We give head low position to him and clear liquids at least for 3 days. He should not. And if old person is there, we put a Polish catheter for him. So 4 days he should have head low position, fix up whatever you have done, and in 3 days give him full diet. Once he passes stool, you try to examine that day also, and you will find whatever chamatkar you have done, that posterior fascia has been, rectal wall has been stuck to the sacrum. On examination also, you cannot get frill on that. So this can happen, and mild purgatives after post-operative we can give it. We have done, now this number is old slide, so same number I kept it, but mind well, in India 26 male patients are there out of 36. If any British research or Western person is giving this lecture or on prolapse rectum, he will say 80% or 85% elderly females having prolapse rectum. My dear friends, this will not do. Whatever they do, we cannot do it. I'll tell you. Out of this, average male patient is average age is 42. Still they are sexually active. Mind well, if you are going posteriorly, I appreciate laparoscopic people, they are going to find nerves and preserving it. But still, we cannot assure that your function will not be. Person has some urinary problem, okay, tolerates. Increased constipation, he tolerates, but not sexual function. So in India, same question I was asked to a very eminent, author on prolapse rectum when he came to Bombay for giving a 1-hour lecture on prolapse rectum. That time I was working on other type of procedure. I asked him, in India, at least 50% prolapse rectum, they are less than 50 years. What you will offer? His answer was that he was MRB Kingley. His answer was that I don't know. Because they don't face that problem. In elderly female, nothing happens. Even you damage the nervi irrigantis, nothing happens to them. So this you should keep in mind, at least when you are doing in India and when you are doing to the young patients. We should not keep on operating very major and fit operation for young patient because he is fit. You should always consider this point also. Follow-up, 1 to 6 years follow-up we have given. Incontinence was there from the gradation 3 to 2 to 3 in 15 cases, and improved, that was changed to 68%, 0 to 1 grade in 6 months. This was after 6 months, I am not saying immediately. Constipation was there in 23 cases, and that was, score was 11.1, changed to 5.1. Peeling of incomplete evacuation has gone. Use of enema and painful defecation has gone. No fresh incontinence and constipation with this procedure. Now one more point, my friends, always it was criticized, and lot of negative expression to this procedure has been given to by people, and very learned people, very, we can say remarkable work who has done in the coloproctology. See, this is a blind procedure. What happens to presacral bleeding? You are not mentioning any times. I have done all these cases with the transrectal probe. I have not found any time any hematoma inside. I don't say that this will not cause presacral bleeding. Even your needle pierces some vein. My friend, you tell me, when intact fascia is there presacral, what else you are going to keep it? Press it for a while, it will stop. That's why if presacral bleeding is there during dissection of the rectum, they say don't coagulate it, because it will spread it will coagulate presacral fascia and bleeding will increase. Same principle. And second thing, when you are tying rectum on that bleeding stops. That is the treatment what you are giving for presacral fascia bleeding. So these both things, they should not be. Still I have given one, 37 abstracts, 13 papers of rectopexy for prolapse rectum, about 1164 procedures, presacral plexus bleeding in that 0.3 to 3%. But that is when you are doing dissections. But I have not found, or anybody has written so far, because they are also putting needle through presacral fascia and they are fixing the rectum, even open. They have not reported any time bleeding. So why with needle bleeding should occur? That is my question, but I could not satisfy all the stalwarts, and they said this method cannot be used. But my friends, this has been accepted now internationally. Annals of Coloproctology accepted this paper, and now this is a colorectal journal. They have their own video library. They are going to accept soon. So in conclusion, it is non-invasive method. You can always say patients, I am a great surgeon. Without pain I can cure your prolapse. I will not cut your abdomen. I will not cut down. I will not cut your prolapse also. So you become great person with that. No incision is there anywhere. No pain. It is safe for all types of people, whether they are having poor risk or fragile or elderly people. It corrects external prolapse, corrects internal prolapse. So this can be used for obstructive defecation syndrome also. So if you keep on going and doing, some partial piecemeal rectal resection is not going to help you. That creates nearly 40% decreases. Thank you very much for listening me. And last few years, if you have not discarded any major your opinion or acquire view, check your pulse.
Sir,
thank you very much.
Sir, this is a novel procedure for us all. Sir, you call it as a blind procedure only in the view of touching the presacral fascia and causing the torrential hemorrhage. But another question, another complication which we understand all the time, that whenever the patient is taken for this procedure, because the patient is in lithotomy position, and there are some of the few, I call it as contraindications also, those patients, those who are having previous history of surgeries, pelvic surgeries, those ladies, those who are having history of endometriosis should be avoided, because we don't know at the position where you are putting the sutures, this small intestine is likely to go there and likely to have the adherence, and so that the major complication of the enteric perforation can also occur. So in this case, what is your say, sir?
I agree with you, but usually what happens, once you put proctoscope, keep it properly, held it properly, pushed it properly, pressed it properly, your needle will not go out of your proctoscope, and you have pushed your intestines out of the rectum. Not only out of the rectum, rectum remains still further away from that. Only thing, when needle is not coming out from this, don't try to manipulate, proctoscope. We try to rotate, we try to get more of this thing, that will cause more problems than this. That is one. Second thing, there can be abnormal things, very short persons. Your proctoscope may go to rectosigmoid junction or beyond that sometimes. Very flat sacrums are there. There you should be very careful. I agree with you.
Yes, you can ask.
My hats off to Dr. Chivte, sir. I am doing this transanal rectopexy regularly. I remember in my first case, I was stuck up in my OT. From OT, I called down to Dr. Chivte, sir. I made a video call, and because that bulge of the rectum was obstructing the view to go beyond to put the first suture. Sir instructed me to go for a 30 degree 4 mm telescope. I used that. That has increased my visibility, and I could do that successfully. My first case, as Chivte sir was there virtually in my OT. Now I am doing this regularly. My hats off to you, sir. Sir, my one question.
Yeah.
Earlier you told us to put a loose vicryl stitch on the apex of that prolapse or intersuscepted part, which needs to be removed.
It is PDS. It is not a.
Which vicryl? It needs to be removed when you fix it, because it will identify the apex.
No, I agree with you. You need not to remove it. You just identify and keep it there. It will fall out.
So
any vicryl doesn't remain more than 3 to 6 months. So that will fall out. Even PDS will fall out.
Yes.
Yeah.
Thank you, sir. Thank you so much.
So, great innovative procedure, sir. Myself, Dr. Hemant Patil from Thane only.
Please.
The thing is that...
Hemant, everybody knows you. Don't introduce.
No, sir. The thing is that it is nice to have a male patient with only prolapse and a young patient. How's your take on with a female who has got laxity more with a tricompartmental or two compartmental prolapse? How to gain access with that? Because young male patients may be an extended prolapse of congenital which is presenting at the age of 40-45, slowly increasing, but a pathology in an elderly male or females with a tricompartmental or two compartmental prolapse is totally different. So how to address that?
I agree with you. I don't advise this procedure for tri-compartment, because that is totally laxity. And whatever we are doing, we are nothing enhancing our muscles tone. Yes. We are just putting mesh there, yes, and obstructing coming down. One day they are going to come down. So I don't have any answer for that. I am always think, those muscles should be strengthened. They should be repaired. But mesh doesn't repair that,
Yes, yes.
So mesh just supports it.
Yeah.
And tri-compartment, you see, if patient has got rectocele in female, and this thing, rectocele is if less than 3 centimeter, you can use this procedure. Why I'll tell you. Even fixing posterior, it helps to rectocele. Why I'll tell you. Because God has fixed rectum posteriorly only. So all female doesn't have rectocele because anteriorly nothing is fixed. So that will help you. If your fixity of the posterior reduction comes down, that rectocele will also come down. In male patient, many times if you are seeing this type of proctoscope you have used, posterior rectocele is there. We don't do anything for that, because posterior rectocele will not go down beyond the bone. Here, anterior rectocele, if it is more than 3 centimeter, you have to repair it.
Sir, my point was just to clear for the audience and everybody here, the most of the times 90% the rectocele is anterectocele. When the rectocele is associated with tricompartmental prolapse, better to have a VMR as a substitute. If at all you have got only prolapse and intersuspension, your procedure is the best. I still agree that.
I agree with you.
Thank you, sir.
Because dry compartment, we cannot use this procedure. If at all you don't want to use anything for the prolapse rectum, you use this, and rest of things you can repair directly.
Especially for females, those who have got anti-rectosis, they have keep on using fingers, they may not be satisfied only with correction of prolapse.
Yeah, I agree. Agreed.
So one more question. I am Dr. Vishal Pawar from Nasik.
Yeah.
Sir, how you should confirm in your suture pre-sacral fascia has come?
Yeah, I agree with you. Otherwise, I will be cheating all the time to you, isn't it? No. See, I forgot at this point. Good thing you have told me. Once you have taken suture, two ends will remain in your hand. Okay? You try to pull it down. If you pull it down, if rectum comes down, you are not through the fascia. Very simple, no? So you test it before you tie knot. Even, see, out of 6 sutures, even 4 or 3 sutures are through that. I think in one patient I put only 1 suture and injected down. Still it was okay. Where is Dr. My friend? With him we did it. He said, sir, only 1 suture. Yes, sir, today I cannot put another suture because patient was little more, having fibrosis and other things. Sonar, he is there. His patient only, he was another witness for that. And he said, ek hi dala, mala ek hi dal denge, chalo. So that also holds you. Okay? And there are papers with only 1 stitch to the presacral and still prolapse has held it. Yeah.
For the same point, sir, anywhere you are taking a transfacial suture, the dictum is that you can pull out the suture. If the suture comes out easily, that means you have breakdown and you have not the suture. I got my teacher, Dr. Arun Mane sir, I have done my DNB. And
he is my teacher also,
yeah,
don't worry.
The thing is that what
Arun?
he has teacher also, in inguinal hernia also, whenever you take a first stitch in open inguinal hernia, you try to pull out. If it's coming out, that is not in a proper pivotal fascia. The same thing is applied for any transfacial suture.
See, I have heard him sometimes and I tell them something.
Sir, myself, Dr. Bhavin Bua from Surat. Sir, my question is...
Bhavin?
Yes, sir.
You are famous, don't worry.
No, sir, no. Sir, my question is, every time while you are injecting the foam, USG guidance is necessary, or now you do by the experience blindly?
Yeah,
And
you can... See, 2 things are there. You practice it with lifting mucosa, with the Babcock. Once you lift mucosa, your needle is behind it only. And you aspirate, that means you are not in presacral fascia. That is okay. And now, why I am putting it, let me tell you very frankly, I never used to show how I inject, and I was injecting earlier. My earlier videos on this, they are without injection only. But when people thought that injection is not necessary, then I said, no, I will show you. So my friend nowadays, interventional, he will see me, you will see him tomorrow. He said, okay, we'll show needles, we'll show injections, and everything will be there. So we have started showing now, after practicing long time. And this, see, let me tell you very frankly, under seeing your ultrasonography, pushing needle is very difficult for me. Because I cannot identify where is rectal wall, where is presacral fascia, where is fat. Now I can tell you where is fat. But earlier on sonography I was not able to. And even sonologists also, transrectal sonography requires separate practice. And while pushing needle, now I can say very, confidently that this is in the, because I am seeing needle also palpating there under the rectum. So use all your clinical sense.
Another question is, which suture you will start, from the S3 to sacrococcys, or from the...
No, from above you should start. I'll tell you why. Because if you lower down, if you suture, that thread may come in your needle holders or somewhere. So you keep on pulling that, so it will bleed unnecessary.
Thank you very much.
Sir, what are the chances of infection?
Well, infection is usually not there in my cases, but can be there, and you have to cover with antibiotics.
Sir, what are the chances of cut through of the rectal mucosa, because you are tying the stitch?
Yeah. See, in future it is going to cut through only. It's not going to be permanently stitched there. It will create a fibrosis and fix there. Otherwise, cut through will occur with all sutures, whether they are taken for a piles or prolapse.
Sir, can I just, pertaining to this, just a practical tip, I may be a very small person to tell you, but the thing is whenever you are giving any blocks anywhere, what is we are having? We are having always a landmark of bone. Where when you go give a nerve block, you hit the bone, come out of 2-3 millimeters prior, and then give a block. The same way, you hit the sacrum and come out of 2 millimeters, withdraw your needle, give the block. Second thing, practical tip, if you put a needle and you can mobilize the, move on the mucosa and submucosa very freely, that means you are quite deeper. So these are the 2 points, practical tips.
No, if you are going too deep, you are going to insert yourself into the periosteum. Your needle,
I said ki withdraw. Just palpate and
you
withdraw. Then give it.
Once you go and touch the hard surface, turn it up. You got it? Turn it up as soon as hard surface. I'm sorry, lot of time is taken. I feel I should. We will discuss during. You don't allow me to take lunch. I'll discuss with you.
Thank you very much, sir. Thank you.
Thanks, Dr. Rahate, Dr. Laduga sir. Now may I request Dr. Saleshwar sir and Dr. Umesh Mane to chair the moderate session. Dr. Saleshwar sir. Laptop. Chair the session. And Dr. Mane, Dr. Umesh Mane. Next lecture is by Dr. Dilip Rajpal. Dr. Dinesh Shah sir could not make it. So Dr. Dilip is speaking on complications of MIPH. He is my colleague at Godrej Memorial Hospital. And he has got a very wide experience of stapler. He has been operating since more than 20 years.
Laptop de do पर हाँ तो तिकडे यांचं लेक्चर सर कुठचा लेक्चर तुमचा
हे कुठे आहे पेनड्राईव्ह
हाँ जिथे सर डाउन
हे वर्ष
तारीख ओपन करू
हां काय होतं ओपन आहे pointer.
Hi, good morning friends. I am thrilled to be a part of this society. I am really excited to learn so much new in just 2-3 simple lectures. So I'll be talking on how to avoid complications in MIPH. So I am Dr. Dilip Rajpal. Yeah, so I practice. Yeah. Yeah, okay. Yeah. So first of all, in normal anal canal, we have several areas called vascular cushions, and when the blood vessels in these cushions swell and enlarge under pressure, causing symptoms, they are called hemorrhoids. So the affected tissues at times extend outside the body, and this is called prolapse, and is a sign of advanced hemorrhoidal disease. So PPH reduces the prolapse of hemorrhoidal tissue by excising a band of the rectal mucosa. A portion of the rectal mucosa is pulled into the device that allows the excess tissue to be removed, while the internal hemorrhoidal tissue is returned to a more normal anatomical position. So here you can make out the prolapsed tissue and before and after PPH surgery, how anatomical cushions are well maintained. So we'll start the procedure. So we'll be discussing all the important steps as we go. So this surgery is usually done in lithotrowing position or jackknife position. We usually prefer lithotrowing position. So the first step is the anal verge is gently massaged and dilated, and the dilator part of the PPH gun is PPH 03 is inserted inside. So this helps in gradual dilatation and also prevents the injury to the internal sphincter muscles. It is advisable to put the dilator first and then without the obturator as a first step, and then second step you put along with the obturator. So once you insert the obturator, you stretch the skin around the perianal area so that the obturator reaches the deepest level. So by doing this step, actually we are pushing the pile mass also deep inside, so it helps in proper positioning of the obturator. The shaft of the obturator is 3 centimeter. So this helps in separating the, and this dentate line should be overlay over this particular 3 centimeter to safeguard the dentate line. So here you can see after inserting the obturator how the pile mass is actually popping out here deep into the obturator. We use 2-0-proline for suturing, bursting suture. So here whatever the common mistakes or what should be done for bursting, that is the only most important step in this particular surgery. So we will highlight that. So here we can see many people take 2 or 3 simple 2 or 3 stitches. So and complete this complete circle. So when you are doing so, here you can make out there is no stitch in this particular part. So when you are doing bursting, knotting, so this part of the rectum may be left alone. So you may remove the partial donut. So that has to be avoided. Second is many people try to take deep stitches. So when the most important thing is you should see to it that the needle is tangential and not perpendicular. So when you are keeping it perpendicular, you may enter the deep tissues which may cause bleeding also, and there is a possibility of this may cause severe pain post-operatively. In females, there is a possibility that you may, if your anterior stitches, you may take the part of the vagina also, and maybe a part of this may lead to a serious complication of rectovaginal fistula and other things. So this should be preferably avoided. Many people do take small bites of the tissue. You can see you are taking small bites of the tissue and then come out and then small bites. So when you are doing this, again there is a possibility that all the small bite may just cut through when you are actually tying the knot. So all these things should be preferably avoided. So this is what can happen when small bites are taken. This part of the tissue may be just cut through, and you may remove a partial donut. Apart from the most important thing is this will cause excessive bleeding. Many times we take sutures along the haphazardly along the following the pile mass. So here the most important step is you have to do this stage above the pile mass, and also we see to it that it is at linear level. So when we have that there are markings on the anoscope of the gun. So where we can actually assess and be at the same level rather than this thing. So when you are doing different level, then this may cause bleeding also, because you are inside the pile mass, and there is a possibility that you can the pursing will not be proper. So what you are actually supposed to do is proper pursing, as shown here, meaning you can puncture at this level, come out, then equidistant here you are taking. So ideally speaking, you should be able to take 6 or 7 stitches at proper intervals. So when you are closing this, it will cause proper pursing effect of the suture. So this is the most important part of this particular surgery, where you can avoid the complications. So here we want to show this is a pile mass, but you are not supposed to take suture over the pile mass. You can go above this pile mass, because if you are taking suture from the pile mass, there is a high possibility of bleeding. And also your suture line may not be linear, it may keep on dangling up and down. So when you are advancing the endoscope, when you are taking with each and every bite, you are supposed to remove the endoscope and then reinsert, because when you are trying to just rotate the endoscope, if there is a large pile mass, then you may actually cause strangulation of the pile mass, or you can injure the pile mass, which can lead to bleeding. So this is, once you have completed this linear, the suture line should look something like this. It should be linear. So you are confirming with the finger whether you are taken at all the levels. Sometimes there is a possibility that you may skip a area in the mucosa, and that will cause partial bursting, and part of the rectal mucosa may be left behind. So now once this is confirmed, so you are inserting the anvil of the stapler gun. So after inserting the anvil, this bursting stitch is tied here. So this bursting, you already confirmed that you are taking stitches from all the sides, and then bursting is being tied here. And after this thing with the suture puller, you try to pull out the threads. Yeah, here I skipped that you need to take one more stitch on, after completing bursting, you need to take one more stitch at 9 o'clock position. Because whenever you are doing this suture with suture puller, you need to give traction from both the sides. Because if at all you are giving traction only on one side, then only a part of the mucosa will be come out. So a gradual pulling will be required from either side. So after pulling the thread out with the suture puller, it will look something like this. And now what you are doing is gradually you are pulling both the threads at 3 o'clock and 9 o'clock position. You are pulling the thread, at the same time you are closing the knob and pushing this thing. So what happens is the more and more pile mass will come inside the stapler gun, and also the anvil head will get approximated. So this, you should be able to see this 4 centimeter mark, because when you are seeing this, that means you have already safeguarded the dentate line. We are way above the dentate line, and the chances of complication will be lesser. When anvil head reaches at least 3 millimeters, then only the stapler will be fired. Because till that time the stapler will, it is automatic, meaning there is a mechanism where stapler will not fire till the time it is approximately by 3 millimeters. And once this thing reaches 3 millimeters, means this is, you are about to fire, then when closing the knob, you should see to it that this, you are in the green zone, and this B should remain smaller. In the previous days, we remember, meaning we used to in fact exchange hands and put excessive pressure. In fact, that may be leading to severe flattening of this B, and that may cause severe bleeding also. So once you are in the green zone, then only this knob will open. Otherwise, this safety guard will refuse to open. So once we compress at this level. Once this thing is fired, so before that we need to compress the prolapse tissue for at least, keep it as such for at least 60 seconds, and then fire, and then we again wait for 60 seconds. Here again there is a lot of school of thoughts. Lot of people debate whether to keep it compressed or not, but preferably we still keep it compressed 60 seconds before and 60 seconds afterwards. So once it is fired, now we again open this particular knob of the stapler, and then rotate the stapler by 1/2 to 3/4, and then remove the stapler gun. So this is a suture line, what you can see. This is the staple line. This is a donut. You should confirm whether it is a complete donut or it is a partial. This is the result what you can see. So the bleeding wise, meaning complication wise, the commonest complication can be bleeding. The main important reason for this bleeding is if at all you are taking deeper bites, then that is one of the most common reason. And sometimes patient may have secondary hemorrhage, and if that happens, then you can put the dilator of that same gun inside the dilator, inside that hole we can put it a Foley's bulb and inflate the bulb, and most of the time the bleeding will stop automatically. If at all it doesn't stop, then you may have to shift to patient to OT. Pain, the main reason is usually deeper cuts. If at all you are taking deep bites, then that may cause severe pain. pain lasting for longer than 6 months, that sometimes, very rarely, may be because of the staple itself. Sometimes the staple may remain open and that may cause pain. Urinary retention is usually because of pain. In fact, many times if at all patient is complaining of pain, that signifies that patient is, you need to give him seeds bath or increase the doses of painkiller. Because of pelvic diaphragm, patient may be going to spasm of the pelvic diaphragm, patient may be going into urinary retention. Tenesmus is usually because of the edema. Sometimes Kegels exercises or pelvic strengthening exercise may help in that, but that usually subsides in 10 to 15 days time. Recurrence usually is not because of the stapler, it is usually because of the dietary factor or what the main trigger factor was is not taken care of. So that usually causes the recurrence. And other symptoms, other complication may be there in the form of anal stenosis. That's it. Thank you.
Dr. Mane, any questions? Dr. Saleshwar? Yeah, question from Dr. Saleshwar.
The stapler will be, the ring will be remaining lifelong.
Yes.
So the more fibrosis will occur. Is there any chances of causing stenosis at there, right?
That most of the staples will fall off actually on its own. 50%, more than 50% of the staples fall off, and rest are covered with the mucosa. So it doesn't usually cause stenosis. However, stenosis have been reported. We have also seen few stenosis in the initial days of practice. But maybe different reasons are there, like bleeding or infection, or to tackle the bleeding in the initial days, we have given foam sclerotherapy also. That are also one of the reasons for stenosis.
The stenosis will occur if your bites are going deeper into the muscle.
Yes. Yes.
That is the most important step, and that is to be avoided.
Sir, if is the rectum become like hourglass, so there is more stagnation of the stool above the suture line, and the stool will be remain there for longer time, and it causes the more dilation proximal to the suture line.
Sir, we have not seen I think hourglass effect, meaning we have follow-up of more than 5 years, personal experiences. So patient's recurrence is almost nil, meaning we have seen few 1 or 2 cases, but I'll say the person is not more than 1 or 2%.
I think that type of complication, hourglass, will again occur because of the stenosis. A pre-stenotic dilatation will be there.
Yeah. So
it will not occur if the staplers there or the sutures are going exactly through the...
So if at all you are doing some secondary procedure for staple, like meaning I said very specifically, if at all someone has a bleeding post-operatively and then mild bleeding, and in the initial days, meaning we have done that, meaning we have given some sclerosis and that has led to this complication. So that can be one of the reasons.
I must congratulate you.
Thank you, sir.
Dilip, I have not seen anybody showing step by step how to avoid complications. So many days I am listening on lectures on stapler, which is very hot topic. You have done very well. Congrats.
Thank you, sir.
Some patient has a complaint of the undiagnosed chronic pain even after the 3 or 4 months. So the reason could not find sometimes even after so much examined by the multiple surgeons. So any reason or how to manage it? Can you please tell? Thank you.
See, in that case, we need to find out any other reason, meaning any other etiology, maybe other than this particular operation. That is one. Very rarely, as I told you, if pain is lasting for a very long time, then there is a high possibility that some staple may be remaining open. So on digital examination, actually you may be able to feel the staples. Although most of the staple will fall off or it will be covered by mucosa. But there is a high possibility that one of the staples is open and that may cause pain. But if patient is having chronic pain, then we need to rule out any other etiology other than the surgery or piles per se. Yeah, so obviously dentate line has to be safeguarded, and that is cause of pain also and lot of other complications, stenosis, everything.
Thank you.
One thing is to be highlighted, and particularly in female patients, we have to safeguard the vaginal mucosa.
Yeah.
And whenever you are firing the stapler, the direction of the stapler firing should be towards the
Yes.
sacrum and not towards the anterior, toward the umbilical side.
Yes, sir. Yeah. Yes.
Dr. Dinesh, you had given very well step-by-step description about the MIPH and all that. Very nice to have these steps. Only thing is that in our, like, we are working in a general hospital, a lot of patients we get hemorrhoids, and we do the traditional open milling and Morgan method routinely. We get many patients there. I think one of the cost effect is there about the stapler. So we cannot ask our patient cannot afford that this thing. All the patients in our general hospital. Is there any way there to we can have this in a minimum amount or this thing for the patient, so we can have use in general hospital also?
Since almost 8 years, meaning we have practically stopped doing Milligan Morgan. We do either stapler or chip tape procedure.
Okay.
We have done more than 300 or 400 such procedures.
But still, we getting the results, and patients are happy or they are getting benefited also. We don't get patients with any complication more or any recurrence and all that. But still, it's working.
Yeah.
Still, it is in a proper place.
See, I have practically seen all the complications of staplers, and I have seen many complications of suture rectopexy also. Okay. So, if you are operating, then you will see complications. But compared to the percentage wise, if you see, meaning how many cases numbers we do and the complication, it is minuscule.
Yes, right.
Yeah. So since almost 8 years, we have practically stopped doing Milligan Morgan. We do either stapler or chip tape, one of the two. Now recently, since 3 years, we have been started doing lasers. Otherwise, we have been following this dictum.
Okay, we'll try this.
Sir, those who are doing Chiute's method, they love it. And I tell you, they try to find the ways, यार ये केस Chiute's method में हो सकता है कि नहीं, पहले वो try करो. So we try to enlarge the frame of Chiute's method. We try to bring more and more cases in Chiute's method. Grade 3, grade 4, uncomplicated. Excellent results. तो जो लेजर कर रहा है, जो MIPH कर रहा है, जो मिलिगन मॉर्गन कर रहा है गवर्नमेंट में, वो भी सोचता है यार पहले Chiute's मेथड में ये फिट होता है क्या, तो पहले वो बाकी बाद में.
In fact, I remember very specifically those I had 2-3 patients of recurrence of post MIPH, and also I had 2 specific patients of portal hypertension secondary piles, where I preferred Chiute procedure rather than stapler because there was no cutting was required. So only thing I was thinking suturing, the chance of bleeding and complication will be low. So that's how I prefer this. And I had follow up of more than 8 years in Chiute procedure, and patient not had any recurrence.
Chiute's procedure, the advantage is that it is as effective or more effective than MIPH. True. And it has almost no complication worth worrying about. There is not any major complication. And the third, yes. No, the fixation is very good.
Yeah, Dr. Hemant.
So, all this procedure has came for the patient-oriented goal. What is definitely Milligan-Morgan, no doubt, in last resort, whenever all this fails out, that is a standard, gold standard procedure at the end. But the thing is that what patient wants is less of pain and early recovery in today's era. So the thing is that whenever we talk about some instrument or some device, there is always a dictum tell that a tool in a hand of fool is always a fool. So whenever you are using any tool, the additional complications will be there because of technique, because of mismanagement of the tools or whatever the staplers. In both the procedures like Milligan-Morgan and suture rectopexy, there are no technical complications regarding the instrument. So that has already avoided. So now in between the two procedures, if at all somebody is ready to give you equal good advantage without pain, so anybody will prefer that procedure. So that counts Chiute's procedure as number one right now if nobody is affording stapler. That is the thing. Yeah, definitely. That is what I said, na. What patient wants is good results, no pain, and no cuts or pocket. So that is all criteria is fulfilled.
There was a paper about MIPH which I want to bring to your notice, which says that all complications occurring in MIPH, the surgeon is to be blamed only in 2%, and the instrument, that is stapler gun, is at fault in 98%. Yes, and this is a paper by Mario Pescatori, the originator of circular stapler, and I can give you this reference 2008.
See, the accident occurs with the car, not because of the car manufacturer. It is because of the driver.
Yeah.
It's all over with the
No, no.
technology for everything.
No,
Stapler may misfire, it may be a bad or faulty. So out of thousands of cars producing, one batch can be withdrawn, one mesh can be withdrawn. It's not because of that.
You have to follow the normal manual, whatever was given with the instrument.
Yeah, it's all. It may be fault of technology, it may be fault of technique. That is what I said. It is not the car which is bad, it is that my driving is bad, that is why I got an accident.
Our next speaker is Dr. Prashant Thane. He's a big name. He has got a very huge hospital in Nagpur, and he's a visiting faculty to Korea and Malaysia and many more countries. He's also has, to his credit, he has operated one appendectomy through colonoscope, and he has recently purchased a robot also. So he's a robotic surgeon himself.
Thanks, Hitesh, for that this thing. So this is entirely a different topic, but we come across this type of patients quite frequently, and we try to avoid them or try to send these patients to the psychiatrist. So chronic perineal pain not responding to treatment. This was a 32-year-old gentleman, athlete, severely depressed, bank employee, from the sports quota. You can imagine what is the type of physique then. Now on leave without pay for almost 6 months. He started having pain in and around anus and scrotum. The VAS score, that is visual anal score, was pain score was around 7 to 9 in sitting position and 5 to 7 in non-sitting position. There is a crux here in the history itself, that the pain score was more in sitting position and pain score was less in non-sitting position. The patient had lower abdominal pain, he had erectile dysfunction. Again, it is related with the chronic abdominal and chronic perineal pain. So these two can be combined because the history itself is very, very specific. Erectile dysfunction since last 4 years. That erectile dysfunction can be measured by IEF score. That was highest score is 6, and out of that highest score is 10. Out of that he had 6 score, and he has constipation. Again, we know that the constipation can be measured by Wexner method, and highest score is 15. Out of that he had 12. So perianal pain is severe. Pain increases on sitting and can't sit for more than 2 to 3 minutes. Operated twice for fissure in ano. He had no relief. The psychiatric treatment since 18 months. So obviously the surgeons, they send him to the psychiatric treatment. The quality of life score was very poor as per Kalman gap measurement, 10 out of 15. So what were the clinical details in this particular patient? He had continuous excruciating pain. His marriage was in doldrum because of the erectile dysfunction. No sexual activity in 3.5 years. He was irritable, quarrelsome, unsocial, now depressed with suicidal thoughts. He received ECT in one of the cities of India, and he had attempted suicide. Suicidal attempts were also there in the asylum. And he was brought for consultation, the history itself was very significant, and the unable to sit was a very significant history. Hence we suspected that this particular patient is having pudendal neuropathy. Investigations, PR examination was normal. There was hyperesthesia in the perineum, that is a significant finding, and scrotum as well, and particularly on right side, not complete scrotum or complete perineum. Abdominal sonography, sigmoidoscopy, MRI, everything normal. So we will see first what is this pudendal neuropathy, what is this canal. Can I attach this voice thing? Yeah, please. Sorry for that. So we will see first the anatomy. I have tried to explain this in three-dimensional imaging system, which my son has helped me. Audio? To see it. See, this is the pelvis completely. We are discussing everything on the left side of the pelvis here now. And I hope it is audible. Spine here. Yes. And this is the sacrospinous ligament. This is the sacrospinous ligament. This is the inferior ramus, and this is the ischial tuberosity here down. If you can see, this is the ischial tuberosity here. So the canal is lying here from the ischial spine here, almost 3 centimeter forward, and this canal is formed because of the dense fascia there, and through this canal 3 important structures they go. One is the pudendal nerve, the pudendal artery, and the pudendal vein. The pudendal nerve gives one branch here in the canal. So when all these 3 structures they are compressed here, the most affected is the nerve, and that leads to pudendal neuralgia because of that compression. And we have to release this particular canal surgically. Laparoscopically we have to go here, and this sacrospinous ligament is the landmark. Sacrospinous ligament is the landmark. We have to reach up to the ischial spine, and there are too many important structures here, the vascular and the neurological structures. We will see the internal iliac artery now. So this is the internal iliac artery, and this is the trunk. This is the anterior iliac artery, anterior branch of the internal iliac artery. This is the posterior branch of the internal iliac artery, and this anterior branch of the internal iliac artery gives 1, 2, 3, and the 4th branch is the pudendal artery. When we want to diagnose, how we are going to diagnose this pudendal neuralgia syndrome? So first of all, by clinical diagnosis from the symptomatology. Secondly, from the if we block this pudendal nerve by giving a anesthesia, local anesthesia here, a pudendal block. So how that pudendal block is to be given? So we go from paraanally, anus is, this is the coccyx here. So in front of the coccyx, anus is here. So we go into the direction of the ischial tuberosity. This is the ischial tuberosity here, and our canal is here. So we have to infiltrate the canal. We have to infiltrate the canal with local anesthesia so that the nerve is blocked. And when the nerve is blocked, the pudendal neuralgia decreases on that particular side. Pudendal neuralgia can be unilateral, it can be bilateral also. The second or third way of how to diagnose this particular pudendal neuralgia is we can go ahead and do the pudendal artery angiography also. In pudendal neuralgia, because the artery is also getting compressed in the canal, the artery will not be visualized in the angiography, and thereby we can do the diagnosis. So by this way we can diagnose, and this is the anatomical structures. So we have to reach to the spine, ischial spine, and we start releasing the pudendal canal from here. So the 5 essential diagnostic criteria are, they are called as the Nantes criteria. Nantes is one of the city in the France. A conference was there for this particular diagnosis of the pudendal canal, and the criteria goes by the name of the Nantes. These are the 5 classical essential diagnostic criteria. Pain in the anatomical territory of the pudendal nerve, worsened by sitting, patient is not woken at night by pain, and no objective sensory loss is there, and the positive anesthetic pudendal block. So erectile dysfunction in males, dyspareunia in females. This is very common symptom in females with pudendal nerve syndrome. These females, somebody is talking, I think. Please help me. So these females, those who are having dyspareunia, think about this particular syndrome. Particularly where sacrofixation is done by the gynecologist, they take that stitch and the nerve is blocked, and these patients, they have hell of a time then. The psychological disturbance, obviously because of all these things, the patient, they are constipated, we will see the reason of constipation, and quite resistant to treatment. They just don't respond to any line of treatment, and frequency and urgency of urination can also be there. So these are the various Nantes criteria. You can go ahead over there. Because of shortage of time, we will go ahead. Right-sided pudendal block, everybody now knows how this pudendal block is given, and we have to palpate the ischial spine, and there the pudendal nerve starts, and then that area is to be infiltrated. The pudendal angiography also, you can see this particular artery is blocked as compared to these other 3 vessels there. The most common profile is the patient who had even multiple physicians, had seen the multiple physicians, failed multiple pharmacological treatment, failed psychotherapy and perineal hyperprotection, severely disabled by pain with no evidence of organ disease. The negative scans, all the investigations, they are negative. Many diagnoses are kept, interstitial cystitis by the urologist, idiopathic vulvodynia, endometriosis, idiopathic orcalgia, idiopathic proctalgia, Levi-Strauss syndrome, then coccydynia. So n number of diagnoses are kept, and the patient keeps on increasing his diagnostic list and doesn't get any response. So these are the various differential diagnoses. So what are the diagnostic tests? As we have already told, physical examination, diagnostic injection, and then ultrasound shows potential entrapment of the nerve and the nerve enlargement in 7 out of 10 cases. MRI is not good there. X-ray, if there is any fracture and callus formation is there, old callus formation causing complication of the neuropathy. Then electrodiagnostic studies greater than normal, but these are very technically advanced procedure, not available with us. So this is the pudendal nerve here, and it gives out 3 branches. The inferior rectal nerve will give rise to the perineal pain. Then inferior, apart from that, the perineal nerve and the deep dorsal nerve of penis. So that is the reason why this patient, they will go in for erectile dysfunction. So the medical management, muscle relaxant, analgesics, anticonvulsants, because the nerve is getting involved. Then invasive treatment, Botox, high recurrences, radiofrequency treatment, again blind procedure and very high recurrences. As usual, steroids, they come to help us, but again no response and high recurrences. Then PRP, platelet-rich plasma injection, again problem, the hyaluronic acid. So only thing which is remaining there is the surgery. So These are the various important structures there with passage of the ureter there. We have to go in between these two. We have to reflect the ureter medially, this laterally, and go in between these to the ischial spine there. We will see a small video. I will try to forward it. So inspection of the pelvis first, and then lifting up of the peritoneum over the iliac vessels, and then searching for the internal iliac artery. This is the vein, external iliac vein. This is the internal iliac vein here. The external iliac, internal iliac vein, and in between there we have to go in for the searching of the internal iliac artery. Posterior branch is deeper, anterior branch is superficial. So I will try to a little bit forward it. We have to skeletonize all the vessels and structures there. We will have to do it very cautiously to avoid the complications. And once the skeletonization is proper, we can see various structures there. Now this is the posterior branch of the internal iliac. So we have to create window. That is the first branch which is coming. The internal. We remember that there are 4 branches there. And after skeletonizing again, whatever fibrofatty tissue is there, we have to remove it so that to improve. And there you can see the branch going down. So every branch is very important. We can't sacrifice any branch there, because most of the branches, they are accompanied by nerves. So this is the window which we have created in between the branches of the internal iliac arteries. So that is the 4th branch which is going down there. And then we think about, this is the ischial spine here. So we will open the ischial spine. So whatever structure which we are removing over the ischial spine will be the sacrospinous ligament. So that is the sacrospinous ligament which we are now opening up. Immediately that sacrospinous, so we come across that artery and the nerve there, and we go anteriorly. And once we get the first bleeding there we stop. So that is almost 3 centimeter of the decompression. And the complete decompression of the Alcock's canal or the pudendal canal. And once that decompression is done, various methods are there to deposit the fat there so as again refibrosis is not occurring. So omental patch can be kept there, or even fat can be instilled there so as to prevent the recurrence. There are certain gelatinous material also available. So that is the completely decompressed Alcock's canal. So pain disappeared in 2 weeks, erectile dysfunction improved in 3 months, he was off laxative after 5 months. So all these scores improved, as we can see in red. Antipsychiatric medicine stopped in 30 days, returned to work in 2 weeks and started his workout and cycling. Remember that he was an athlete, and now follow-up of more than 16 months now. Various exercises are designed for the pudendal neuropathy. We have done 4 laparoscopic decompression, 3 females, 1 female. We are into 1 transgluteal endoscopic decompression, a multicentric study going on. That is the reason why I can't much disclose, because it is an ongoing study. All patients are symptomatically improved. Usually female preponderance is there, symptomatically usually in 4 to 7 decade. Diagnostic dilemma is always there. Laparoscopic approach is one of the best, fast, safe surgery, early return to work, less morbid, less complication, less hospitalization, less post-operative. Obviously, all the advantages are there in the laparoscopic method. Thank you very much for that. Thank you.
Are there any chances that while doing laparoscopy, can there be, because it appears that the nerve injuries, very small nerve injuries are there. So while doing this pudendal neuralgia, treating pudendal neuralgia, can there be
Yeah, I could get that. If the nerve gets damaged, then he will be permanently disabled patient. Erectile dysfunction.
Secondly, whatever the other things which
And that is one of the reason in septa anesthesia, that is one of the complication has been explained in pudendal blocks.
Okay.
That if that nerve gets damaged or there is bleeding and then entrapment of that nerve, this syndrome can occur in pudendal blocks. So that is the diagnostic, and the complication of that diagnostic pudendal block is also again a pudendal neuralgia.
One question again, Prashant. You have told so many of the modalities of the management of this neuralgia. Before that, before going for the laparoscopic approach, what is your say on that? That which type of patient will need for the surgery only, and which type of the patient can be treated by other modalities of the management, which you have narrated very in a long list. You have narrated. What are the treatments?
All those methods, they have been tried, but the scientific papers and the literature, whatever is available, that favors only surgical. But there are many surgical, the open method also. I have skipped that because of the time. You can see here. Laptop connect. You can see here how morbid is the procedure. We have to reflect the gluteus maximus to reach the sacrospinous ligament, then cut the sacrospinous ligament from back and then expose that canal from the back. So this is very, very morbid condition. Even a small ligamental problem or muscular problem at that back level gives rise to tremendous problem in our locomotory function. And cutting that complete, reflecting that gluteus maximus, exposing this sacrotuberous, then again cutting that sacrotuberous in that way will lead to instability of the, and that are the papers available, particularly with the orthopedic people. These papers are available with the pelvic injury and the sacrospinous and sacrotuberous ligament injuries. These pelvis, they become very unstable and patient can have lot of orthopedic problems.
Hats off to you, because this surgery doesn't appear to be so easy to do and so easy to be implemented by all, because the problem is very common, because many of the patients, they are having this type of neuralgia treated for a long time on analgesics only, and then later on they are going on anxiety treatment. Thank you very much.
Thank you so much.
Congratulations.
Yeah, thank you.
Sir, great surgical work. But before any patient for surgical intervention, do you give them a pudendal block just to ascertain the diagnosis?
Pardon?
Do you give them a temporary pudendal block to get ascertain the diagnosis?
See,
then only you can.
Pudendal block will work only
surgery.
for 4 hours or 5 hours.
But that will confirm the diagnosis.
Yes.
So that is for every patient.
Yes.
You give a block.
Every patient.
If he is free, then subject to surgery.
Every patient. In only out of 4 patients, we did in 2 patient pudendal angiography. We have done.
Prashant, many of these surgeons, they are doing on the anorectal work in blocks now, local blocks. What is your experience on the pudendal block and going for all anorectal surgeries like Fisher?
No, it is always good.
It is always good.
Pudendal block, long term, the immediate post-operative pain decreases, but it is not advantageous. Those people who are giving pudendal block after doing surgery in spinal. So the spinal effect will be there for at least 4 hours. And this pudendal block will also remain there for 4-5 hours. So there is no advantage. But if you are doing it in short general anesthesia, then you are giving pudendal block. So immediate post-operative period, patient will be painless.
One more complication of the pudendal block, which I feel that whenever you are going transanally at the lower side, you can put the infection inside sometimes through the pudendal block.
Any transdermal.
Because this I have seen the case what was referred to me that the patient has developed the abscess after the pudendal block. So might be that the precautions might not have taken, but still I feel that is it so safe rather than doing for a spinal? It is not related to this subject.
No, I think the procedure of pudendal block should be given at the beginning of the procedure, not at the end of the procedure.
Beginning of the procedure.
Because we are definitely going to soil the perineum, and if the abscess is forming, then that is a problem with the surgeon.
The abscess is because of infected hematoma.
Yes.
Primarily abscess.
Yeah.
Thank you. Thank you very much.
Thank you.
Very nice topic, and it is elaborated quite nicely. For the first time I heard the surgery for the pudendal neuralgia. Thank you, Prashant.
Thank you. Thank you very much, Dr. Rate.
So I will introduce you then.
Fish flap procedure.
So now the time is for today the first one who has done a lot of work for only 1 month. He has arranged this program. It was quite difficult for us because after a long time of online habitual learning phases for 2 years, we have come down for the first time for this offline workshop, and for this Dr. Jiten Chaudhary actually he needs a good round of applause because he has taken tremendous pain for only one year and 1 month, and there was no actually so many of the hands was not helping for him, and now he is there to present his good work. He is known for these procedures. He is very much interested in pulmonary sinus, and when we talk about the pulmonary sinus, there are multiple procedures. Out of that, there are multiple flap procedures also, which are done quietly by the plastic surgeons. But as a colorectal surgeon, we are facing the problems of pulmonary sinus. We are only removing this tissue, and we are allowed to heal that wound by this secondary intention. But nowadays, the flap procedures are rampantly used, and they are quite famous also and having good results. Now the question is, he will be telling us which flap procedure to be done, and this is not only on the bookish knowledge, on his personal experiences. Thank you once again.
Thank you, sir.
Yes, Dr. Jiten.
Yes, sir. Thank you, sir. Thanks for the nice words. At one point or the other, we surgeons, most of us, must have faced this dilemma that which flap procedure we have to use, either the Karadikis or the Limburgs, if we are using both this. Here in this scenario, the patient has presented to us either with the recurrence or his pyloral abscess has been drained, and he has presented to us with an open raw wound. So we have to plan a flap. So this dilemma is always there in the mind, and in my subsequent slides, I'll try to clear off this dilemma. Myself, Dr. Chaudhary from Godrej Memorial Hospital. Dr. Ladukar has already introduced me. Okay. To begin with, we have to understand what causes the pulmonary sinus and what causes the recurrence. So, it is mainly the midline holes are there in a given patient of a pulmonary sinus. If we are just doing a laser procedure, or we are doing a Bascom's 1 procedure in which we just pick up the pits, but it's a normal tendency to have clear the lateral sinus, and it's a high chances that the midline pit is missed, because midline pits are most of the time silent, although they are the source of the pulmonary abscess, but they are most of the time silent, and they present mainly with the abscess in the lateral side. So there are high chances that midline pit is missed, and that causes the recurrence. Another, there are many other factors of the recurrence, but this is again one of the main causes, or surgical cause for the recurrence. So another point to be taken care of is that we have to understand that the force concentrates on that 1 mm to 2 mm area where the narrow gluteal crease comes in close contact with the sharp angle of the sacrum. So this will come into play so when a patient has got a deep natal cleft, we have to address it differently than a patient with a shallow natal cleft. It has been well accepted that off midline versus the off midline procedures are better than the midline procedures. They take less time to heal, and there are less chances of the wound infection in the off midline procedures, and there are less chances of the recurrence. See, there are now I'll be comparing the two procedures, that is the Limburgs and the modified cardiac crease, the Bascom's modification of the cardiac crease, and both procedures has got its pros and cons. There was a large study comparing the two types of procedure, and in fact not one study, two studies, and this is a combination of two studies. If you will see the cardiac crease lateral advancement flap versus the Limburg flap, the rate of complications was less in the cardiac crease flap, the wound infection rate was less in the cardiac crease flap, the subcutaneous fluid collection was less in the Limburg flap, and there was a less recurrence rate in the cardiac crease. But that difference is 1% only. We can say it is almost the same chances of the recurrence. But whereas in the cerebral formation is more in the cardiac flap, the wound dehiscence is again more in the cardiac flap, and flap maceration again is more in the cardiac flap. So we have to choose the procedure according to the requirement of the patient and according to the requirement of the disease. So I'll be just dealing in brief this Bascom's procedure and the Limburg procedure. I'll be directly going to the video. See, this patient has been marked on two sides. The outer line you can see is basically where the natal cleft meets, where the two cheeks of the natal cleft kiss each other before starting the operation. And after starting the operation, what we do is we strap the patient on both the sides. The marking on the outside has to be done before we start the operation. This marking I'm saying. Local anesthesia is being infiltrated, having adrenaline in it to avoid, to basically to maintain the hemostasis and avoid bleeding. A flap is being raised on one side. See, we have to keep in mind that we should not be crossing the dissection more than the outer line. The dissection has to be till the outer line only. Otherwise, there are high chances of the flap necrosis and maceration of the edges. See, this the whole disease has been removed. You can see the marks of the methylene blue which was instilled before. And the wound is closed under a Romovac section drain. The wound is closed in two layers. One inside layer I have used 2,0-Vicryl, and outside people use ethylone. In this case I have used the staplers, the skin stapler. And you can appreciate that the wound has come off midline. See, keeping the wound off midline not only makes the gluteal cleft more shallower, it also helps the patient to clean the wound in the post-op period also. So there are very less chances of the infection. Next slide. Now coming to the Limburg flap. This again is a very nice procedure. And in fact, this procedure has got better vascularity than the Bascom's procedure, because the vascularity in this comes from two places, unlike the Bascom's. This is the marking being done. So what we do is basically we first mark the vertical diameter. So and then we draw the horizontal diameter. So the horizontal diameter is basically 60% of the vertical diameter, and that is how a rhomboid is being made. This is the area of the pilonidal sinus which will be excising it. We mark it as ABCD for over convenience. That AB has to be equal to the flap which we are designing now. So basically this limber flap is a combination of a transposition flap and also a rotational flap. It also rotates and it also transposes. Position of the patient is prone, of course. Any pilonidal sinus we have to operate in a prone position. This like. No, it's not a jackknife position. It's a prone position, proper prone position. Yeah, now the buttocks have been strapped. Yes. So in this you can see we have already injected the this thing adrenaline solution. So it's quite clean. The dissection is clean. There is hemostasis which is this thing nicely maintained, and in this flap we raise the flap above the presacral fascia. In fact, the presacral fascia is basically included in the flap. You can see the gluteal muscle there. So the section should be up there. Muscle till the muscles. The flap has to have the sacral fascia along with it. And the other set of blood supply is from that just above the presacral fascia. That is why it gives a very nice vascularity and it fills the volume more. So any patient who has got a very deep natal cleft, this is the procedure of choice. Although it looks very big procedure, but the results are so fantastic, and that and the chances of the recurrence of the pilonidal sinus is very, very less. So this flap has got the additional advantage. The length of the flap can be at almost 3 times more than the width. So I'll tell you. These are the basically gluteal muscles you can see. Now, the vascularity, the part which we are transposing and taking to the other side, even if it is 3 times more than the base, it maintains the vascularity, being a vascular flap. That is what I meant to say. See, this is how it is going to get attached there. We see that there is no tension in the wound. We first hitch it with some 2,0 Vicryl at a few places, and then close the wound with 3,0 ethylone or 2,0 ethylone. Sutures are better to have a proper alignment. Yeah, see, nowadays many people have stopped keeping the drain, but I prefer to keep the drain. Complications of any procedure are there. I'll be discussing in the next my next slides. Yes. Commonness is basically if there is more tension is there, then chances of wound dehiscence is there. The chances of wound the edges getting necrose is there. Yes. Yeah. And there is this C point can sometimes be a point of sorrow. We call it the sorrow point because it is the point where it is very near the anus. So there are high chances of it getting contaminated and wound infection is there. So this is the point where the wound normally opens up. So nowadays what we do is we just tilt the rhomboid little on the one side so that that C point goes little more laterally. It's better to take the point C point little laterally to avoid the sorrow point. See, this is how the wound gets closed. Now I'll be taking multiple sutures to close the wound. So it was said by none other than William Osler. It is much more important to know what sort of a patient has a disease than what sort of a patient, what sort of a disease a patient has. So this has to be kept in mind while planning a flap. So what is the anatomy of a flap failure? See, one is ischemia. If it tight, the sutures we take sutures very near near sutures, and if it tight make it a tight suturing, then there are chances of ischemia is there. And if their dissection is not proper, then there are chances of tension is there. And if we have not very well versed with the technique, then their chances of flap failure are going to be there. Contamination of the wound definitely can lead to wound infection and a flap failure. Friction, we have to avoid friction for the initial 7 days after the procedure. The patient has to be made to lie either in the left lateral position or the prone position for at least 7 days, and after that also he has to use a very soft cushion while sitting also. So, and the importance of hygiene cannot be overemphasized. One of the most common causes of the recurrence is not proper maintenance of the hygiene. And smoking is found to have an independent risk factor for the flap failure. So, these are the various reasons for the flap, as asked by you. So, how do I approach? Which procedure to be used? Between the two, modified Karadickis or the Limburg's flap. So we have to understand the anatomy of the disease. So if you see in this slide, this patient has got the disease on both the sides. So he is a perfect case for a Limburg procedure, not the Bascom's, because Bascom's means it's a lateral advancement. Bascom's modified Karadickis is basically a lateral advancement flap. If the patient has got disease on both the sides, the pits are on both the sides, it's better to go for the Limburg's procedure. Another thing, as I mentioned earlier, is that if the patient has got a deep natal cleft, then one should go for a Limburg flap. But see, the thing is, cosmetic wise, the Bascom's procedure is a better procedure. So if the patient is a female patient, so one should first go for it's an easy to do procedure. Anyone can learn it very fast because we have been raising the flaps in the breast dissection also while raising the flaps for thyroid also. So it's a very, it's a similarly we raise the flaps there also. So it's a very easy procedure is Bascom's procedure, and the results also good, and cosmos is also good. So another factors which have to be taken care of is like disease severity. If it is like this kind of disease on both the sides, we should go for the Limburg's procedure, and we should always think about the patient's expectations. If the patient is trying for more cosmesis, we should offer a modified Karadickis flap rather than the Limburg's flap because it's more cosmetic. And if the patient, sometimes patient comes and they ask me, doctor, is there any guarantee that this flap will not fail? So I better not do anything only. For them, I'll leave the patient to heal it on its own. That is again one of the choices we have. Because if the patient is not understanding, he wants some kind of surety from us. Ki, honey, doctor, you have to give me some surety. Then leave the wound line and let it heal by secondary intention. That also to be kept in mind. And patient's education. The patient has to be educated to understand what we are doing and how to take care of the wound later on. The patient has to be properly explained and counseled regarding the procedure. That's it. Thank you. Any questions? Yes, please.
Sir, what is to be done for avoid for the few stitches gangrene over the limber plaque, particularly in the top sutures?
So the thing is, see, normally this procedure takes this flap takes it well, except for few necrosis or gangrene at the edges. So we can just excise that wound and let it heal by secondary intention. Clean the wound and let it heal by the secondary intention.
In last 3 years, I have done around 26 cases of the limber flap.
Excellent.
And touch wood, there is no recurrence till now.
God
but
bless.
In around 6 to 7 cases, I found that always there is a necrosis of the top suture, 2 to 3 stitches. So I tried in last 3 or 4 cases that I avoid suturing at the top sutures. I just take the dermis with the Vicryl 30 in that area and leave it. And touch wood, it was.
See, the thing is, what you are saying is the top suture means your dissection. Top suture means your dissection. See, I'm just presuming it. The dissection may not be have adequate, because that is the point where the maximum tension is going to be there. So the first and foremost point is that wound has to be closed without any tension. So that is the point, the top point, A point, what you are talking about is the point where that maximum tension is going to be there if there is not a proper dissection. Dissection, I mean to say, extensive till the flap is not raised properly till from the base. It has to be lifted up from the base. Sometimes what we do is we see, yes, it is moving and we try to close that wound. It has to be dissected till the base to have that transposition effect, and the flap should raise till the point A to to avoid any kind of tension.
Maybe I will take care of next time.
See, the cause of necrosis at that particular point are 3 problems. First is the angle which we are creating. It should be more than 60 degree.
Okay.
That angle is to be proper. Secondly, handling of that particular flap, it should never be handled with tissue forceps or your forceps. No LEs, nothing. And thirdly, the use of cautery should be very minimum. So these 3 reasons.
Every case I use cautery 100%. Knife for only the first put incision, then each and every case is 100% flap raised by the cautery only.
Excellent presentation, Dr. Jachin. What we want is now your post-op protocols. How many days you remove, post-op day you remove your drain, if at all it is placed. Second, how many days after you will do a suture removal, whether it is a suture removal after 2 weeks, 3 weeks, or in between half and half. Third thing is, what is the patient positioning or advice to the patient, whether when they will sit, they can sit, and when they can lie down on buttocks.
Yeah, you asked a very, very important question, Hemant. Basically, the drain normally we try to keep for 3 to 5 days. And sutures we normally take between 15 to 16 days. And we advise the patient to stay in the prone position or in the left lateral or right lateral position, not in the supine position, for at least 7 to 8 days. And he cannot sit for at least 7 to 10 days. After 10 days, even if it sits, it's better to use some kind of a cushion or a ring kind of thing, so that the pressure doesn't goes into that area. So you have to avoid a pressure at any cost.
Doing a flap surgery is very easy, but maintaining a flap in a post-op care is very utmost
very
important.
Yes, yes. See, the thing is, again, the wound has to be cleaned properly. There is a tendency, because that is the area where the negative pressure builds up and the hairs gets trapped and sucked in that area. So the thing is, the cleaning has to be, the training for the cleaning has to be started from the immediate second or third day itself. You clean that area in front of the patient and in front of the relatives. You teach the relatives how to clean that area. If you clean that area properly, then there are chances of this thing failure or less. Otherwise, there are very high chances that even in the edges, the patient may have hairs entering into that area.
Do you advise laser depilation for such patients where particularly you have done a flap? Now it is in a major
No, I'll answer that question. See, the thing is, the hairs in the pylonal
flap is very bad.
The hairs in the pylonal sinus are not necessarily from that area only. It has been shown in various studies. Even the hairs from the back and the nape of the neck has been found there. So even though it's, if you mean to say that you would want to depilate that area, you have to ask the patient to get bald. Okay? So then it will be a complete procedure. So just doing in that area is not recommended.
Thank you.
आते ना सर
Hello.
Moderated by Dr. Ladukar sir and Dr. Ramesh Kurapati.
Yes, sir. Hello. Thane. Hello. Good afternoon, everybody. I think everybody is going for a lunch now. Please stay back, listen to me. Thank you. Today I am talking about Chiute's procedure tips and tricks. Why I am doing it? Because apparently the Chiute procedure looks very simple, and that is why there is a tendency of taking this procedure very lightly. Because when you ask anybody, अरे उसमें क्या है, टाका तो लेना है और क्या है? So that complacency has crept in, and because of that we are seeing some funny complications after Chiute procedure, which should really not happen. Because when the experts operate, like Dr. Chiute is going to show you the procedure, or Dr. Ahate is showing this to you, it feels like this, Sachin Tendulkar 6 at each ball. But when you do it, it becomes like this. And that is why there are certain precautions that people who are learning this technique fresh should know, because each small thing makes a big difference. And the important thing is that Chiute procedure is a 100% surgeon dependent procedure. If you get good results, you get full credit. If you fail, you cannot blame anyone. So there are so many things, one by one, I will briefly touch them. Meticulous assessment, of course, this is for no matter which procedure you select for piles treatment, all these things you have to look at, so we will not discuss much about that. Pre-op pre-op preparations, what I feel is that oral metronidazole and deworming is necessary, because amoebic infection and worm infestation is very common in Indian people. And secondly, there is documented evidence that oral metronidazole given pre-operative, post-operatively for hemorrhoid cases reduces pain. Thorough bowel preparation is mandatory, at least for me, because I don't take any shit from anyone. And you always need a very clean operating field, and you enjoy it, and then even the infection rate is much less. Now we will come to instruments, because these two things are very important. There are two Chiute proctoscopes available in the market. This is his older design, which is made of metal, and there is a moving sheath, and that is why I call this
proctoscope with variable operating window. So this is a operating window, and this is a margin of a sheath. This is good proctoscope for beginners, because when you use this proctoscope, you can put this line as a guide to taking your sutures. And important thing is that you should have a uniform distance between the two rows of sutures. So if you put this as a guiding line, then you take first suture 4 centimeter away from dentate line, then retract this sheath and go for 2 centimeters from dentate line. You are more likely to get a uniform distance and a good avascular strip of mucosa, which is most important. But it comes with lot of problems, and that is why sir has designed another proctoscope. Now the problem with this is that when you use this sheath, you pull it. So eventually the length of the proctoscope becomes long. And when the length of the proctoscope becomes long, you need to take longer instruments, like needle holder of at least 11 or 12 centimeters. That is what you need for this surgery. And when the instrument is long and you are operating deep inside, taking sutures are little difficult. So now he has prepared this instrument, and what he has done in this is that he has made this area fix, which is 4 centimeter, which compresses about 2 centimeters above the dentate line. So all the hemorrhoidal masses are compressed. This is transparent, so you can see through it. And what he has given is, he has given the markings inside, and those markings you can use as your guide to take the suture line. And the illumination also is far better. So this model is much better, but the previous model may be a little advantageous for those people who are starting their work fresh. Now there are two types of suture materials that are available for doing this procedure. The one is 20 Vicryl 30 mm half circle round body needle. It has 90 centimeter thread. This material, this needle 30 mm half circle is very easy to suture, and it is much easier for the beginners. The loops are larger, and to take, that is why you take a overriding sutures. Maybe in the evening when sir will demonstrate, he will demonstrate that. More likely to fail inadequate length at the end in the initial stages. These are the disadvantage. This another suture which is Vicryl 27 mm. It is 5/8 circle, so it is fairly curved and round body needle, but it has 100 centimeter length thread. This is also named after our Dr. Ladukar. This is called Ladukar suture, LDL. This is difficult to handle for the beginners because the curve is very narrow. But it takes good tight small loops, and the length of suture is mostly not inadequate. Now, when I want to describe Chiute's procedure, I described it as Chiute's procedure is a single ideal stitch repeated over and over till full circle is reached. The importance of this is that each stitch must be meticulous. And the good thing about this is, in Chiute procedure, each stitch is a single event. You can take each stitch individually. It can be easily undone. If you have put a needle, it has gone deep, you can take it out. If it is superficial, you can take it out and then take it again. And that is why uniform depth of entire suture line should be achieved at all times. That should be your aim. And if you do this thing, then your Chiute procedure will never fail. and each stitch is taken under direct vision. So you have no excuse to say why I did not take a proper stitch. Now we'll look at the ideal stitch. What is the ideal stitch? Ideal stitch is, it's a stitch we should take mucosa, submucosa, and just reach to the muscle layer, but should not include it. Now the definition is good, but how would you know on table that your stitch is ideal stitch? So if your stitch is superficial, what you do is take a stitch, when the needle other end comes out, with the needle holder, slightly pull the needle up. If you see the needle through it, it means that you are going only through mucosa and your stitch is superficial, and this is useless stitch. So you take it out, take again. The ideal stitch will have a fleshy bulk between the needle, and still you will be able to lift that very easily. This is an ideal stitch. But if the stitch is deep, where you have taken the muscle, then it will look bulky, but you will not be able to lift the stitch very easily. These are clinical judgments on the operating table to know that you are taking a proper stitch. And if you take each stitch like this, then you are less likely to have any problem. Now we have to look at the position of hemorrhoidal masses. If you as a beginner have large hemorrhoidal masses at 11, 12 and 1 o'clock, beware, you are more likely to get recurrence. And for a simple reason, that this upper half, starting from 9 o'clock to 3 o'clock, here you need more practice to take proper depth stitches. This is a difficult half to suture for the beginners if you are not have good experience of suturing in depth. And that is where what sir explained to you, use your pronation, supination, use your wrist, not your shoulder, that you should not drive the needle, you should rotate the needle. That technique you have to master in this place. So if you are not very good at suturing, what else you can do? The other thing that you can do, which is not something very familiar to Indian surgeons, is to operate in jackknife position. So if you take jackknife position, this upper quadrant comes below, and then the below sutures are much easier to take. Now we'll look at the procedure. The important thing is extended lithotomy position with steep head low position. This is important, both things are important. Extended lithotomy meaning the anal verge should be at the edge of the table or slightly jutting out of the table. So here the introduction of proctoscope will not be a problem because the perineum opens up. Massage and reposition of prolapsed hemorrhoids. You have to massage them, reduce them, decompress them, reduce the volume and reposition them properly. Gentle anal dilatation is necessary to relax the circular fibers. If you do gentle anal dilatation, proper lubrication of proctoscope, and thirdly, which I do, and I think it works very well, is keep proctoscope in place for about 1 to 2 minutes before starting your procedure. When you put that proctoscope inside, it gives uniform circular dilatation of the circular sphincter and it relaxes. Where the objection was of dilatation is that it is not uniform, and then that is why you use dilators to do it, so it will give uniform. This is exactly the principle. You keep it there for 2 minutes, it gives proper dilatation, and then you will know that once you do this, then to rotate your proctoscope will be extremely easy. You will not have to put repeated jelly on the edge of the proctoscope to do it, or even to put the obturator inside to rotate the proctoscope. The proctoscope will rotate very easily. Now, starting suturing at 6 o'clock, this is only for beginners, because 6 o'clock is a beginning. We take only 2 ties in Chiute procedure. To begin, you take a tie, and at the end you take a tie. And 6 o'clock is much easier place to tie the suture than any other place. But once you get this habit, there are people who start at 3 o'clock, those people start at 9 o'clock. There are some people who start at 12 o'clock. No problem once you have good technique. Each stitch should be ideal stitch, which I have explained to you. That type of stitch, if you have taken, then your results will be very good. The common problems that you get when doing this procedure is uneven depth of suture line, and this is a crime. If you do an uneven suture line, then you are not doing this procedure properly. So you should know what is an ideal stitch and try to take each stitch as an ideal stitch. Bleeding. There are 2 types of bleedings which commonly occur. That the needle comes out, that on the tip there is little bit of ooze. That should not be that should not bother you, because you continue suturing and that will stop. Second bleeding that can occur is at the stitch, but there is a spurt. So if you take that stitch, tie the knot and take overriding suture, the bleeding will stop. The biggest problem that comes is during submucous hematoma, and these kind of problems come in patients having cirrhosis, having CCF, or those patients who are on anticoagulants and we have not stopped their anticoagulant medicine for adequate time. And it can become messy because it rapidly increases. So when you have this kind of problem, you take a moist gauze piece and compress over it, and keep the compression past the clotting time of patient's clotting time. And still the edema is quite lot, difficult to handle, and this is 3 cases preferably the beginner should not try. Laceration. Laceration also is a common problem of beginners, where they try to push the needle and not rotate the needle. And that normally this laceration is mucosal laceration, causes little bleed, stops with compression. But laceration like this should not happen in a good suturing. Breaking of suture midway, short length. If that happens, you take a fresh suture material, tie the knot to the previous one, and you should be okay. Post-operative clear. This is something which is a little bit controversial, but something that has worked well for me. That there are people who start full diet immediately after surgery, but I prefer to do that. If there is no prolapse, then I put my patients on clear liquids for 3 days, and I don't want them to move their bowels. The simple reason is that it is quite a good amount of edema that occurs because of the surgical procedure itself, and we should allow that edema to subside. Otherwise, patient will have bleeding or have part of that prolapse coming out, and then he will not be happy. If the prolapse is more, that is 3rd degree, then I put them on liquid diet for up to 5 to 7 days. There are people who are questioning me, How can people remain on liquid diet for 7 days or something like that? The simple thing is, otherwise what you advise them is that you take food, visit your toilet, don't sit on toilet for more than 5 minutes, don't sit on toilet for more than 2 minutes, 5 minutes. Patient is not going to listen to you. So it is better that if it doesn't pass the stool, then you give adequate time for the edema to subside, and mostly the prolapse will never occur. And there is no bleeding, no prolapse. The pain is very, very less, to the extent that most of my patients don't ask for analgesia after 24 hours. Oral antibiotics should always be given. This is again a controversial subject, but I give antibiotics for at least 5 days post-operatively. Thank you very much. Yeah.
When we were discussing this in operative surgery,
yes,
and we are quite too late now, one
yes,
and a half year. So we'll stop over here and we'll call the next speaker.
Thank you.
नहीं नहीं बहुत सारे प्रोसीजर होने के पाटिल धरो ना अरे क्यों यार
Is Dr. Furia here with us?
अरे नहीं यही करो ना डॉक्टर हेमंत पाटिल अंदर स्टेनोसिस उसके पास
हाँ yes sir. Is Dr. Furia with us here?
यार मैंने किया था ना.
Okay. Next speaker is Dr. Hemant Patil. He'll be speaking about anal stenosis. He's a consultant at Fortis Hospital, Mulund, and he has got his own hospital in Thane. He's also the secretary of Thane Surgical Society, and he has helped me in many ways. Okay? Dr. Hemant Patil.
On behalf of Surgical Society Thane and ISCP, I welcome you all in the city of dreams, that is called Mumbai. To arrange a conference is always a dream of a surgeon. But to arrange it single-handedly needs courage and applause too. Hats off to Dr. Jiten Chaudhary. He's very near and dear friend also. I have given some inputs for this conference as well. The topic given to me is anal stenosis. So the thing is that in any proctology conference, we talk about pies, fissure, fissulas, n number of techniques, n number of things. But very rarely we talk about the complications which needs attention. That is, the complication is anal stenosis or stricture. Thanks for giving me such a simple topic. So, anal stenosis or anal stricture. So, we'll go by simple things. I hope everybody is enjoying lunch. My lecture may not make them sleepy. Let me be short and sweet. So what is mean by anal stenosis or stricture? Anal stenosis or stricture is narrowing of either anal ring and or anal canal, which makes passage of stools difficult and if at all untreated causes morbidity. So there are so many causes. 90% of time post anal canal surgery the anal stenosis occurs. Most probably Dr. Mani is there. So this is a problem with open Milligan-Morgan procedure. Only one problem apart from pain. Otherwise that procedure is fantastic. The thing is that 10% of time you got other reasons like anal malignancy like squamous cell carcinoma, sometimes inadvertent trauma, IBD, Crohn's do cause anal stenosis, but mind well, this is a contraindication for anoplasty because Crohn's will always give rise to water can perineum and multiple fissulas. So don't try to do, even if it is stenosis, don't try to do anoplasty in Crohn's. Radiation therapy, other venereal diseases like gonorrhea, HIV, TB can lead to anal stenosis. I don't know, but it is given in the books that chronic drug abuse do cause anal stenosis. There are senior speakers here. I don't know, no personal experience of drug abuse like laxatives can cause anal stenosis, but there are few cases which is reported that migraine treating drug in a chronic constipation can cause anal stenosis. So why and what symptoms patient do come to you? Most important is constipation. Not constipation, you have to define constipation for that patient. Constipation is not by definition by Rome criteria. It is constipation for that patient. Whether it is passing stools or not, whether it is having difficulty in stools. See, coming stools after 3-4 days is a constipation by Rome criteria, but that not for that patient. So history is more important. What is mean by constipation for that particular patient? Most importantly, frequency. Frequency doesn't always means a loose stools or a diarrhea. Frequency do give a complaint by patient because he is not passing proper stools, he is passing infrequents. So that frequency is not like diarrhea, but it is a form stools, but patient need to go every frequently. The important thing is sometimes they do have a severe pain because they do tremendous pressure. And here we have discussed in the morning, the hourglass rectum can be seen on investigations. So painful defecation. Sometimes too much of pressure can cause a tear and cause a bleeding. Very rarely, and I have seen some patients with local trauma, injury and ulcers, and then after examination they have been diagnosed as anal stenosis because they try to do whatsoever maneuvering, they do put some amount of any sort of you can say a material or any sort of rod they want to get out of their stools. So sometimes I have got one patient who presented with bleeding, acute bleeding because of this forcible dilatation by himself. So how you will diagnose? Diagnosis is one is history taking. History you will always see that these patients have got multiple types of surgeries for hemorrhoids. So second thing is visual inspection. You will have to see that properly the perineum. Dr. Chute is there. He says surgeon who can diagnose so many things on finger, he should not rely on the investigation. Investigation is additional thing. Your finger is your diagnosis. So the thing is inspection. You can see the anal opening, whether tight. You can see that there is scarring nearby around in the perianal area. Important is what is digital rectal examination. That is the only criteria for the diagnosis. There are so many things on the literature and books has given. I can't do proctoscopic examination for my patients where I have done anoplasty, but it is the role I am still doubtful because I could not do a proctoscopic examination for the patient who has presented with anal stenosis. And anorectal manometry. I have never done anorectal manometry for anal stenosis unless patient has got other diseases apart from previous history of piles. So there are so many classifications depending upon the severity, depending upon the lesion where it is. So depending upon the severity, it is mild, moderate and severe. So what do you mean by mild? Tight anal canal, but it can be examined with a gloved finger or lubricated gloved finger, or a passable Hill-Ferguson retractor of a medium size, will call it as a mild. Moderate is forceful dilatation of a gloved index finger. So what here we can pass the medium size of Hill-Ferguson retractor with a pressure, but it is not possible on a OPD basis to pass a retractor. It's very painful. So a forcible entry of an index finger possible in a moderate thing. Severe you cannot put your even little finger, whether it is gloved, lubricated, whatsoever it is, and cannot do a PR rectal or digital rectal examination in a severe anal stenosis. Not even a smallest possible Hill-Ferguson retractor can go there. So depending upon the involvement of anal canal, so the stenosis is classified, as I said, depending upon the involvement of anal canal. Segmental or diaphragmatic, there is a thin strip of a contractile tissue or a fibrosis which leads to anal stenosis. This is especially seen in IBDs. Annular or ring type. What is meant by annular ring type is mostly traumatic or surgical, where anal stenosis is circular and annular at the ring only. Third thing is tubular, where you will see mostly post-surgical, mostly a major open hemorrhoidectomy, where there is loss of mucocutaneous junction in between the two segments of piles removal. So tubular is one of the thing which is very commonly seen in a post-open or multiple hemorrhoidectomies. The length of a tubular is more than 2 centimeter. Length of a ring type is less than 2 centimeter. So anal canal level, there is another classification for anal stenosis: low, mid and high. What is meant by low anal canal stenosis is below dentate line. 60% of patients, we are fortunate enough, they lie into this category. Mid, as just above the dentate line, 0.5 centimeters above the dentate line. It causes almost, it compresses around 18% of anal stenosis in the studies. High, it is more than 0.5 centimeters above the dentate line. So what are the treatment options? There are so many treatment options in the books. There are so many anoplasty flaps are given. There are VY plasty, there are U-shaped flap, there are S-shaped flap, there are house flaps, there are diamond flaps, there are mucosal advancement flaps. So there are so many details in that. There are few of them I'll just to see. But how you will treat? Not every patient requires a surgery. So what is the conservative surgery when you will offer? Only mild stenosis will be treated with a conservative treatment. Moderate and severe definitely will require a surgery. So what conservative treatment you like to give in a mild variety? One is stool softener. Whatever we are giving regularly is our bread and butter. With routine patients we give advice. Give us laxatives, give a high fiber diet, change of lifestyle, give adequate fluid intakes, and teach them self anal dilatation. So how you will tell them? You have got a Higgins dilator which is gradually increasing, they can do it. You have got a St. Mark's anal dilator, we have got 3, 4, 5 number. So in a mild stenosis you can teach them how to use the anal dilators and do a self-dilatation. If the self-dilatation is not possible, it is a mild thing, then we can go for a balloon dilatation as well. But if it is moderate variety and a severe variety, there is no choice for anoplasty. So there are some patients who can present with an acute obstruction like a malignancy. There you have to do a colostomy diversion, but it's very rare. And some patients, if at all they are operated squamous cell carcinoma of the anal cutaneous junction, that time you can do a coloanal anastomosis, but that time the incontinence is a little problem. So my topic is anoplasty. So as I told you, there are so many techniques. What I do, I'll just show you. So there are so many flaps: VY plasty, diamond flap, there is a household flap, and there is S-shaped flaps. So we'll just go ahead with what is my favorite is a diamond flap. So this is a patient in a prone position, severe anal stenosis. You can see there is a gradual dilatation of on table under anesthesia by Higgins dilator, because I could not put even my little finger for that patient. Just excising whatever the tags outside. How to go ahead? This is very important because there is no place to go in and find out the rectal canal. So you have to just excise the anal ring or cut the anal ring, put your finger, gloved finger, try to put a retractor. If it is not possible, you have to use your age-old instrument, that is forceps. Cut the anorectal ring on the forceps, make your finger to go inside to assess the anal canal. Then go ahead with the retractor, examine the anal canal, how far you have to release the anal stenosis, then cut the stricturous part, how much you cut till the anal canal dilates more than 2.5 centimeters. It is the importance, because once you do a flap, it is going to come down to little less. So to minimum 2.5 centimeters. Then you mark the area of a diamond. How will you decide the diamond? It is up to your length of the stricture and breadth of the stricture where you are cut. So you mark the diamond flap, and as Dr. Jitin showed a limbus flap, any flap is that you have to take care of it is vascularity. See, for once you put the retractor after dilatation and after cutting, you can just identify hypertrophied papillae here and there. Take care of that, examine under anesthesia before doing any flap. So whatever is you could not pre-operatively diagnose on digital examination, you will do under anesthesia examination, then you try to mobilize the flap. So Dr. Hate sir already tell minimum cautery, but I do for all my breast oncoplasty also, or any flap I use maximum cautery. But the thing is that flap should be digged perpendicularly, it should not be going on the converging side. So you should have a bulk to get the flap and to avoid the necrosis. So do a perpendicular dissection. As the time is short, I will just go little faster. So this is a complete mobilization of flap. You have to decide till what your flap is going up in deep inside, because you have to suture this to the elevated rectal mucosa. If your length is inadequate, you should not suture under tension. You have to properly mobilize. Say I have tried once, but I am feeling that it is inadequate, so I will mobilize little bit more. It's a bulk of a tissue, including the skin, subcutaneous tissue with a scarpus fascia as well. So this is I have not infiltrated anything, but mind well my cautery will giving you a complete bloodless field. Even the medial part I have just released because there is a cicatrization and fibrosis which was getting my flaps to go inside. So not only the flap mobilization is important is your rectal mucosa mobilization at the apex. So we have to do undermining for rectal mucosa so that we can do a easy stitching. There are few stay sutures we have taken. There are people who always say that you should take a long lasting suture. See, this is a rectal mucosa which is already undermined and mobilized. My apex of the flap will get sutured to the rectal mucosa. I don't use a delayed absorbable suture, because one patient I have used a PDS and it's very difficult to go inside and remove that PDS if patient has got a continuous pain or continuous feeling of that stitches. So after one or two cases I shifted myself to a monocrystal stitch. It lasts for 2 weeks. Any flaps, if it is less under tension, it will stay back there. The only thing here is a disadvantages for other flaps, because this is a forcible coming out. So always your stool will force that flap out. So that is the only disadvantage for anorectal flap rather than other flaps in the body. So we'll have to take care of flap. So that is why I said even Jiten's case that any flap will require a very good post-op care. That is more important rather than your technical care on table. Technically every flap will look very good on table. Mind well, this flap will also look 100% very well. But the thing is that when the pressure comes up, when the suture gives up, then the hiccup starts. You know, the hiccups, once you get yourself hiccup, then the patient hiccup starts. So you will have to always do a good post-op care. So this is the suturing. It is a mattress suture. This is a monocryl. No need to remove. The flap should be very much under less tension. Sorry. Once you suture the flap, you will have to suture the remaining raw area, and this is the, I will show you the end. The important is that every bite of your inner suture should involve the rectal mucosa, otherwise the flap will not stay there. So I will skip this. This is just a closure. So what is important is after doing a complete flap, your retractor should go very smoothly, because before surgery our finger was also not going, even dilator was not going. Now after surgery minimum 2.5 centimeter of your retractor goes very easily. You can see the rectal mucosa very nicely sutured to the flap. Sometimes some people do bilateral flaps. If it is severe stenosis or failure of one-sided flap, people do bilateral flaps. I don't have a personal experience of bilateral flap, but one of my friend has shared his images. Dr. Abdullah Mamun is from Dhaka. So he has done a bilateral flap. So if it is too much of severe stenosis and failure of one flap, sometimes primarily people do bilateral flaps also. So what are the complications? Any flap related complications are always there, and here the more, as I told you, is all related to flaps. So what is required is post-op care. Post-op care is that patient should not strain too much. Patient should do a regular lubrication of the area with a gloved finger and self-dilatation. Wound morbidity is one of the important thing. Flap necrosis, stitches giving way, as it is the soiling area, infection is very common. So cleaning of the area is important. Flap necrosis is one of the biggest problem, but mind well, if at all you are having a tensionless flap, even if the partial flap necrosis is there, epithelialization takes care, and the patient who is having less than a little finger, he will be happy with at least 1.5 centimeter because his problem is solved. Though your dilatation was 2.5 centimeter and ultimately it has come to 1.5 or 1.7, it's okay. So recurrence is a one important thing. I got very few series of 8 to 10 cases, but the thing is that mind will everybody is till now happy. There are few patients who has got a follow-up of almost 1.5 years, but I have advised them personally, there is no data, that you should do at least once in a day manual Hagas dilatation of number 5, manual dilatation up to 5 number of anal dilator for at least 6 months to 1 year. That is what my protocol for every patient. They should do dilatation after suture removal every day, morning, evening, night. That is the way you do for your seeds bath also sometimes. So it is a religious procedure. It is not that you are done the things, fibrosis will occur again, the patient may have some stenosis again. So if at all it is like a urethral dilatation, you have to give a dilatation regularly in spite of your surgery. So primarily they will do first 3 months thrice in a day, then next 3 months twice in a day, then next 3 months once in a day, or like that they have to do at least for 1 year. Thank you everyone. Thank you for patient hearing. Any questions I'll like to have, I'll be happy to answer. Yeah.
Very excellent video. I have also operated around 6 cases, and I feel in 2 cases I had a seroma at the lateral angle of the flap, and later on one patient had got infected and again resuturing has been done. So you like to put a Godrej or any small?
I don't put any drains. The only thing, if you observe your patient, that must be a female patient with a big subcutaneous fat. Am I right? Or it's a male patient without sweat?
Male patient.
So the thing is that if at all you bury the properly suturing, I do a serum subcutaneous dermal fascia to fascia suturing. I don't involve a fat in any surgical closure. And then a lateral angle, what you said, it's a dead space you need to ablate. There you have to do a facial subcutaneous facial suturing and then a skin, not directly skin. I have never used a drain and not encountered any seroma. Though we are selling in the same boat, you have got 6 cases, I got 8 to 10.
Dr. Hemant, nice presentation.
Yeah, thank you.
This thing,
one more question or suggestion.
Yeah.
We used to do the laterally another side. If we are doing the 3 o'clock flap, then we used to do a 9 o'clock release incision. So it will get good benefit. So that is we are doing.
See, for the why it will never get benefit. It will create a problem for your flap. We have created a raw area, but we have covered with epithelium or a skin. You are creating a raw area, but not getting covered. That is the cause for stenosis. Why the stenosis occur? Because we are not leaving a mucocutaneous junction adequately. You are creating again raw area, which will give a fibrosis. So the fibrosis which has already there, you are cutting it, but will giving rise to a more fibrosis, and it will compromise your dilatation of the flap. So never do that release incision. If you want to do a release incision, do a flap there as well. If you feel that it is not adequately open up, because we need a cover. Why we need a cover? That fibrosis should not occur again. There should be barrier.
Do you do sphincterectomy at the site of the flap?
No.
Internal sphincter fibrosis?
See, the thing is that there is another thing. In a mild cases, we can get away with the lateral anal sphincterotomy also. If a mild stenosis, we can do only a sphincterotomy. That is what I said. The second thing, what is your question, is that whether I do sphincterotomy in association with my plasty. I never do it, because I just want to excise the cicatrized or fibrous tissue which is giving rise to a problem. There is no problem with the hypertonicity of the patient's sphincter. So sphincter is not at a fault, and sphincter will give a release only with the pressure, because sphincter has become hypertonic that time in a fissure because of pain. Here the sphincter is not hypertonic, the cause is cicatricial tissue. We have to excise the tissue, put a barrier, that will solve a problem.
Yeah.
Thank you.
Thank you. Thank you.
Presentation, Dr.
Hemant.
Nice presentation indeed. May I call Dr. Ladukar sir for the next presentation? He'll be talking about perineuropathy for incontinence. Dr. Hemant was tightening the anus, and he was releasing the anus, and Dr. Ladukar is going to tighten it. And Dr. Ladukar is a well-known figure. He is a ISCP, International Society of Coloproctology, and he has got a huge practice near the Nagpur. Dr. Ladukar.
Yes. Actually, we were here to have a operative workshop. It has been delayed, and for that, huge congrats to Dr. Jiten Chaudhary, who has in a very short time he has arranged this, and same is a part of any of the conferences, and to have some theoretical knowledge, we want to that. Today I am to discuss this perineuropathy, which is a very not a common topic for the anorectal surgeon, but it is the complications which occur in rural area because of many of the patients. They are conducted, the labors are conducted by the untrained people, mostly the eyes, and then the third or fourth degree perineal tear occurs, and then the life of the person becomes absolutely miserable. And with that, we are planning to have what is the normal perineal structural anatomy, how to define the perineal tear, and then repair of the perineal tear in anal incontinence. These are my few of the objectives that we know. Everybody knows it, how and where the location of the possible episiotomy should be given, so that the perineum would be normalized, there won't be any perineal tear. So proper position of the episiotomy and the labor conducted by a trained person is essential to avoid the perineal tear. Superficially, if you see the perineum, superficial, because there is superficial area deep and the very deep when we go into the peritoneum. So superficially, these are the important muscles called as bulbocavernosus muscle and the transverse perineum muscle, and the midway in between there is anus and the vagina, and there is a part which is called as perineal body. Whenever there is a perineal tear, there is absolute loss or damage to the perineal body. Once there is loss to the perineal body, this vagina and the anus, they will come very close together. Sometimes there will be only a membrane, just like a mucous membrane. That is the complete 4th degree perineal tear. And then the patient suffers from two things. One is there is dyspareunia, rather there is a total laxity of the vaginal wall, And secondly, then if the more muscles of the external sphincter they are torn, then patients will have anal incontinence. So the life of the person becomes much miserable. If you see this, if you see the perineum from downwards, there is what we are accomplished with, what we know is where there is pubic symphysis, there is ischial tuberosities bilaterally, and there is a sacrum where the sacrospinous ligament is there. Now this is a deep portion. Now the previous slides where we have seen it was a superficial position, superficial perineum. Now we are going into the deep, and now when we are here, we are seeing that if you know the anatomy, anatomical structures are very important, because from the pubis there are three muscles, the levator ana starts, and that is some of the modifications of the pubis, the levator ana. They are from puborectalis, pubovaginalis, and pubococcygeus downwards. These are the two. This slide we are less interested in this slide, but it was important as the first slide where the pubococcygeus was there. Now this will tell you something about what is bulbospongiasis muscle, how the perineal body is there, how the ischial tuberosities are situated laterally, and there are three muscles: iliococcygeus, pubococcygeus, and puborectalis. And downward is the gluteus maximus muscle. This anatomy is very important in going for the repair of the perineal tear. You must know which muscle lies. This is the same thing which is again picturized, how the perineal body is formed and which muscles are to be actually they are brought together to form a perineal body. I will be telling everything in detail when we are dealing with it. The same thing again where the superficial transverse perineal muscle is there, where the perineal membrane is there, how the external sphincter, anal sphincter look like, and how what is the now the levator ana is below downwards. Now the same thing again. I will just keep up this video. The overall incidence is the in UK is 2.9%, is in India it is more than 6%, 6 to 8%. With an incidence of 6.1% in primipary compared with 1.7% in multipary. If a perineal tear which occurs at the time of the labor, it should be repaired at once, at the time of labor itself. If that circular muscle, that the sphincter is seen, so that it is a third degree perineal tear is there, bilateral muscles are cut, at the same juncture you have to repair the muscles and you have to repair the sphincter. This is at the time of the labor itself. It will avoid so many of the future consequences. Now when we describe that what is obstetric anal sphincter injury, which includes both third and fourth degree perineal tear, it is because of the mismanaged second degree labor that we all know. The overall risk of obstetric anal sphincter injury as quoted in the literature is 1% of all vaginal deliveries. It is more than that in India. It's an occult injury and it occurs because of the overstretching of the perineum, rapid stretching of the perineum, and the part which is inelastic perineum, where it is, and wrongly performed episiotomies. How it occurs, everybody knows it. During labor, stages of labor, and how it occurs. Now anal incontinence, which is defined as an involuntary loss of the feces, flatus or urge incontinence that is adversely affecting the woman's quality of life. And up to 40% of the women with third or fourth degree perineal tear during childbirth suffer from anal incontinence. In rural India, where we live, where we operate, there are many of the patients, when the patients come up after 6 or 10 years, we find that they have got third or fourth degree perineal tear. Now, as far as the classification goes, first degree injury of the perineal skin, second degree is up to the perineum involving perineal muscles, third degree is having internal anal sphincter injury, and fourth degree injury to perineum involving the anal sphincter complex and anal epithelium. Fourth degree injury is very dangerous. in some of the patients, those come after 4th-degree perineal injury, after 6 or 8 months, there is a real challenge for us. Now you see, in 4th degree, epithelium is also damaged, anal sphincter is damaged, and these are some of the pictures when you see that post-parchment tear causing incontinence, and the patient is having incontinence for anal incontinence and vaginal incontinence also. Flabbiness is there, the whole of the sexual interest of the man is lost, and the patient comes up to the level of the divorce. There is always a problem who will face this patient. If it is caused by an obstetrician, who will repair it? Either it should be repaired by the obstetrician or a surgeon. But basically, if we are in this as a colorectal surgeon, we can do it better. When the injury occurs at the time of the injury, at the time the repair can be done, and repair can be of the external anal sphincter. This is of two methods. Where the internal anal sphincter is identified, it is advisable to repair separately with interrupted sutures. Repair of 3rd and 4th degree tears should be conducted in an operating theatre. I have taken some pictures of the videos when the 3rd degree perineal tear occurred at the time of labor. How it should be repaired? You should repair from downward. You should come from below upward, so that you should anal mucosa to be repaired first, then bilateral muscles, and then you should come to the vaginal wall afterwards. So at the time itself, we can repair the perineum, and the injury can be avoided. But now, when we talk about the perineorrhaphy, it is the obvious injury to the perineum with loss of perineal body, causing fecal incontinence and vaginal flabbiness. The digital rectal examination is must to see the tone of the external anal sphincter. Every patient cannot be subjected for anal manometry. And manometry and ultrasound examination is preferred if it is available. And for this patient specifically, bowel preparation 12 hours before surgery is essential, because after doing perineorrhaphy, patient should not pass, patient should not strain, patient should not sit for the defecation, so that your stitches would be there in the position. So bowel preparation for this patient is a must. After all, even for hemorrhoidectomy, for prolapse, we prefer bowel preparation, but there we don't put on the stitches. But here, this is completely plastic repair. Here one has to take care that bowel preparation should be very adequately done. I have done so many of the procedures, but this appears to be good. Patient under regional or general anesthesia. Now you see, patient is in lithotomy position, and there is an anovaginal junction where this is not moving actually. Now you can see there is only anovaginal junction. Now at this juncture, I instill the saline with adrenaline to have a complete hemostatic, to have a bloodless surgery, and it also gives us a plane where to put a knife, so that sometimes there is such a thin wall of 1 or 2 mm. So this installation of the saline will give you a plane. Actually, the surgery is in a way to pull up the posterior vaginal wall. Posterior vaginal wall to be pulled up, and the remaining portion which was torn in, we have to go laterally, and you have to see for the muscles. Go deep down up to 2 inches. You should go inside. Now whatever there is lifting of the posterior vaginal wall, and now the remaining muscle structure which is there, now you have to identify where the levator ani muscle is. The levator ani muscle bringing into the midline is just forming a perineal body. It will tighten the space. Now whatever the
if it is dilated, whole of the anal mucosa is dilated, this anus is dilated, that is trimmed out. Now you see, the anus is, it is constricted by giving these stitches. This is not mandatory for every patient. This is not a mandatory step for this operation. But if at all the anal canal is much dilated or patient is having much anal incontinence, this can be shortened. So suture to the anal canal. You have to bring down the diameter of the anal canal. Now after this, we have to identify which are the muscles which were torn off 6 or 2 years ago. All the muscles, they are laterally, they are actually pulled out. You have to dissect out laterally, and you have to see for the muscles, group of the muscles. Now you can very easily identify which is the levator ani. Once you go posteriorly, once you lift the posterior vaginal wall, you can definitely go to the level of the levator ani. So levator ani, first plication of the levator ani in the midline will form a perineal body. But not only that, you have to go up to the all sphincter muscles, those which were torn. So now you have to identify the muscles. This is plication of the, we will be plicating the levator ani in midline. Now from levator ani, from downwards, you have to come about up to the skin level. So whatever the muscles, those who are there laterally, but the splitted part of the muscle, those who are very fibrous part of the muscles, we have to bring it and close it down. So your dissection starts from below to upwards. Now you see, then you come to the torn muscle complex of the external anal sphincter, the last one, that is external anal sphincter. Now here, this finishes the actual surgical part of the procedure. Once you come down to the external sphincter, then only the superficial transverse perineal muscles, they are to be plicated. The complication while doing this surgery is when you are lifting the posterior vaginal wall, sometimes you may be very close to the vaginal wall, sometimes it may be torn out. So that plane of dissection to be done while lifting the posterior vaginal wall, that is very important, and if with the aqueous dissection it becomes easy. Instill the saline and this vaginal wall can be lifted very easily. Now what are the remaining portions of the muscles we are tying, so now with this much of the midline, bringing of those muscles in midline, you create a space in between the vagina and the rectum. This is how the perineal body is constructed. With this external sphincter bringing together, the continence mechanism of the anus is improved, and whatever the flabbiness of the vagina was there, that is also trimmed off, and that is the very small diameter vagina is created. That is, if it is done wrongly, then there will be stricture of the vagina also. This is a possible complication. Another thing which is very important in this case is, because patient is to sit for defecation in lithotomy or in the normal usual position, these sutures, they sometimes give up. If infection occurs at this area, there will be complete opening of the wound. So we have to start with, I started with the Vicryl 2.0, but later on I shifted to PDS 2.0, because these sutures should be there for at least 2 months. So there will be good amount of fixation, strengthening of the muscles. This later on, once I tried to develop it, many of the patients I operated, at 10 cases till date I have done,
and every case is doing finely. Now we close, we come to the last layer of this suture, that is skin is closed. Now you see, if you see I will show some of the pictures, how the previously it was pre-operatively and how it looks post-operatively. So it is a good surgery to look, and the results of the surgery are too nice. With proper post-operative follow-up and perioperative instructions and care, because perioperative instruction and care is very important. The results were evaluated after 1.5 months. Vicryl 2.0 were initially used, but because of it gives away infection at wound site in earlier 3 cases, but the wounds were normal with good strength by PDS 2.0. Out of 31 cases, 26 cases, this 8 cases I operated within 6 months lastly. 26 cases improved for anal incontinence, and 2 cases had developed dyspareunia due to shortening of vagina and too tight a closure of levator ani. This is a complication which occurs. Only 1 case had developed vaginal tightening and partial continence. This before surgery, how it was looking now, there you can see how the only one lining is there seen. There is no space in between the vagina and the rectum. And after surgery, how the result was that is in front of you. This was just after this surgery. How preoperative that patient which I was shown, preoperative there is no space in between. Postoperative there is a formation of the perineal body, a good space is being created. This is again, this is for that on-table perineal tear. Preoperative cases, this was again a very good case having this chronic issue for last so many years. Preoperative, postoperative pictures are there. You see, after 1 month, there was a normal perineal anatomy was formed after 1 month. Patients are doing fine. Under some of the early cases, I used to keep our drain, then I avoided it. But after 1 month, the picture was good. So how it looks? If you see for the normal anatomy showing perineal body and rectovaginal septum, this is in between. Pointer. But this is a rectovaginal septum. When perineal tear before surgery, there is no rectovaginal. This is a vagina and this is an anal region. So there is no septum. Normally this septum is there in between. And after the perineal body construction surgery, there is now, this is vagina and this is a rectum, and this perineal septum, this is CD. Yes, this is the rectovaginal septum. This is created. This normal anatomy is created. What is postoperative measures are daily wound care, antibiotics and anti-inflammatory drugs with laxatives. Avoid strenuous activities for a month. This was another approach. This is given in Corman. I never tried it, but it also seems to be good. Only lifting of the posterior vaginal wall and bringing the 2 flaps from the either side. This is also good. Obstetric perineal injury is having disastrous trauma if neglected in early postpartum period. Carefully assisted delivery with mediolateral episiotomy can avoid perineal injury. Early repair of perineal tear is easy in identifying the structures, and it does not lead to gross trauma to perineal body. Meticulous case selection with evaluation of vaginal and anal symptoms, and to decide the grade of perineal tear before surgery is mandatory. Results of perineography improves the fecal incontinence. Thank you very much, though it was prolonged. The cases today is, there is no the 4th-degree case, otherwise we could have shown it. Thank you very much. Next one.
You got a lot of experience, but for the beginners who are in the hall, pre-operative perineal ultrasound to locate the levator ani or sphincters, how is it mandatory, how it is helpful? That is one thing. Second, I'll talk. Pre-operative ultrasound for marking. Is it helpful?
Yes, it is helpful. It is helpful, definitely.
beginners, I think so.
And perineal ultrasound, nowadays it should be, now the radiologists are doing quite nicely.
Yeah.
Perineal ultrasound helps in so many ways, not only in this way, in location of the, not only the muscles, but in locating the tract of the chronic fistula also.
Yeah, yeah.
So perineal ultrasound, it is comparable with the results of the MRI.
Definitely. Second thing, any tips to the beginners, if at all no intra-op ultrasound or perineal ultrasound has been done, how to identify the muscles? How lateral they should go?
This, it is how one should lift the posterior vaginal wall first. That is the first thing what is to be done very nicely.
That is lifted up, but how
that is,
they will identify the
and
muscle?
then you have to go laterally. Laterally, when you go laterally, it should be around, if you go 1.5 inches, it should go laterally. Laterally.
I'll share my tip because I
Yes.
got few rectovaginal fistula total feces coming from the vagina immediately after third or fourth day of episiotomy. What I used to do is I use a cautery to twitch the tissues.
To have the
Whenever you will see that twitching, that is a muscle.
That
there
is
you
the
should
muscle.
stop. And don't tighten too much of sutures because it is already under pressure. If you take a too tight sutures, it will definitely give way.
Give way.
Make it a loose. Even if 1 millimeter or 1.5
Approximation
millimeter,
only.
just
Yes,
approximation is needed. That's all.
Thank you.
Hello. तो ऊपर ना क्या कर रहे हैं जैसे पहला एक केस लेना प्रोडक्ट का और साथ में दोनों उड़े करनी चाहिए हाँ मैं क्या कर रहे हैं आपका
आपका ये क्या है? टेक्नोलॉजी प्रॉक्टोलॉजी।
हेलो नेक्स्ट टॉक सर के बंद कर लेते हैं शैलेश्वर सर ही इज एचओडी ऑफ थाने इज नेक्स्ट टॉक राहता सर से पहले ले लेंगे हेलो हाँ या व्हाट इज देयर सी वी आर रनिंग शॉर्ट ऑफ टाइम तो लाइक डॉक्टर राहते सर विल टॉक अबाउट फिश लाइन नैनो while operating on a fish line nano. Is it okay, Rahate sir?
Yes, yes.
Okay. Now, Dr. Shailesh, may I call Dr. Shaileshwar sir? He is HOD at Kalwa Hospital, Thane. He'll be talking about recurrent fish line nano.
Pen drive, right? No, pen drive.
Yes, sir.
Oh yeah. Yeah, वही ठीक है कौन सा 10 है आएगा इसमें विल गेट द नोट्स आल्सो नोट आएगा इसमें नोट्स नहीं आएगा कौन सा पूरा प्रेजेंटेशन ठीक है चलेगा नो प्रॉब्लम या Good afternoon. I think everybody is now very much keen on the surgical aspect now, on the operative workshop. I will not go too much into it because I am not going to go into operative session at all if recurrent fistula in I am going to just give a small overview of how recurrence occurs and why it should occur or why it occurs first of all. All of us know operating a fistula is always a nightmare for most of us or even all of us, whether it be a first time operation or a recurrent fistula operation. Even for the first time when we operate, we are always dreading that it should not recur. It is a condition that involves the anal region. It is very common. We have seen lots of fistula. In fact, in our OTs, we have one fistula or two fistulas every OT in our general hospital. But yet it is very debilitating, It is very, depressing for the patient to come again and again for some discharge and for pain around the anus. So it's always a challenge to operate on a fistula, especially if they are complex type of fistulas. Recurrent fistulas are more challenging because the chances of re-recurrence is more. The more the recurrence, the more the re-recurrence occurs, and therefore they are more challenging. And not only that, the more you operate on the fistulas, the more chances of continence getting disturbed. That means patient getting incontinence are always a high chance. Now this operating on a recurrent fistula is always challenging since it renders the complete eradication of the fistular tract associated with considerable risk of continence impairment. On the other hand, failure to excise the primary tract and its secondary extensions and to drain sepsis adequately may eventually result in persistence or recurrence of the anal fistula. Especially after previous fistula surgery, the anatomy is disturbed and that one cannot address the cause of the recurrence. If we do not address the cause of recurrence, always there is a re-recurrence, and also we have difficulty in navigating or operating on a probably altered anatomy which may be present because of the previous surgery. Now what do we define as a recurrence? What are the various risk factors that are associated with this recurrence? What are the problems associated with management of recurrent fistulas? And how do you assess and treat these recurrent fistulas? When we talk of recurrence, first of all, we must know what is the success of anal fistula surgery. When we talk of success, we mean that there is always complete healing of the wound that we create following a fistula surgery. Then there is total obliteration of the tract that has been formed. There is no internal or external opening at the end of surgery, and at the same time there is no discharge for a continuous period of time following the surgery, at least for 6 months. Because when we talk of failure of the surgery, we say that it may be either a persistence of the fistula post-operatively. That means the fistula doesn't heal. It keeps on persisting and persists. There is always a continuous discharge for more than 3 months after the surgery also. That means it is a persistence and there is a failure of that surgery. Recurrence is when we talk of the appearance of the fistula again after the complete healing of the wound. And complete healing may take anywhere between 4 to 6 weeks or even up to 3 months. We can give timing for the complete healing of the fistula wound, because some fistulas, when we lay open, it is a complex fistula which we lay open, takes a longer time to heal by secondary intention. And de novo, that means the new appearance of fistula recurrence is usually after most probably a year of the previous surgery that has been done. Now what are the various risk factors that we are considering while we are considering the recurrence in fistula in Most of the time it is a preoperative consideration that we have to see when we operate on a fistula, because anatomical considerations of the fistula are more important. What are these anatomical considerations? We will see in a short time. Of course, presence of comorbidities along with the fistula is always a predictive factor for recurrence of the fistula. Intraoperatively also there are problems which may occur while dealing with the fistula, and these also can predict whether we will get a recurrence or not, or whether patient develops a recurrence later or not. Post-operatively, as such, there is not much of a problem because post-operative care is very important. If post-operative care is not taken well, then chances of recurrence can occur, and it usually depends on the patient. No. No. All of us have seen this, and all of us know about the classification of this fistulae. Now, most of the time, when there is a superficial fistula, a transsphincteric fistula which is subcutaneous, which is not very deep, or an intersphincteric fistula which is not very deep, are not very commonly does not commonly lead to recurrence if done properly and if done without any complication. However, extrasphincteric fistula and high suprasphincteric fistula are very common, and they recur quite frequently. The percentage of recurrence in these fistula are quite high. Or sometimes you have anatomically problems like multiple openings. You have got openings like horseshoe fistula, or openings on either side of the anus, or multiple openings from single side, where we are not sure how the tract is going to be, whether it is going to be a straight, simple forward, simple straight tract, or it's going to be a curvilinear horseshoe shaped tract, or it's going to be a tract which is leading high up into the perianal region. Now, this was a case where we did a multiple fistula which was recurred, and then we had to put in a seton afterward for a long time, so that some part of it at least healed, and finally we found out that it was a tuberculous type of disease. That was a tuberculous fistula. Now, a single fistula tract is usually easier to deal with, but with secondary extensions over to the supralevator, infralevator, or ischioanal may be missed during the surgery, and thus persistence or recurrence of anal fistula may ultimately supervene. The pathology of anal fistula plays a fundamental role in determining the outcome of the treatment. Anal fistula is secondary to specific diseases such as Cox, which is very quite common in our country, Crohn's disease, are more susceptible to persistence or recurrence after surgical treatment. So, these are the patients which we will expect that there will be recurrent fistula. Now, the other thing that we must do is, when we are dealing with fistula and ano, to prevent recurrence, is a detailed preoperative, detailed proctological examination that we must do. Many a time we find that fistulas we just see on the table, especially as senior surgeons, if the residents are seeing the fistula in the OPD, and then they ask us to operate later on, we see that on the table we find something different. So, a preoperative detailed proctological examination is must. Not only physically, but with per rectal digital examination to find out where the internal opening is, how high the internal opening is, if possible. Also, if we can feel the tract along the fistula. If nowadays our residents are so smart that they, even before showing us, they get the MRI done, because it is so commonly available. So, even before they examine, they don't examine also many a time. They just send the patient for MRI, and then when the patient comes with MRI with a complex this thing, they show to the seniors. That is a big problem, but MRI is a good investigative tool to find out if there is a chance that patient may get a recurrence in future. Endo-anal ultrasound is also possible, but it's not done very commonly in many places, and therefore is not available so easily. Of course, presence of comorbidities like diabetes, tuberculosis, Crohn's, or immunosuppressive drugs, or patient of HIV, these patients are more likely to get recurrence rather than patients who are stable. Now, what are the various intraoperative factors? Now, most commonly intraoperatively, when we try to operate the patient, the first thing that we do is to see that we identify the internal opening. And the importance of identifying the internal opening cannot be more highlighted. If the internal opening is not detected properly, then chances of recurrence are high. And how do we detect this internal opening? Most of the time, most of us use some sort of a dye, that is methylene blue we use. By injecting methylene blue outside from the external opening, you see for the internal opening. Or we can use even betadine with hydrogen peroxide, where we can see the internal opening, which will show the dye coming in. But sometimes we do try to probe the fistula. You know, when we try to probe the fistula, if the probe goes in easily without any tension or without any pressure, without any force, then it is okay. Then we do come out from the internal opening. But many a times we see that we give some sort of a pressure and then we create some false passage, and that false passage will lead to secondary fistula, and therefore it may lead to recurrence later on. The second thing is when we are doing a simple fistula. Yes, we may do a total fistulectomy, but at the same time we may miss a small secondary tract which may be going up into the intersphincteric area or suprasphincteric area, or there may be an underlying abscess which we may miss, and this can lead to recurrence. Thirdly, procedure. No, when we talk of procedure, we have so many procedures are available for dealing with fistula, starting from laying open the fistula like fistulotomy to fistulectomy to the various recent ones like laser and waft and plug and glue. It is the selection of the procedure for every fistula that is very important, because wrong procedure to a fistula can lead to recurrence later on. And one study has found that you can find that every procedure has got some amount of recurrence or is there with every procedure. It's not that any procedure is 100% non-recurrent. Of course, finally, experience of the surgeon is important. A beginner may cause to miss the tract, miss the abscess, miss secondary extensions, and as the surgeon improves his surgery and as the experience improves, the chances of recurrence also decreases. Now, what are the post-operative facts? Post-operative factors are mostly lying with the patient. Usually a normal wound takes 4 to 6 weeks to heal. If it is a small fistulotomy that is there, perianal region. But for a large wound with multiple openings and with multiple fistulectomies, it can take up to 3 months to heal. So it is during this time that one must take care to see that proper hygiene is maintained. Because of the area that is there, though it is very difficult for the hygiene to be maintained, but you must see that the patient is advised to maintain proper hygiene by good amount of washing. Seeds bath is one very good indication, a very good method to keep the hygiene of the patient for 4 to 6 weeks. You can give plain hot water bath, or you can advise the patient to use any solution or even potassium permanganate along with the hot water. If there is a ceton which is put, this requires more care, because since there is a foreign body there, so chances of the feces being stuck there, feces being it can lead to infection, and therefore chances of recurrence even when you put a ceton afterwards can occur. So this is very important that you see that patient takes good care, and when he will take good care, when you call him for good follow-up every time, you see that you give a good follow-up once a week at least, so that you find that he is taking good care of his wound. Now, why are the recurrent anal fistulas challenging? Naturally, the first time we operate a fistula, we are not much bothered, especially if it is a simple fistula. But the moment the patient comes back to you again with same complaint, saying that, sir, this is not healed and I am still getting discharge, I am still getting pain, then the problem starts. Because the moment you want to operate on a recurrent fistula, there is always a chance that there will be re-recurrence. So that is why this is very challenging. And then second is, you may create a situation where the patient may have some amount of incontinence. Now, when these recurrent fistulas come, how do you assess them and what do you assess? First thing is, you must identify the cause of the recurrence, why this recurrence has occurred. And for this, you will have to take a proper detailed history to find out when he was operated, how he was operated, who was operated, and whether there was any problem during the surgery, and what about post-operative conditions. The second thing is to recognize the anatomy of the fistula. And this can be done by a proper physical examination and of course investigations. And thirdly is to evaluate the continence state, that means how continent the patient is. Preoperative assessment with ultrasound, endoanal ultrasound or MRI can be done so that you can get a fair idea of the continence as well as the tract of the fistula, how far the tract is going. Now treatment strategy is first and foremost you must address the cause of the recurrence. If the cause is because of some tuberculosis or because of Crohn's, you must see that that disease is treated first, so that if you operate on the patient again, it doesn't recur. So see that the patient either undergoes complete treatment for tuberculosis or at least is under the treatment of tuberculosis for a sufficient period of time before you take up the patient for surgery. And also see that his comorbidities are taken care of properly before you take up the surgery for recurrence of fistula. And then you surgical treatment, what type of surgical treatment you will do. Of course I am not going to details of the various surgical treatment. Surgical treatment will depend on what type of recurrence it is, how much recurrence, what is the stage of recurrence, that means how far the opening is from the anal verge, and therefore you can decide on the various types of surgery. So in conclusion is that recurrent anal fistula is a very challenging situation, not only for the beginner but for even the experienced surgeon. Though assessment of the patient to decipher the cause of the recurrence and address it, that is very important. Surgical treatment of recurrent anal fistula is usually associated with higher incidence of re-recurrence and potential compromise of the continence state, and therefore it must be properly explained to the patient before you take up surgery for recurrent anal fistula. And sufficient experience with treatment of anal fistula is absolutely necessary for the adequate management of recurrent anal fistula. Otherwise, it's going to be a most difficult problem for the surgeon facing the patient. Thank you very much. Questions you want, you can ask. I don't think there is any question because it's a very, very difficult topic in the sense recurrent fistula itself is the most nightmare for the surgeon.
Thank you, Dr. Shaileshwar, sir. We have got next speaker, Dr. Ramesh, sir. Technology and proctology. Over to you, sir. Thank you.
So the topic is I bring warm greetings from Warangal, the city of Kakatiya Kingdom. So we are living this era of fourth industrial revolution. A new surgical technology that offers promise of improved patient care is attractive. So whenever coloproctology sessions are going on, most of the times there is a lot of debate regarding new technology, whether it is really improving patient outcomes, whether it is safe or not. So in these days of technological explosion, it is highly important to understand the advantages of this new technology, and we should apply this judiciously for better patient outcomes. So rapid application of new technologies resulted in certain complications, and these complications are never reported in literature. So it is highly important that complication can happen even in the hands of surgeons who have got experience in open surgery or conventional surgery. A good surgeon doesn't just concentrate on technique or technology, but also on appropriateness of what you are doing. So nowadays, when a surgeon acquires a technology, he is trying to apply, irrespective of patient pathology, whether this particular technology is suitable for disease. So this is resulting in bad outcomes and complications. So perineum is the most precious and most private and most important aspect, and it is very important to concentrate, understand the anatomy, and give better outcome before treating any disease. So when new technology, it is described wolf in the goose of lamb. The technology appears attractive, simple, safe, but there is a danger in applying improperly without judicious application in wrong indications. So all surgeons who are taking up new technology in the beginning should be careful not to ruin their practice. So all these days, in the beginning surgery was unsafe. There was a lot of morbidity and mortality due to surgery. But due to different innovations, now surgery has become safe. Since last 10-15 years, we are going through a different phase that the safe surgery is becoming unsafe. Let us take the example of stapler causing sepsis due to anastomotic leak. There are certain complications which are never described in coloproctology happening due to new techniques. So are we becoming unsafe? Safe surgery becoming unsafe in this era of technological explosion? We have to question. So should complication occur during evolution of new technology? The very common phenomena in surgical sessions, we think complications are part and parcel of surgical practice. But we have to find a way to see that complication will not occur while we are applying this new technology in our practice. So we are living in the era of fourth industrial revolution. Now patients are having high expectation. The time is very important. Due to new technology, patients are expecting they will recover from the disease early and they want to go back to work as early as possible. If there is unexpected complication due to this new technology, the patient is not at all mentally prepared and it is very difficult to convince them. So these are the conventional armamentarium, which is very simple, but there are certain morbidities, delayed recovery. Why minimal invasive procedures are becoming very popular? So these are the advantages of new technology or techniques which are minimally invasive. There are no cuts, no suturing. This is what patient want, like stapler, laser, digihole. This is where we are doing surgery most of the times inside the anal canal without any incision in the perineum. So current status, scope of new technology. While we are discussing new techniques, they are not taking care of all categories of pathology. Suppose you take example, hemorrhoids. Grade 1 most of the time will manage conservatively. Grade 2, mostly laser will suitable. Grade 3, stapler or Chevardez procedure is best. Whereas grade 4, conventional open technique is the only solution. So one technology is not going to take care of all the pathologies. But presently what is happening is, once somebody is familiar with stapler, he is trying to do stapler for every grade of hemorrhoids. Once somebody is familiar having laser in hand, they are going to apply laser in all cases, irrespective of thinking which category of hemorrhoid is suitable for that particular technology. Are we limiting to the indications? No, that what is happening. So these are the limitations of new technology, that will not take care of all the pathologies. Still conventional surgery has a role. So we take example laser in fistula. There are certain indications, only certain category of fistulas, straight track, simple fistulas can be taken care by laser. So new surgical technology, we have to learn how to balance the safety and outcome. Unless we balance these two things, the outcomes are going to be disastrous. So traditional versus conventional. Advanced technology is exciting and attractive. So most of the younger generation, they want to take up this new technology in their clinical practice. So these are the prevailing armamentarium: laser, stapler, Digi-Hall, waft. So many new techniques are coming to deal with fissure, fistula and hemorrhoids. So adoption of new technology. Whenever new technology comes into picture, the surgeons are divided into 4 categories. There are over-enthusiastic people who want to adopt this new technology as early as possible without understanding, without mastering the technique. There are surgeons who are in always confused state whether to really take up or not. The third category is surgeons who are judicious in taking up the technology. There are surgeons who never want to take up new technology. They want to continue their conventional surgical techniques. So these are the 4 categories we are divided into. So surgical procedure should be tailored to the individual patients. In reality, the choice of surgical technique is often based on surgeon's experience, preference or availability of technology. As I said, because we are having laser machine, we may be trying to fit all cases into laser. Or somebody who is expertise in stapler, he may be trying to do stapler for all cases. Ideally, stapler is better technique whenever there is a prolapse of mucosa, circumferential hemorrhoids. If we are trying to do stapler for grade 1 hemorrhoids or early disease, because there is no prolapse, it may be technically difficult and outcome may not be good. So, whenever we are adopting technology, these are the types. Early adopters will be taking early majority, late majority, and those who are going to reject it. New technique is not necessarily a better one. So there are critical dynamics in adoption and diffusion of new technology. These are the 3 important players: patient, surgeon, and the industry. Patient always crazy about the new technique, imagining that it's always going to be better. Surgeon, image of advancement. Today's practice of proctology, somebody is not talking about laser, patient will think he is not a surgeon to be approached. So we are forced to say that we are doing laser for anorectal procedures. So this is a image of advancing in that particular field. Unless you are taking new technology into your practice, probably you are going to lagging behind compared to other surgeons. The industry is very aggressive in promotion, which is the final beneficiary. So there are guidelines for introduction of new technology and techniques. There are international organizations which says how to judge a particular technique is to be adopted in our practice, whether it is safe and what are the different stages, how we have to apply these techniques in our clinical practice. So technology gives us power, doesn't and cannot tell us how to use that power. It is our surgical judgment that is going to be very important to use this technology for safety of the patients. So this statement, fool with a tool is still a fool. In spite of new technology, if the surgeon is not properly trained, not having sufficient surgical judgment, there are going to be disasters in clinical practice. So protect the patient and potentially devastating complications of new technology is the sole responsibility of surgical community and organization like ISCP and ACRASI, ASI. We have to give orientation to the new generation, to train them to see that the technology reaches all the patients safely. Surgery runs in a hierarchical manner in teaching institutions. There is a military hierarchy that a professor doing something that junior resident cannot question. Another tendency in the clinical practice for surgical community, the practicing surgeons in going with the tide. Surgeons and institution must guard against it going with the tide attitude in adopting technology without solid evidence of its efficacy, safety and superiority over other alternatives. Simply everybody is accepting and practicing some technology we are not supposed to take up. Before involving technology in our practice, we have to examine establish safety and supremacy over the existing techniques. The whole idea is not about using or not using the technology, but the challenge is to use it in right way. So best for the practice and best for the patient. There is a lot of confusion in the minds of surgeons. What is best for their practice to grow? They think only new technology they can grow professionally, irrespective of whether the patient is benefiting or not. It is a wrong impression. Whatever is best for the patient is best for the surgeon, even to grow in clinical practice. So by helping others, we help ourselves. So this particular judgment is very important in practice. So premium non-nursery. We are not supposed to do any harm to the patient. So traveling piles doctor. So this is a new concept that pile surgeons are moving around with a laser machine to operate the patients. So the type of patient, what they are going to, they are not aware. Patient is already prepared and everybody is talking about one particular technique. And after examining the patient may not be suitable for the technique. But wandering surgeons, who are called as nomad surgeons, are at great risk that their judgment is going to be fault. So this type of practice, we are not able to decide exactly what we are going to do. So we are not supposed to promise to the patient that this particular technique we are going to do. There are so many surprises on table. Unlike diagnostic laparoscopy, you have to do examination and anesthesia, then decide which procedure is best for the patient. Loeb's law of medicine is a very important principle for the practicing surgeons. If what you are doing is doing good, keep doing it. If what you are doing is not doing it, stop doing it. If you do not know what to do nothing. These are the principles we should govern while adopting new technology. Never make treatment worse than the disease. There are situations that patient's condition is worse after treatment, which is not going to be accepted, going to have lot of litigations on surgeons. So limitations of technology in practice. How much anorectal disease can be treated by new technology? I was trying to understand how much laser is useful in treating fistula, how much percentage of hemorrhoids can be treated by stapler or laser. So there are so many limitations, and all the proctologists or any special surgeon should be familiar with conventional techniques to handle the pathology. So there are some new techniques and technology, and every surgeon should be familiar with conventional techniques, because new technique or technology is not going to be suitable for every patient. So technology doesn't make man. Man made technology, hence it depends on use we employ for it. These are the new generation of surgeons who are having special interest in particular field, passion for technology. Because of there are challenges in surgical training, they are incompletely trained, inexperienced, and highly ambitious to grow in the field, in whose hands the new technology is going to lose its reputation. So previously we used to say, a good surgeon knows how to operate, a better surgeon knows when to operate, the best surgeon knows when not to operate. In today's era of new technology, this is more relevant. Good surgeon knows new technology, better surgeon knows when to use the new technology, best surgeon knows when not to use the new technology. This is how our surgical judgment will go on maturing in the process when we are experiencing different complications, understanding the safety of new technology. So we are reaching a stage that adopting new technology is a must. We can't wait. There is a force from the people. There is a necessity to grow as a surgeon. Do not wait for the perfect moment. But when we start new technology, take the moment and make it perfect by understanding, by attending conferences, by interactions, and undergoing training. It's the only way left, because adopting new technology is a must, but we have to go in a systematic manner. How to make new surgical technology safe? Approval, licensing, safety assurance by associations or international authorities who are declaring that a particular technology is safe. Structured surgical training program. We have to first attend conferences, we have to operate under guidance by senior surgeons, then start doing. The moment we start adopting new technology in our practice, that is not end of the story. We have to get certification in particular technique. Systems approaches to surgical quality and safety. So whenever we are operating in the beginning, always should be under the guidance of seniors. It should be in a protocol that which technique or technology should be applied for which disease. There should be institutional protocols. There should be teams to decide different treatment modalities in particular institution. And all important thing is self-surgical audit, whether this new technology is really giving good results in our hands or not. If at all the results are bad compared to the conventional, maybe you have to drop it. So let us all make new technology safe for our patient. Thank you very much.
Thank you, sir. Very, very, very nice presentation. Your 2 or 3 slides, I think everyone should imbibe in their practice. This is very useful. And I am so impressed that this should be the teaching institute should give these lectures to every teaching student or institutions, that they should not be excited about the technology and fit the technology into patient, but rather patient should be tailor-made. It's very nice. Thank you, sir.
Thank you very much.
Anybody is from the AV guy? Whether the OT transmission is ready?
Thank you, sir.
Next lecture is there? Dr. Jiten है क्या? Jiten को बात करूँ? है क्या नहीं? Jiten को 40 minutes झाला? Okay, चालेल sir. चालेल. Thank you sir. डॉक्टर जितेंद्र की बात करो. लेक्चर कोई बाकी है? नहीं है. एक है लेक्चर बाकी. मिशन सर राठे सर का है ना? राठे सर ऊपर गए ना? हाँ? बाहर गए. है क्या सर? अबे लोकल कोई बंदा कर दो ना.
Check. Wait. मला कसं कळणार? येते आवाज. हॅलो चेक येतो काय? नाही येत आहे. हॅलो चेक
येते सुशांत.
हॅलो सर.
ऑडिओ येते?
हा सर तुमचं येते. माझं येते?
यस ओके. कॅन यू रेडी?
हा सर.
जस्ट सरांना दे.
सरांना माईक लावतो आता. लेपर.
हॅलो.
हा सर.
Hello. Dr. Jiten is there?
Yes.
Hello.
Dr. Hemant.
You can tell us who is operating surgeon.
Yes, Dr. Hemant. On one side, in one of the OTs, Dr. Ladukar and Dr. Rajpal are taking up a case of rectal prolapse. Hello, can you hear me?
Hello. Hello.
Hemant, can you hear me?
We can hear you. Just tell us which is this OT screen.
See this
rectal prolapse is there. I think so.
Yes. What you are seeing on the screen is a case of rectal prolapse.
Okay.
Dr. Dilip will brief you about the case. Dr. Dilip.
So this patient is 42-year-old female, and her main complaint was prolapse.
It's not coming out.
And
Hello?
no other complaint other than prolapse. So we have given him a phonetic stimulation, and initially, so basically we have not seen the patient. Finally, when we diagnosed the patient, then she was posted for surgery.
Hello, Dr. Dilip, we cannot hear you. Can you be little louder?
Patient is having rectal prolapse, complete rectal prolapse, almost
Okay.
8 to 10 centimeters is popping out, prolapsing. Yeah.
What's the plan?
Plan is to do suture ectopexy.
Dr. Ladukar will show, Dr. Ladukar, well assisted by Dr. Rajpal, will be doing this thing, sacral rectopexy.
Sacral rectopexy.
Yes, yes. Fixing the posterior wall of the rectum to the sacrum. Using PDS suture and also foam sclerotherapy.
दाखवण्याकरता इंजिन माझ्या बोटामध्ये येते तसं. दुसरा स्पंज होल्डर दाखव. ब्लिडिंग होतं ना फालतू. नाही हां जस्ट दाखवण्याकरता राहू द्या. हिने प्रेस नाही करायचं.
एवढं पुष्ट झालं पण धरून ठेव दाखवायला नाही तर ते
ठीक आहे. ओके. Should we start now? Hello, am I connected?
Yeah, you're connected, sir.
Hello.
Hello.
This is what you are saying is rectal prolapse. Patient is in lithotomy position. She is not straining. Otherwise, it could have come out fully.
Okay.
There will be total procedentia of the rectum.
Okay.
Now we have pulled it out. It's only to show you that this is a case of rectal prolapse.
Sir, Ladukar sir demonstrate field test.
That field test, yes, I will show you. I will put it inside. I was a gospice. Now, see now.
Okay.
Is it coming, sir? Are you saying it?
Yes. Very well demonstrated.
So now, without losing any time, have you got the light source? Now light source over here. Light source.
Sir, how is the anal tone of the patient?
It's very lax.
It's too much relaxed. Actually, my 4 fingers can be inserted very easily. You see? Okay?
Yes. Very well seen.
If you put my fingers inside, it can be, 4 fingers can be inserted. So, let us now move inside.
Anybody has got any queries? Keep the mic. Ask questions to the demonstrator.
Now I am inserting a proctoscope which is specially designed for this procedure only.
Sir, this proctoscope's length seems larger than the normal you use.
Oh,
yes,
this
sir.
is also.
Can you show in front of the camera?
Oh,
yes.
This is a rectoscope rather than proctoscope.
This is
rectal inside.
Boss, और echo कम करो.
15 centimeters.
15 नहीं है.
More than that?
20 centimeters.
Yes. काय होतं पूर्ण it is मला तर पूर्ण आतमध्ये होईल का जाईल का नाही जाणार जाईल हां येस
एंडोस्कोपी लगेगा इसमें लैप्रोस्कोप जीरो अच्छा हाँ 30 डेज हाँ आपको 5 चाहिए सर 5
I couldn't
थांबा सर, हे तर ठीक काही
त्याला स्कोप लावून ह्याला
स्कोपलाच आपण डायरेक्टली काढली.
त्याने
स्कोपनीच लाईट सुद्धा येतो ना.
बस मग तेवढ्या लाईट आणि या लाईटने होऊन जाईल आपलं. चला ठीक आहे, लेट अस सी. अदरवाइज आय वॉज डुईंग विथ धिस ओनली.
चांगलं दिसतं.
ही पण चांगली दिसते सर. वा ना.
हां हां पुरा आलाय.
वा ना. काय सर, इट कॅन बी सीन.
सगळं घालायची गरज नाहीये. सगळं घालायची
शक्य
तुला दिसेल.
येस, बट वी हॅव टू शो देम.
मग नाही तर काय अर्थ काय.
आणि आता बघा, वी आर ऑन द सॅक्रम पल्मोनरी. यू सी
आणि त्या तिथं देऊन प्रेस करायचं म्हणजे ते हलत नाही.
आता आपल्याला काय करावं लागेल, अगेन वी हॅव टू गो हेडलो परत करावं लागेल. दिसतं हेडलो द्या किंवा टेबल कॅन इट बी रेस्ड. टेबलला वरती कर.
हेडलो दे, तुला असं बघायला चांगलं होईल. रादर दॅन आता आहेस ना चांगला आहे, याला तुला काय नको आहे. टेबल वर येतं
काढू सर. येस,
नाव यू कॅन सी इनसाइड.
ओके.
तुम्हीच बघू शकता.
आता आपल्याला हे लागेल.
हेच तरी मी अगोदर घ्या म्हणून सांगितलं.
द्या ना म्हणा, लाईट्स दे, हे द्या. याला हे कॅमेरा लागेल. मग हो, लाईट्स असतात फक्त लाईट्स.
पूरा लॅप्रोस्कोपी सेट लागेगा.
याला कॅमेरा दाखव, याला फक्त लाईट्सच दाखवायचं तुम्हाला. असं कॅमेरा लावून
रेकॉर्डिंग
दिसणार कसं त्यांना. तू तर काय बघणार आहे त्याने.
द्या कॅमेरा द्या.
तू काहीतरी झालंय तुला.
त्यामुळे तू फक्त बाहेरून दाखवायचं, त्यांनी
तुम्ही मला यामध्ये हां अरे बाबा हे दे. सरांना पूर्ण लॅप्रोस्कोपीने दाखवायचं आहे याचा अर्थ. येस
मी तर असंच करून जाईल.
येस, इज इट सीन नाव.
सीन
इथं काही दिसणार नाही.
ते जवळ घ्या, ऐकून घ्या, म्हणजे तू पण बघू शकतोस त्या खालती जरी दिसतं नाही.
हां.
आणि हे तू धरायचं नाही, असिस्टंटने धरायचं.
येस येस
तू ऑपरेट करायचं.
येस. दे बाबा कॅमेरा. गिव्ह मी द कॅमेरा. हा. किंवा हे असं वरून पण धरू शकतं सर. असं वरून जर धरलं की नाही तर इट विल नॉट बी इन माय ऑपरेटिंग फील्ड. हां दिसतं ना. वरूनच धरायचं.
लाडूकर सर, टेलिस्कोपला कॅमेरा हेड कपलर अटॅच करा ना.
तू एक तर हे बघ दिलीप, तू या बाजूने करतो,
मी त्या बाजूला येतो, मला दिसणार पण.
म्हणजे तुलाही दिसेल.
अजून एक असिस्टंट लागेल. वन अनादर असिस्टंट. हां
ठीक, जाऊ.
यू हॅव टू फिक्स दिस लाईक दिस. आपलं सुचर मटेरियल घेतलं पीडीएस सर पीडीएसचं ते आपलं सुचर मटेरियल द्या. यांच्याकडे आहे की नाही मला माहिती. हां तुम्ही आहे ना वॉशिंग. हे द्या ना. यू सी, गिव्ह मी कॅमेरा. रिटेनली आपण असं करत नाही एवढं. हे मी आता पण सुरू झालं असतं प्रोसिजर.
दाखवायचं ना पण.
हां त्यांना दाखवायचं आहे म्हणून. तुम्ही काही घाबरू नका, कारण ही प्रोसिजर सगळे ॲनोरेक्टलचे आहे ना, त्याच्यामुळे दिस इज नॉट अ मॅन्डेटरी थिंग ओवर हिअर. ते बिचारे सगळं डायरेक्टच लागतं ना. याला फिक्स कसं करता तो.
हे पण दाखवायला लागेल तुम्हाला.
येस, प्रत्येकाचं अलग अलग. अरे हे धरण्याकरता कोणीतरी असं.
मी धरतो ना.
नाही सर, दोन्ही नाही धरणार तुम्ही. एक हे वन असिस्टंट. वन असिस्टंट इज निडेड. दॅट हां असं ठेवायचं आहे. याला कॅमेराला ॲडजस्ट करता येईल. हां कशाला. हां ते ठीक आहे, पण आम्हाला बघावं लागेल ना.
दुसरं हे करा, फाईन ट्यून करा.
आहे ना फाईल थांबा, वाईट बॅलन्स करा आणि झालंय का बरोबर? येस. आता पहा तुम्ही हे कशी हां
फाईन हे ॲडजस्टमेंट करा.
अरे फाईनचं हेच आहे ना याचं का हे आहे हे असं फाईनचं कोणतं आहे? हां बरोबर आहे.
आगे आगे आला इसको इसे सर आप नैरो कर और इसको पूरा खोल दो. हाँ बस इसे आगे से करो.
प्रत्येकाचं अलग अलग असतं साधं. हो होतं हो हो करा तुम्ही.
आमच्या घरचं हे जरा सर
नेहमीच्या आहे तुमचं ते नाही मागे चाललं ते हां. आपण टाकून बघा सर, कारण ते फार जवळून होतं, इतक्या जवळून आपण घेत नाही ते बघ काय झालं. आणि काय होतं या लेन्सला, हा छोटा लेन्स आहे ना, आपण नेहमी 30 डिग्रीला जातो त्याचं विजन मोठं असतं सर. ओके मला काही दिसत नाही. तर बघा दोन्ही हात आले. हे पकडायला कुठेतरी असिस्टंट पाहिजे ना. या सर इकडनं या. सर असा कसा हात येतो ना वरती.
ओके
असं वरून वरून धरता येईल का? क्या पता ना उसको स्विच करो. इथे आपल्याला काय एक सक्शन पण पाहिजे. वी वॉन्ट ए सक्शन ऑल्सो. सक्शन पण पाहिजे. हां असं बघा. हां आणि हे काय सर बघा आता हे हां याच्यावरती हे नाही झालं पाहिजे. हां स्पंज होल्डर द्या, स्पंज होल्डर द्या बरं, स्पंज होल्डर द्या.
छोटा टेलिस्कोप आहे का? दे ना
सर याची काढवं तर नाही.
हेलो. नहीं नहीं समझ में आता है. हेलो.
Yes.
Hello.
Yes.
Can
you are
anyone in the
audible.
CME hall hear me?
Yes. Yes.
Who's there?
I am Dr. Hate.
Dr. Hate. In one of the OTs, Dr. Sonavan is going to show the laser hematoidoplasty procedure.
Yeah. We are waiting.
Yeah.
Hello. Hello.
Sonone sir, you
Yes,
are
sir.
audible here.
Okay. This is a 52-year-old lady who was operated for piles in 2013. Now she's got a recurrence. She has something coming out of her anal canal and bleeding, profuse bleeding. So on examination, there is a single point recurrence at around 7 to 9. Am I audible, sir? Rate, sir?
Yes, yes, you are audible.
Yeah.
And very clear vision here.
Okay. Okay. So this is a slit endoscope for the purpose of people who have not seen it, and it is self-illuminated. So this is the recurrence. Can you see it?
Yeah, very well.
Yeah. And as Dr.
What about the other positions?
Yeah, I'll show you. Very small one here.
Yes.
And no recurrence at 3 o'clock, sir. So it's a very nice case to do by laser. As Dr. Kurapati was saying, that laser is not a big boy's toy, and we should be very careful in choosing the cases, especially when we are doing it in the first phase of our experience of laser surgery. So what my method and most of the people that are doing is palpate the superior hemorrhoidal artery. Sir, can you wear the gloves, please?
Yes, yes.
So I will be demonstrating this.
Your head is coming in between.
Okay. I will be demonstrating palpation of the hemorrhoidal vessel to Dr. Jiten Chaudhary. Yeah. Sister, hold this. Yeah. And we start, sir, Rahate sir, we started doing Doppler guided hemorrhoidal artery ligation first, but then we have found that finger Hall is equally giving good results. So we have done away with the Doppler guided system, and we can really feel the hemorrhoidal vessel like a radial pulse. I am waiting for Dr. Jiten Chaudhary to feel it. Aram se, sir.
What type of laser and what will be the
Yes, sir.
specification?
Sister, जरा बाजू में हो जा. आराम से.
Yeah.
So just for the sake of everybody, I am demonstrating each step that I am doing, and you can really feel the hemorrhoidal vessel easily. No, just above the base of the spine.
Yes, sir.
Yeah.
Yes, sir.
Yeah?
Yes, sir.
Yeah, fine. Okay, sir.
Yeah.
Can you hold this? Yeah. So I'll be underrunning the hemorrhoidal vessel with a 2-0 Vicryl. Yeah, sure. Can you see it, sir?
Yes, yes. How much deep you have to go?
Thank you, sister.
Since you are doing it with Doppler assisted,
Yeah.
do you find that there are multiple vessels there or?
So, is it for me? I cannot hear you properly.
Yes, yes, it is for you.
What is it, sir?
You said that you are doing this particular thing with Doppler guided ligation, no?
Yeah.
Before going in with the laser. So do you find multiple blood vessels?
Yes. We definitely find multiple blood vessels. Around say 5 to 7 blood vessels we find usually on Doppler guided. Even if we are doing a case for the first time, we do get 5 to 7 cases. But this is a recurrent, single recurrence, so I am just ligating one vessel for the demonstration purpose. And I'll ask, once I put the stitch, I'll ask Jiten sir to just evacuate the pile. Sir, can you just press? Yeah.
You already
Just,
tightened it, no?
Yeah, no.
You just taken this in?
Yeah, not tightened.
Okay, okay.
So we are emptying the pile mass. Yes, thank you, sir. Ek second, झालं. So you are already seeing that the pile mass has shrunken. Caesar, sister.
It is because of the ligation or because of that compression or because of the stretch?
No, I think it is because of the underrunning of the vessel. Some shrinkage immediately occurs, and not in this case, but in larger piles it does help you in the application of laser. So this is the probe that I use. It is a conical laser probe. It is good because it is giving out laser energy in a conical fashion. And the settings are, go back, nahi, परत बंद करा, हाँ, 6 watts and 3-second pulses. दाबा. So what we do is we just puncture at the mucocutaneous junction, go inside. Can somebody turn off the light, please? The lights, OT lights, as well as this, as well as this. The light source. Yeah. Yeah. If you can see the laser light in a bright fashion, that means you are too close to the mucosa. And if you are too deep, that means that you are too close to the muscle.
in between. Yeah. Now it is okay.
So you should be in between and then start applying the laser energy. You have to rotate and withdraw gradually. Rotate and withdraw gradually. Yeah. Hi. Goggle. याच्यावरच टाक. Yes. Thank you. Thank you. Since there are two pile masses, I am going at them separately. Yeah. Sir? Yeah. Thank you. So rotate and withdraw.
But you have not ligated here, no?
Sorry?
This particular pile mass, you have not ligated the artery, no? Feeding artery.
I can't hear you properly, sir.
It is saying you are not ligated the other pile mass.
No, I have gone through the base of both the pile masses.
Okay.
One stitch. Can you turn on the light, please? This light? Light source.
Light source.
Yeah. See, it's almost collapsed. Gone.
When you will be applying the ice pack?
Sir, your mass is... I can't hear him properly.
He's saying, will you applying the ice pack?
Ice pack, no, not much energy. I have used only 168 joules, sorry. So I don't think I will be using. Wherever I am using multiple pile masses and the energy used is more than 300, 400 joules, then I use the ice pack. This is hardly any energy. Open kara. After the surgery, we put this. Yeah, no, we put this gel spawn, which has a small hole inside to pass gases, and it collapses within say 4 to 6 hours. Jelly. So the surgery is done, sir. Any questions?
Why this spongy stone?
It's for the pressure number. It's called gel spawn, sir. Gel spawn.
Mic दे मला mic द्या mic द्या. Mic.
There is a question. What about that 1 o'clock pile mass? What you have done?
शाला. हा चढवतो. Hello. Hello, Rate. Hello.
Yes, you are audible.
But are you seeing the picture inside?
No. Your angle of the camera is different, and your axis of the
नहीं इसको शुरू करो. इसको दो. एंडोस्कोपी पिक्चर दो. एंडोस्कोपी पिक्चर दिख रहा है. It is seen now.
Yes.
हाँ, अरे बंद हो गया. I have given the first suture while you are doing that laser pile. I have given the first suture at.
Show us. Pull that knot.
Which knot? That which is applied over there. I will put now. I will give the next suture now, and you will see, I will show you how it is pulled. Okay? This is PDS 20. One number. No, PDS one number. Okay. So 40 mm. See? This is over.
Can you see?
Can you see it?
We can see it very well.
Yes, good.
This is not Yes.
Yes.
Can you see the tip? Tip आला ना?
Yes.
Yes, sir. पर
Touch it.
इसको ऐसा करो थोड़ा सा ऐसा.
हाँ, दिसते.
क्या आएगा क्या टेक्स्टबुक में आएगा कि
You see this? These are these two suture like?
Yes.
Two threads in my hand now. It is okay?
Okay. You are pulling?
Are you saying it?
Yes, yes.
1, 2, 3. Hello. Hello, barabar.
Hello.
Hello.
Yes, sir, we are seeing very good picture here. Second thread is tighten up.
Sound is not there. Yes. ओके. याला आपण त्याच्या पलीकडे पण गेलो सर. दॅट इज व्हेरी इम्पॉर्टंट. जवळचे सूचर सहज मारता येतात, दूरचे सूचर मारणं कठीण जातं.
Hello.
Hello. Yes, Dr. Chidan.
Hemant.
Yeah.
Any questions?
And everybody is mesmerized by seeing the good procedure here.
Okay.
Yes.
So what he is using is basically number 1 PDS on 40 mm needle.
Yeah.
40 mm round body needle.
Okay. Well.
So he'll be putting up at least 4 knots.
झाले ना 4. अजून एक
4 sutures basically. And 5 to 6 knots per suture.
Jitin, what this needle holder Dr. Ladukar sir is using must be around 25 centimeter of length.
Yes.
Yes.
The problem of this particular piece of needle holder is that it has got a groove at the hinge. So it should have been the plain one so that slippage of suture material will be smooth. You need to push that so that it should not angle for there. Is it? Am I right?
Yes, yes, correct.
Yes, you are right, Dr. Kodwani.
ढकला लागतं ना थोडंसं. थोडंसं ढकला लागतं. झालं ना. Cut scissor.
Ladukar sir, my question to you and Dr. Chivte sir. Ladukar sir, can you hear me?
Yes, I am hearing you.
Yeah, my question to you and Dr. Chivte sir also. This needle holder, whether there is any advantage of angulated needle holder or it should be straight one?
Straight one.
I don't think angulated will have any because it is too long a tube for that.
Okay?
Yeah, angulated will just elevate, in between. or flattened it.
We have to come down now.
Here,
Now
here we can
two
keep
knots.
the thread longs and use a knot pusher to tighten the knot.
Yeah, I agree with you. I agree. Ladukar is very, adamant. He is not using knot pusher.
Yeah, it's very easy to
He's
use
all
the
the time
knot pusher.
adamant.
No, no.
That's
He
the
said
problem.
he is easy with this, putting finger everywhere.
Sir, kahi mana sir.
Sir, there is a question.
Please.
How much is the distance from anal verge?
This is near about, first stitch is at about S3 level. You can say about 12 centimeter or 10 centimeter.
Okay.
How many centimeters exactly, sir, from anal verge?
This is again I
10,
pulled.
10 to 12.
Pulled.
Female, so it will be 10.
Hello, I have pulled this. These two threads have
Yes.
pulled and it is.
Yes, we can appreciate.
It is not lifting the anal mucosa. So it is deep.
Proctoscope length is almost 16 to 18 centimeter.
20 centimeter.
It's 20 centimeter, 18.
Yeah, some part remains outside only.
Yeah.
We don't push everything in.
This is 10 to 12 centimeters. First stitch
Okay.
is 12 centimeters. Part of the proctoscope is outside.
Ladukar sir, are you going to push sodium tetradracil?
Yes, everything would be shown. Caesar.
तयार करा सोडियम पिटेटस किती 4 नॉट झाले का रे
सर बरोबर
4 की 5
तीन
पाच करा
इसको हरदम ऐसा करना पड़ता है, ये स्ट्रेट हो जाता है.
काय पाहिजे तुम्हाला कुठे यूएजी आता त्यांच्याकडे यूएजी जीवन ज्योतमधनं आणायला लागेल कल टुमारो नॉट टुडे
और एक है
ब्रदर
और एक है प्रोलैप्स. ओके. जमला ना. फर्स्ट याच्यामध्ये
bloodless.
This is what happens when somebody who is good at showing you the place.
Yes. Yes, it's too good. It's very true, sir. But I am used to it, ना. मी जे करतोय ना ते मी नेहमी करतो असं. So I am accustomed to it.
तुम्हाला नेहमी चांगला असिस्टंट भेटेल.
म्हणजे काय चांगले असिस्टंट सर तर त्यांच्यापेक्षा खूप चांगले आहेत. आणि सर कसं आहे सर क्वालिफाईड ड्रायव्हर सारखे आहेत. हो सर
Qualified postgraduate driver.
बरोबर आहे ना. झाले 4 प्रश्न. आणि हे प्रत्येक वेळेला काय करायला लागतं हे सांगून देतो. हे प्रॅक्टिकल बघा की ऑल द टाइम ही असं सब स्ट्रेट होऊन जाते. मग त्याच्यामध्ये लेंथ कमी होते. तर एवढं असं हॅलो
हात मुवमेंट दाखव तुझी.
हॅलो जाऊ द्या कोणी ऐकायला तयार नाही. हॅलो हॅलो
Sir, everybody is listening here.
Actually, it goes deep down to the tissues and up to the periosteum, up to the presacral fascia.
Yeah.
So big amount of tissue mass is there. So there is so to take out the needle, tip of the needle outside is quite, it requires a strength. And in that position, sometimes needle straightens. So we have to tilt the needle again, we have to make the curve of the needle again proper. Because this is the surgery where no time permits you. If you put the needle inside, the tip of the needle has to be outside. Otherwise, if you fumble, if you take down the needle again and again, then there will be bleeding. So important question is, putting the needle inside and bringing the tip of the needle outside is very important.
Yes.
You see now? So get that. चांगलं झालं ना, sir. There is no problem. Okay. See you. Yes. दुष्काळग्रस्त भागातला माणूस आहो मी आणि जास्त आय डोंट. आणि सर काय आहे, एव्हरीबडी wants to pull. Yes, again. It is not chunk. You see how much of the chunk is there. They are observing, sir. Everybody is observing.
डॉक्टर पुरिया आए थे तो महाराष्ट्र मेडिकल काउंसिल तो आके विजिट करके गए।
तो अपने को कितने पॉइंट्स मिलने वाले हैं सर? यस, वी हैव टू गेट द पॉइंट्स नाउ।
2-3-4 पॉइंट्स। पता नहीं कितना है, 3 भी मिलेंगे तो बहुत है। हां, यू विल गेट। आप नीचे नाम लिखो ना। हां,
अरे वो दो
लिखवा दो। बहुत कल आओगे तो लिखवा देना। उसके पास ही अपना क्या नाम उसका, हमारा हॉस्पिटल का ही बंदा है।
बरोबर आहे, 4 झाले ना सर?
जो आपका जैसे बगीचा
ओके,
है।
1 2 3 4 5 झालेत. 5 झालेत. Hello.
Hello, we can see, sir,
I am
all
showing
five
you.
knots.
I am showing you now. We have taken five switches now.
Yes, we can see
5
very
knots
well.
have already been done.
Yeah, very well.
Yes, again we will come.
ठीक आहे, आता रेडी आहे सगळं. हां, त्यांना दाखव 460 काय आहे.
What is your lower limit? The last stitch, kitna anal verge se? How many much centimeters from the anal verge?
Actually, it should be beyond the dentate line.
Not necessary.
Above the dentate line? How many centimeters or at the dentate line you say?
It should be above the dentate line, not close to the dentate line. Otherwise, it will be a painful procedure again. Why you should tie the knots? It should be above the dentate line. No, answer is correct.
Hello, Hemant.
Yes, sir.
Hebak, we are not coming to the dentate line.
Yeah,
From the
that's
apex,
you should not
4 to 5 stitches are good.
Yeah.
At 1 centimeter or 1.5 centimeter distance. So it comes near about sacrococcygeal junction.
Yes.
Okay? And lower part, we are going to inject it, lower as well as upper. So everything will be created fibrosis.
I don't feel that now there is necessity of this. इथे लावायची गरज नाही. आपण आलो खाली बघा. We are very close to the dentate line now.
Yes.
How beautiful dentate also you can see.
This is the dentate line. You can see. How you see. I will.
We
Okay.
very well, we are appreciating the dentate line here.
माझा बोट आहे.
मॉस्किटो या फॉर्स है, उससे लिखा था।
Now I will show you. See how many stitches I have taken. No bleeding as such.
Yeah.
1 2 3. I will count on this. Now you count. 1 2 3 4 5 6. Now I will inject the. I will show how the tetradecyl. Now you have to focus on this. यांना
हो बरोबर आहे, कारण ते हे बघ पहिल्यांदा निडल घालून दाखव, मग
Yes.
चर्न कर.
हा, yes,
म्हणजे
yes.
ते पुन्हा फॉर्म होणार नाही.
काय
तुला देत नाही, मी देतो.
Ascaron.
ठीक आहे.
Ascaron. 4 and 6.
4 and 6. आता हे नेडल कुठे लावू रे? नेडल कुठे लावू मी? हां, नेडल कुठे लावू?
आधी हे फॉर्म बनव ना.
हां, बनवू नाही पण दाखवा लागणार त्यांना. आमचं स्पायनल नेडल यूज कर. हां, शो. Focus this needle. This needle is called as
Yeah, we can
Shiba
see the needle, sir.
needle.
Chiba 20 centimeter long, 20 gauge.
It is used for routinely. It is, no, this is used for this much of long needle is used for which procedure?
So many procedures.
So many procedures.
So many procedures.
I am saying for the first time. I have
Okay,
seen
okay,
only.
thank you.
Thank you.
पहले ये बना था
हाँ नहीं. हाँ.
You can see so many innovations and new things whenever Dr. Chute is there in the theatre.
You see.
लाइट पेरिनियम वरती घालणार आहे.
अरे हे light.
पेरिनियम वर घाल म्हणजे डिस्ट्रिक्ट कॅमेरा.
Are you seeing this needle now? Yes. This is Chiba's needle. This is Chiba's needle.
दिलीप तुम्हारा हाथ निकाल.
I will be now. हाँ. इसको लाइट दिखा. इसके अंदर दिखाओ लाइट अभी. इसके अंदर लाइट दिखाओ. नाही इथून टाकू ना आपण.
खाली रेक्टमच्या खाली.
हो. तर कुठे इथून टाका. इथून टाकायची ना आपण. इथून टाकायची.
हे बघ तुला कॉक्सिक्स लागतं का?
हो. हो हे
तिथं बोट ठेव तिथून आत घाल.
हाँ टाकतो ना पण पहिले येस येस फर्स्ट आय हॅव टू डू इट
ते घाल अगोदर नंतर ते कर.
Yes. So now I'll be putting the my need. Now I have palpated this coccyx over here, and above that there is a anal canal, and then beyond that there is a rectum. Now this I have felt it. Now I'll be putting this needle from here.
Under rectum, this retrorectal space.
It is a retrorectal space. Now it has gone inside. Yes. Okay. I feel it is okay.
Fine.
Now,
not that. You aspirate with the other syringe.
Syringe get.
Show that it is not in blood vessel.
Yes, stencil syringe आहे.
तिथे दाखवलं तरी पण झालं.
हे निडल घ्यावं लागतं सर. Yes, yes.
सर हे दाखवतो ते बघा स्क्रीन.
हाँ. Give me one. हाँ, yes. Now I will show that whether it is inside the venous plexus or in blood vessels. So I will try to aspirate it. If nothing is there, it is in a better place. Nothing. It is not coming inside. Okay.
Suction vacuum येतं. Vacuum येतं का त्याला?
Okay. ठीक आहे.
मग एअर येते म्हणजे याचं बाहेर आहेस का बघतो.
बाहेर नाही. नाही सर निडल बाहेर नाही आहे.
मला बघू दे. आत घाला.
हा ना. नाही सर कुठे बाहेर आहे?
बघू दे ना.
No, no.
हां ठीक आहे.
No, it is not. हे ना.
मग सिरिंज लीक आहे का?
सिरिंज लीक असणार नाही तर ते
कुठे आहे? काहीच नाही.
तू बसवत नाही सर सिरिंज
घट्ट बसवलं. सोडलं ना की ते पटकन आतमध्ये गेले.
नाही जात.
आता तर समजी की
लिव्हर लॉक द 10cc.
हां. इथे लिव्हर लॉक आहे. हे लिव्हर लॉक लावून बघ ना. ही बघ. आम्ही ह्याच्यामध्ये घेतलंय का? ऑलरेडी घेतलंय. ओके.
पण निडल ही बरोबर आहे सर आतमध्ये आहे ना.
अरे पण दाखवणं तुला काय जात आहे?
ओ.
दाखव.
हां सोड.
नाही जात रे लीक आहे त्याला सांगतोय तुला.
घट्ट कर.
टाईट कर.
हां.
सो आता निडल आउटसाइड आहे. दाखव मला पुन्हा. लास्ट में पंक्चर हो गई. पंक्चर हो गई.
ते बघ ना दिसतंय.
पाठीमागून नुसतं काही करू.
काढले मी पुढे टाकतो ना. परत टाकतो एकदा.
काढायची गरज नाही ना.
काय पुढे टाकतो ना.
तिथे बघूनच तू बाहेर ओढला असता.
बच गए ना तो भारी
ऊपर से आता था बाहर.
धुआं
बघून का बरोबर आहे. हात जास्त. हां बस इथे पण गेलास ना.
बस इतकंच गेलं.
ओके.
ओके आता करून बघा सिरिंज.
कोणत्याही सिरिंज होईल ना.
हे बंद करा.
नाही हे
सॉरी.
स्कोप आतमध्ये बघ.
हाँ.
Yes.
Correct.
ये देखो. दाखव आता ते दाखव. हां.
And now you see, I have put the Chiba needle inside, and now this is absolutely in a retrorectal space. I have to test it. Just I am aspirating it. No blood is aspirated, but the needle goes inside.
हेमंत दिसतं का तुला?
Yes, sir.
So negative
आणि काही उत्तर देत नाहीस मला वाटलं दिसत नाही तुला.
नाही नाही तुमचं क्वेश्चन नाही आलं ना सर, मी उत्तर दिलं असतं.
ओके
आता
ओके
ठीक आहे.
आता ते
Now what I am doing, what I am going to
We
demonstrate.
can see
now
now you are injecting the foam.
करेक्ट करेक्ट.
हे दाखवा आता.
Foam preparation is going on.
Now foam is being created. On the left hand side there was cetrol and on the other syringe there was air. And now air being mixed with the
This is
cetrol.
तुझीच प्रोसिजर.
Yeah,
You
yeah.
proceed?
या
You are using
Churn
only
it.
one vial
Churn.
of cetrol, no sir?
या या.
Yes. आता पूर्ण याच्यात ठेवतो.
नाही नाही अजून कर अजून कर. इयरफोन व्हायला पाहिजे चांगला. मला दिसत नाहीये. फास्ट कर राजा.
सर
हां. आणि आता नीडला लिव्हर
Two
लॉकनी
ampoules.
बसवू चांगलं.
It was 2 ampoules.
हां बस आता बस झालं ठीक.
आता लावू कुठून?
आता थांब, ह्या बाजूला बंद, त्या बाजूला बंद करायचं.
आणि आत बघ किती बल्ज होतो ते.
बरोबर.
या बाजूला बंद करून
हां
ते काढून टाका.
हे काढून टाकू. येस. हां थांबा थांबा, हे लावावं लागेल ना म्हणा.
ह्याला आता
फक्त वाईट.
फक्त वाईट काढा. सोडा.
दाखवताना इंजेक्ट करताना.
एक मिनिट टर्न.
येस येस येस.
बायबल टर्न करा.
हां
टर्न करा.
टर्न करा ना ते व्हॉल्व.
येस येस.
आणखीन.
ओके.
आणखीन टर्न करा.
ह्या बाजूला ना.
हां. हां.
थोड़ा. Okay. Now you see, I will be injecting this foam now inside.
Can we see the inner picture? Camera.
इनर पिक्चर दाखव.
इनर पिक्चर.
वहाँ का पिक्चर.
Only when it is in the vessel.
सर जाऊन राहिलं पण
The
प्रेस.
rectum and stomach, two organs are there surgeon friendly. Whatever you do, unless you are too messy, it will not give you trouble.
काय?
हो येस. फोम टाकायला.
नाही नाही थोडं पाठीमागे ओढ बघ तू. त्यात टिश्यू असेल थोडासा.
गेलं ना.
विदाउट स्टिलेट घातली ना नंतर.
गेला ना पहा ना समोर समोर हे ना बघा ना रेज मार्जिन झालं रेज झालं ना ते रेज
तू थोडं पुश कर पुल कर अगोदर.
झालं ना सर. आय हॅव पुश्ड इट इनसाइड.
इंजेक्ट केलं.
इंजेक्ट केलं
बस
पूर्ण.
झालं. मग काय करणार आहेस आता?
झालं
बघत
सर,
पैसे
इंजेक्ट केलं.
आता एक थोडंसं खालच्या पण रेला करून टाकू. ओनली टू
राहिले
सीट्स.
का?
येस इज
नाही नाही ते तेवढंच असणार आहे. जास्ती नाही करायचं.
ओके.
प्रेशर देऊन ठेवतो.
गेलं की आता
संपलं म्हणून.
Now you have just injected this cetrol inside. A cetrol foam
पाहिजे
is
तर
inside.
होल्डर करून दाखव त्यांना बल्ज
नो लंप इज पेन. बोल दो.
आता lump is filled.
आपला हे दाखवा. हां. त्यांना सांगा की तिथे
I-
bulge नाहीये म्हणून.
Now there is no bulge inside. It is adequately.
Hemant,
Yes, sir.
there is no leak or no bulge is there.
Yeah, sir.
So it has spread in that holy place.
Okay.
So at least sclero is very good now in this. Okay. Are you happy or you want to do something?
No, sir. Very good, very good.
Okay,
The only
okay.
question is that while injecting, do you continuously withdraw the needle or it should be kept at one place only?
No, see, you can withdraw at some places because not necessary to inject at one place. And even though you inject at one place, it will spread whole holy place, you know, in that fascia.
Sir, there is a question from the forum that have you seen any time ulceration because of this scroll in a wrong place or some complication because of this?
See, usually we are injecting this retrorectally, this beyond muscle. And if you are injecting into the wall or mucosa, you may see ulcer. And while injecting, if you see bulge or balloon, then you should stop it.
Now I will try to do the frill that test again, but I don't feel that it will now come out because it is already.
एक मिनिट.
Now you sure? Now I want to pull it out.
Dr.
Nothing.
Jiten is there?
Nothing comes out now. You see?
Yeah.
That frill stress now, when I am doing, nothing is pulled out. No mucosa is pulled out. It has gone very nicely inside. I don't feel that the treatment is done now. Okay. Over.
Have you seen appearance of the anal verge also?
Yes, sir. Fantastic on dental appearance.
Yeah.
Request to Dr. Jiten that tomorrow morning they should show this result.
Okay.
Tomorrow morning, yes, yes, why not?
Yeah.
Tomorrow morning. we
Okay,
can do that.
okay, sure,
It
sure.
is a request of the house.
Yes, yes, yes. we will do.
Tomorrow evening we will show, so sometime should go. And we will ask her to eat then.
Okay? काही ठेवायची सुद्धा गरज नाही आतमध्ये. There are no bleeding, nothing, nothing. काय सर? Nothing was there. काय पाहिजे?
Very good. Yes, very good.
माइक लो
थोड़ा एक और टर्न नीचे ले ले. हाँ हाँ, थोड़ा सा नीचे ले ले. ये ऊपर हो रहा है.
One.
हाँ चल ठीक है बस. हाँ जल्दी देना सिस्टर. ओके.
He will not come to you.
Yeah. Gauche please, gauche please.
Immediately next is not. Immediately next day fibrosis नहीं होगा. तो ना next अगर नहीं आया तो शायद नहीं आएगा. Next आएगा तो chances है थोड़ा तो रहेगा. Fibrosis doesn't occur in one day. Next day तो अच्छा है. तेज बनता ना.
कहाँ? तुमको ये पस आता है इसमें कब से? पस कब से आता है? क्या है लिखना?
Dr. Jiten sir.
Yes, Hemant.
This case. Hello, we are seeing one fistula.
Yeah, we are seeing one external opening.
हाँ.
हाँ, तो I'm just going to this thing ना. First put hydrogen peroxide in it, diluted hydrogen peroxide.
Okay. What's the plan of the procedure?
Say it again, Hemant.
Any pre-op investigation has been done, or it is a primary fistula, single opening? You are not advise MRI for such patients.
Yeah, yes. MRI we normally advise only in recurrent cases.
Yes, that is the take-home.
Whenever we see a fistula, what we do is to clinically examine it and try to find out some fibrosis where the tract is heading towards. But here in this case, I cannot see any fibrosis in around the external opening.
On per rectal examination or on scopy, do you find any internal opening or suspected internal opening?
No, actually, I'm not able to find any internal opening. Neither I'm not able to find any fibrosis around also. Normally, sometimes what happens, we can feel the tract, no, the fibrotic tract, just
Yes.
by digitally pressing the surrounding area.
Okay. Do you
What I'll
use
do is
only
just
methylene blue or you use methylene blue with hydrogen peroxide?
normally we use first. I use first the normally hydrogen peroxide, and then I inject methylene blue later on. Because
Okay.
what happens is it stains the tissues. If you give the hydrogen peroxide directly immediately, it's better to use either the normal saline betadine solution or this thing hydrogen peroxide mixed with the normal saline.
Okay.
Diluted.
What is your take if at all you cannot find the internal opening on examination, on table examination, or even the dye doesn't come out anywhere in the anal canal? So what will be your take?
So when the situation arises that you're not able to find the internal opening or neither you're able to find where it is going, so what we do is basically try to core the fistula.
Yes, that is the important thing. When
yes.
we are not uncertain with the internal opening, try to engulf the fistula tract and core it. मिलेगा उधर दिख रहा है डिंपल दिख रहा है
नहीं इट इज नॉट गोइंग एनीवे उसको फिसला था भी कभी कभी कुछ एनल ओपनिंग ऐसा भी हो सकता है ना कुछ समझ
Jitin, what you are expecting, how is the path, how is the anatomy of fistula? It has come, I think.
Dr. Rahate?
Yes.
You are asking me something?
Yes. How is the anatomy of fistula? What do you expect here?
See, normally, as per the Gutsal's rule, the internal opening most likely have to be at 6 o'clock, because any fistula which is in this position normally opens at 6 o'clock.
Usually, if the fistula is at 9 o'clock, it will go up.
No, it is not exactly at 9 o'clock.
Yeah, it will go up supralevator or near to levator and then turn back down. So it will be a V-shaped.
No. If you draw a line which is at half of the divide this bisect this plane, it is on this side. It must be something at around not exactly at 9 o'clock. Yes, you can see it's a straight tract. Can you see?
Yes.
Hydrogen coming out. इसको पकड़ना जरा. Dr. Rahate.
Opening is at 9 o'clock.
Yeah, opening is at 9 o'clock. Yes. No, not only the external opening. It's a straight tract, and I can see hydrogen peroxide. Can you see?
Yes, we can see.
Yes, that's what. So what I'll do is now I'll mix it with some methylene blue to stain the tract.
So what is your plan now?
So it appears to be a superficial fistula. I may just do a fistulotomy. Yeah. Now I'll try to probe it. If I'm able to probe it nicely, then I'll just go with the fistulotomy. Yeah, गया. Yeah, it has gone like this. See, the whole of the track is in front of me. What I'll do is now inject some locks with the adrenaline solution. I'm just injecting a solution containing adrenaline. नहीं बहुत ही नज़दीक है, तो थोड़ा दूर होता तो ठीक था. क्या है नेक्स्ट? नहीं, अगर एक डिफिकल्ट फिस्टुला है, ट्रांसफिंक्ट्रिक अगर है ना, तो राहते सर को बोलो करने के लिए, अगर ट्रांसफिंक्ट्रिक फिस्टुला है तो, है ना. Oh, sorry. That's it. I'll just massage it for 2 minutes. Let the adrenaline have its own effect. Fistulotomy. Superficial, है ना? हाँ, it's very, very superficial. We'll wait a minute or so. हुआ नहीं, जल्दी हो जाता ना, पेशेंस नहीं रहता ड्यूरिंग दिस थिंग. And just a fistulotomy. And on the external opening, what we do is we literally enlarge the external opening. That's it. Here you will find some fibers of external sphincter also. You can see. Hello.
Hello.
I'm there.
Yes, sir.
There are some fibers of external sphincter which I am going to divide, but they are very, very superficial fibers, so they will not cause any problem. Mop. Yeah. Last. ले ले. थोड़ा सा वहाँ पे मॉप कर. डॉक्टर हेमंत. डॉक्टर हेमंत.
Hello. What you will do for the
Hello?
tract remaining posterior tract?
Hello.
Posterior part of the tract is to be curated or not?
No. Of course, we'll be going to curate the tract. This is just I'm ensuring the hemostasis, and what I'm going to do is just not to make the external opening little more wider. Forceps, है ना? So that forceps, so that it drains well, and just fulgurating rest of the tissue.
Why don't you prefer complete fistulectomy in this patient, sir?
Hello?
Sir,
Yes.
you have done fistulotomy in this patient.
Yes.
Why you had not done complete excision of the fistula tract, fistulectomy?
No, see, the thing is, we have got both the procedures in our armamentarium.
Yes, sir.
And if you see the literature, the results of fistulotomy are not less better as compared to fistulotomy. They are either equal or more better than the fistulotomy. So there is no external advantage you are going to get in such a superficial fistula after doing a fistulotomy, except for that fact ki, like if you want some tissue to be sent for this thing for some histopathology, for that tissue also you can get from the this thing debridement if you want to send.
So posterior wall which is left behind, you will curate it.
Yes, I am doing that only. Abhi.
Okay.
And it's not a very thick,
Tract.
the
Yes,
posterior
sir.
wall is not thick. In fact, before the surgery also I could not feel that.
Yes, sir.
It was a very, very soft kind of fistula, not a very old fistula. It was a new fistula. It was not an old fistula. The age of the fistula was not very old, so it was not very thick.
So after curate, you are planning to lay open and keep it open like that only, or
Yes,
whether
yes.
you will apply some loose stitches, sir?
No, what I'll do is I'll do the this thing first, maintain the hemostasis, and this thing I'll take one suture here on the mucosal aspect where the internal opening was there. Rest of the tract I'll leave it open. I'll clean this first.
Sir, if you keep the cut edges like that, the skin edges will be inverted and that delays the wound healing. Rather, it will remain for the longer time or lifelong.
No. See, some like to do marsupialization also. So we can do marsupialization also.
So are you going to do the marsupialization in this case?
No, marsupialization is not required actually in this. No? This is very superficial tract.
Okay.
There are certain situations where marsupialization is required. If you see, I'll just take a simple suture. This wound will be like this only. I'll first clean the wound with the hydrogen peroxide, put a betadine, and just take one suture here. And this type of wound is only left. You see?
Principle of life is keep the thing simple for.
It's a simple fistula. If there is a more depth, then marsupialization will help.
Cases.
If the depth is more, then marsupialization is required.
Yes. Simple linear track, superficial track, a single track, not old age track, not.
Actually, my gold standard is the procedures are still the fistulotomy and the fistulotomy both.
Even if the ages, somebody is saying ki they gets inverted, even if ages get inverted, that is from the outside the anal verge, you are going to have a stitch.
You see, when I have removed the proctoscope, you see it is.
That is what I said. The mucosa has been.
You can see the mucosa is here only. It's very superficial and not a very deep wound.
Mucocute junction, the skin will heal faster than the external part of the skin. So at least you have to take one stitch at the
Rapid अंदर लगा लेता हूँ मैं. ये वापस लगाना scope, this thing scope, proctoscope, यही half circle.
Actually, we can leave it open.
Yeah, I'm leaving it open. This thing inside I'm taking where it is bleeding, na. Okay. I'm taking a suture there, one. That's it. Behind the
level of mucosa.
I have gone behind the internal opening, where the internal opening was earlier. That's it. Mop. This is only one suture which I am taking. Yeah, that's it. That's it. So the procedure is complete, and I'll just keep a gauge piece there, and that too. थोड़ा बेटर देना सिस्टर पर दे दो dry gauge piece. I'll keep a dry gauge piece there. नहीं नहीं अल्ट्रा नहीं बस हो गया बहुत बड़ा है पीस गॉज पीस बस दैट्स इट इसके ऊपर से ऐसे रख दे इसके ऊपर ऐसे रख दे टिंचर हाँ टिंचर ले ले टिंचर लगा दे चलो yeah I'm there on the mic I'm there on the mic yeah hello
yes sir
yeah thanks Dr. Rachit Jain he is the anesthetist with us for giving the anesthesia and taking out his
sir,
time
very
for
nice demonstration sir
Dr. Rachit, yes, thank you so much.
Thank you, sir.
He has taken out time for us. It's a very, very, I'm indebted to you.
Thank you, sir. Thank you so much.
Yeah. Yes. Dr. Rachit Jain.
Thank you, sir.
Yes, yes.
Over to the next study.
Hello, can we go to the other theater? Hello? Hello? Visual guy, please connect to the other theater.
Yes, connect to the
Hello? Can somebody give us the history for this patient? Wait, scrotum.
Hello? Hemant? Yeah. Hello? Can anyone hear?
Hello?
Hi, can you hear Hemant?
Oh,
can you hear?
Yes, yes, very clear and loud.
Okay, fine. So the thing is, this patient is a 64-year-old male with no comorbidities, and he has presented to us with protection of mass while defecating and bleeding per rectum.
Okay.
Also, he has complaints of pain. Since his age is more, we have to decide whether to just go for the treat the hemorrhoids, or we have to deal with the this thing also, fissure also. Because if he has got an anal spasm, then only we should address the sphincterotomy. Otherwise, being this thing 64-year-old male, the chances of that chances are there that the anal tone may be less. So
Okay.
we'll assess it again before the surgery.
Does the patient had pain priority?
Patient had main complaints of protrusion of mass and bleeding per rectum.
Yes.
But there was an occasional pain.
Okay.
Pain was not the main symptom.
Okay.
Yeah.
So what? Who is going to demonstrate?
The plan is to do transanal suture hemorrhoidopexy,
Okay.
which either I'll do.
Hello. Hello, OT.
Jiten?
Sir, who is the operating surgeon?
Hello.
चलो ठीक है सर, सर और भी कैसे रहने दो, आ जाओ।
तिकडे कोणती आहे आता दुसरी केस
मध्ये कॅमेऱ्याच्या मध्ये आहे, कॅमेऱ्याच्या जवळ आहे।
Doctor sir.
माइक किसको लगा वो बता दो सर। वो मेरे को बताओ, मेरे पास माइक है।
Dr. Ramesh.
सर माइक लगा।
Hello, Dr. Ramesh. Are you there?
yes 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 करो
Dr. Khurapati sir.
बाद में करेगा हेलो
Yes sir, Ladukar
hello
sir.
हाँ yes actually this case is of it is written over there that it is a case of fissure with internal hemorrhoids. Dr. Jiten Chaudhary is to demonstrate. I will be assisting him, and if the picture is being seen over there, are you seeing the external picture? Hello.
What is this case sir?
Case is internal hemorrhoids, internal external hemorrhoids, what I see externally. But it was written over there, jelly. Now Dr. Jiten Chaudhary will be demonstrating the case. Hand over this mic to Dr. Jiten.
सर एक मिनट
मैं पीछे हट जाता हूँ
निकल जाओगे सर वो से
Sir, what is the plan?
हाँ वी आर प्लानिंग
एक मिनट सर, एक मिनट।
जस्ट अ मिनट हाँ जल्दी देना हाँ सो द पेशेंट्स एनल टोन इज नॉट हाई तो वी आर जस्ट गोइंग विद द चिप टेस्ट प्रोसीजर गॉश पेज देना डॉक्टर चिप टेस्ट ट्रांस एनल सुचर हेमरोडोपेक्सी एक हाफ सर्कल दे हाफ सर्कल बोलते ना प्लास्टिक का हाफ सर्कल ये पूरा प्रिपरेशन ठीक नहीं हुआ इसका एज ज़्यादा था इसका एनिमा नहीं दिया क्या एज ज़्यादा होता थोड़ा सा प्रॉब्लम हो रहता है ये सब दे रहा हाफ सर्कल यही दे देना चलेगा इसे क्लीन कर लेता हूँ नहीं एक मिनट थोड़ा करते हैं क्लीन हो जाएगा
क्या बोलो
है सर
इसको फिशर नहीं है ना
नहीं तो
इसलिए पेशेंट को एनिमा देते हैं
हाँ हम लोग भी देते हैं मैंने दिया बोला था पता नहीं लाके दिया नहीं लगा हैं इनिमा नहीं दिया लगा नहीं इनिमा भी मैंने लेके आया हुआ था क्रेमलेक्स तो अलग चीज़ हो गई यार मैंने सुबह भी बोला था सुबह भी बोला था मैंने भरत
अरे कर ही नहीं पाएंगे
हाँ
अच्छा एक काम करो सर उसमें एक गॉस्पिट डाल दो
नहीं ये सही क्या ना ये तुमको इसलिए मैं बोला था तुम लोग जो है इंस्टेड ऑफ 9 o'clock तुम
सर
अपना इतना लेट से आ रहे थे
नहीं ये ऐसा निकालना अच्छा नहीं है
हाँ।
ये डाल दो अंदर
हाँ फिर बाहर कैसे
हाँ we can do it we can pull it out after this surgery we can pull it out that is the easiest process ऐसा होता है
देखिए क्लीन करना इसको
काही जरूरत आहे त्याची या सर्जरीला काही जरूरत नाही डिलिंग विथ फिकल मॅटर है अभी कौन सा वायर चाहिए नो स्टरलाइजेशन इज रिक्वायर्ड
अभी भी आ ही रहा है
गुड
क्या सर अभी भी आ रहा है क्या नहीं आ तो गया लेकिन अभी भी आ रहा है ना
अरे यार अरे पेशेंट प्रिपेयर ही नहीं है
हाँ पे ये ना तुम्हें इनिमा नहीं दिया था भरत, मैं तो लाके रखा भी था सही, मैं क्या कर सकता हूँ ना वहाँ पे, तो भी पता कि हमने इनिमा रखे हैं और सुबह
सर पहले डायलेट करा पूर्ण,
हाँ
सो इट विल कम इजीली।
ठीक है,
डायलेट करो।
बहुत है नहीं ये, इट्स एन रिलैक्स टोन है, रिलैक्स टोन है, ज़्यादा कुछ नहीं है, पूरा भरा हुआ है इसका। हाँ थोड़ा सा अच्छे से देना, तो पतले निडल से मत दे, थोड़ा ठीक से खोल ले यार, और क्या निडल से करके देते हूँ सर। पता है यहाँ पे क्या हुआ है कि कहते हैं कि हम लोग वर्कशॉप में बिजी हो गए ना, मैंने अपने हॉस्पिटल से लाके भी रखा हुआ था, और क्या करेंगे।
Sir, Rate sir is there.
Hello, you have to wait for 5 minutes, only 1 or 2 minutes, not 5 minutes.
Okay,
Patient
sir,
is
we
not
will
being
wait for
well
2
prepared.
minutes.
We have
Sir,
to
this
shift
is
the-
last case or what, sir?
No, it is not last case.
So what is the other case? What are the other cases pending, sir?
Are we, 5 more cases are to be done. Vikas.
Yes, sir.
Hello.
Yes, sir.
5 more cases has to be done. Please wait inside.
Yes, sir. We all are waiting here.
Yes.
Hall is completely full.
Okay. Thank you.
Sir, Kodwani sir is asking something.
तिकडे कोणीच नाही म्हणते हॉलमध्ये.
लाईट जाऊ द्या खाली, जाणार नाही परत.
असा घ्या खांद्यावरून घ्या लाईट.
लाईट 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 हां असं हां. ते काय होतं झालं त्या ट्रॅक स्ट्रेच होतात
म्हणून तो बायवॉल पाहिजे. बायवॉल
हां. आपल्याकडे बायवॉल स्पेक्युलम नाही का? असं बायवॉल स्पेक्युलम नाही आहे ना. हे दोनच असते, त्याला स्ट्रेच आणि ओपन केला जाऊन जातो.
हॅलो हॅलो, am I audible in the hall?
जमा झालं की सगळं.
इथे ॲब्सेस कॅव्हिटी आहे का? इथे
पर्यंत आलं ते पर्यंत आहे.
इथे ॲब्सेस कॅव्हिटी आहे. इथे ॲब्सेस कॅव्हिटी आहे. अँटिरियरली तर नाही गेला असं आता.
अँटिरियरली फील नाही होत का? आहे तिथे आहे ना.
नाही आहे आलं पण ते दिसून नाही राहिलं.
मला वाटतं आता आपल्याला काय करायला, काय घेतो तू? हेच घेतो ना. आणि एवढी मोठं ट्रॅक अशी अशी आणि अशी झाली ना ती. तिला मल्टिपल ट्रॅक असल्या पाहिजे, कारण तशी 2 ओपनिंग आल्या तिथे.
तसं एक मॉस्किटो द्याल तर आर्टरी.
मॉस्किटो हे टाकतो का?
हॅलो
टाकतो का?
हॅलो.
नाही नाही, त्यांनी तर हमखास हे होईल. जर माहीतच नाही आहे इंटरनल ओपनिंग
काहीतरी होऊन
ते
जाईल.
तर हां
इंटरव्ह्यू आहे इथे. इथेच असेल इंटरव्ह्यू. हे इथे इथे असेल. हे इथे ते लागते तिथे इंडोरेशन लागते.
तिथून आपला डाय पण नाही आला ना.
ते साला काय होतं, हे आपण टाकलं की त्या ट्रॅक ऑब्लेटरेट होतात, अशा ओढल्या जातात. त्याच्यामुळे मग तिथून ते
द्या तुमचं सिम्स द्या बरं. ते द्या
वरती.
हॅलो.
हां शक्य आहे, शक्य आहे.
हॅलो
हॅलो हॅलो.
येस.
Hello, Dr. Sonavne from the hall, sir.
Sir, good afternoon. Dr. Rahate speaking from OT.
Yes, sir.
This is a complex fistula, 2 outer opening and 1 internal opening at 6 o'clock most probably. I have put in a dye, hydrogen peroxide, weak hydrogen peroxide, but there is a cavity here.
Okay.
At 2 o'clock.
Okay.
So, is the vision proper there?
Yes, yes, very much. Was any MRI done?
Probably not done.
Okay.
I am putting very little hydrogen peroxide. We'll see whether it comes through 6 o'clock, because I can feel the opening there at 6 o'clock. But definitely there is a cavity here. You can see I am pressing that cavity, and abscess cavity might be there. It is getting accumulated there. So let us see how is the anatomy.
Okay. What is your plan?
My plan is to open.
Okay.
Gauze piece. I will put in methylene blue, weak methylene blue solution. Since internal opening is not dogmatically seen, it is better to explore. खूप नका टाकू सलाईन.
Is it just a chronic abscess cavity with 2 openings?
Yeah, there is history of previous surgery. You can see the scar here. A previous fistula was done on the right side. Now he is having recurrence on. होऊ शकतं. That is a good idea. See, very little of
methylene blue I have instilled. I don't know whether it will come into the internal opening or not. So I will start exploring.
Okay.
We will take both the opening, outer opening. What will you do? Will laser work here?
I would like to have a MRI, sir, first.
MRI,
We
yes.
have the anatomy cleared.
Yeah.
And if there is a big cavity, what's the use of using laser?
You are not audible properly.
Yeah.
Hey,
If the
आवाज
cavity,
वाढवायला सांग.
if the cavity is big, can you hear me? Hello?
My options are open.
Yeah. If the cavity is big, what's the point of using laser there?
Okay, yes.
Correct.
Yes. Release the sister. Yeah. I will turn a bit on right side of the patient so that I will not come into the vision of the camera. जसं इकडून या एक रिट्रॅक्टर घेऊन छोटे 2 रिट्रॅक्टर्स लागतील.
नाही का सर? That is the only.
See here
Yeah.
the
We can see
material
it clearly.
Yes. So that means it is not going towards 6 o'clock, it is going somewhere else. Let us see.
अरे वरती चाललं का रे ते? ते भरलं होतं पूर्ण ट्रॅक्ट हा? वरती चाललं. पाटील आले.
नमस्कार. I think I will have to excise the cavity.
Yeah, it looks like.
Set-on is also a good option. If the internal opening we could see by pulling or giving a tug over the fistula, and if there is a dimpling internally, I will have to do a big repair work, I think.
हो.
जसं इकडून या तुम्ही, इकडून या, रिट्रॅक्टर घ्या. मला हे छोटे एकदम ENT वाले नका देऊ. कॅट्सपो नाही चालणार सिस्टर इथे. तुम्ही मला कमीत कमी मोठे रिट्रॅक्टर्स द्या. लावा, कमीत कमी लावा ना सिस्टर. ट्राय टू असिस्ट. So this is the cavity which we have reached. Sir, sorry. बस असं ठेवा.
Is a part of it going down?
No, it is going up. Too fragile.
Sir, the patient has external opening at 3 o'clock.
Yeah.
External opening is at 3 o'clock, yes.
Single opening.
Clinically, it appears that 6 o'clock is the internal opening. There is some rough area there.
There, yes.
But after putting hydrogen peroxide, I
Yes,
could see a large cavity there at 1 o'clock, 2 o'clock position. Sister, retraction शिवाय होणार नाही.
Sir, internal opening at 6 o'clock.
See how fragile is the tissue. This is the cavity which I am holding now.
Yes, sir.
नाही, तुम्ही जर असे जर झाले ना रेस्टिंग पोझिशन मध्ये
Sir, will you extend the skin incision?
Yes, I will have to. जर्नीस सारखं मोठं नाही आहे का? तर बोलवा ना, घ्या ना सिस्टर. So what do you think, Vikas? What should be done?
Sir, so Dr.
Yes, sir.
Sonone here, I feel there is an abscess cavity and there is a track going down.
Yeah. Let us see what is the surprise here.
It is a large cavity, I think, sir.
And Jiten has absconded after giving this case to me. Huh? He was knowing that this case is going to be difficult one. तसं मला मोठे द्या ना रिट्रॅक्टर झाले. I think I have reached the upper part, upper level of the cavity.
At present, only 3 o'clock external opening is there, and sir is doing the coring of the fistula. And a large cavity is there, and sir is searching for Jiten.
Yes, I am searching for Jiten. Seems there.
Yes.
See, the sphincter part is coming now. Huh?
Yes, sir.
Pull.
Not. Could be there. It could be perianal venous also. Going up to ischiorectal fossa.
Gauze piece. Lot of edema there and fragile tissues.
Under, partially, ischiorectal.
One more, Elise.
Perianal sinus are always.
Somebody will have to wash for this olive.
मसल मिला सर. नहीं सर, स्किन इंजन बहुत छोटा है.
I am morally supported by Dr. Ladukar sir and Dr. Kanekar sir.
Morally supported. We are learning from.
Hey, I got Jiten.
Yes, sir. So you got internal opening.
He is absconding what he has ordered.
Yes.
See, I am above the cavity and now that thing is turning up what Sonone sir was projecting.
Perianal sinus. नहीं ऐसा जाएगा, नीचे जाएगा.
No.
अभी नीचे जाएगा.
वो आपकी कॉटरी अच्छी है भाई.
जिसके हाथ चल रहे हैं उसके ऊपर डिपेंड है ना.
So this is the sphincter here. Huh? This is the sphincter. Can you appreciate?
Yes, very much.
नाही. प्रोब किया तो फॉल्स पैसेजेस होने के फुल चांसेस है. The tissues are very fragile. See, the fistula is going in this
Yes, sir.
particular fashion now.
वो ऐसा घूम के ऐसा 6 o'clock ही आ रहा बॉस.
My hand is coming in between. अच्छे से ये बड़ा लगाओ ना यहाँ पर प्लीज.
इसको लगाओ बड़ा इसको ऊपर का.
Sir, we came for such cases only. What to do in such situation?
यार हमारा
Yes,
my
sir. To
adrenaline
be
is
learned by
rising,
a
ना?
big surgeon like you.
My adrenaline is rushing, but so Elise, you got Elise? ट्रॉली पे कोई नहीं आया. इसको मेरे को रिट्रैक्टर दो ना. Zernies, any Zernies type. चलो ठीक है. The armamentarium
is better, then we can operate better. Otherwise, difficult.
Yeah.
Sir, it is going deep to ischiorectal fossa, sir.
Let us see, fingers crossed. Pray to God. Sister, do you have some retractors, better retractors? I will wait for the retractors to arrive, because this type of surgery without good armamentarium, it is very difficult, no? Yeah, thank you very much. नहीं, डेप्थ में होना, ये नहीं है. These are abdominal wall retractors. जर्नीज नहीं है, जर्नीज कुछ नहीं. Let us hope it will help us. Okay. So sister has helped me.
अभी आ गया अच्छे टिश्यू में अभी आ गया.
See, Ellis tissue is becoming useless here because of the fragility.
Sir, slightly louder, sir.
Yeah. Because of the very fragile tissues,
Yes, sir.
The Ellis forceps is not working.
Yes, sir.
The tissue breaks. Yes.
Is it a fistula or a sinus?
I don't know.
It's like a chronic abscess with a sinus.
I think it is abscess and an external opening. I don't know whether it will be opening down there, and that is the reason why I have selected this particular procedure. Previous history of fistula surgery is there, but that is on right side.
May not be the recurrence.
No, it is not a recurrence. This is on new disease on the left
There
side.
should be undrained ischiorectal abscess, sir. Now you are reaching to the ischiorectal fossa. Now fat is coming. We are seeing through your lens, sir.
Okay, so sorry. ये इसको तो जरा
अंदर जाना बॉस देखो हो गई हाँ 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 सी हाँ है ना
नहीं सिस्टर तिरछा नहीं होने का, वैसी ही पकड़ने का। रेस्टिंग मोड में गया हाथ कि रिट्रैक्टर का यूज गया।
Sir, is the patient investigated before MRI?
नो, जिससे मेरे को डीप रिट्रैक्टर्स होना ना, प्लीज हेल्प मी।
Right angle there.
हाँ यस यस यस, दैट्स ग्रेट।
Sir, do you feel that a pre-operative MRI for this is important because already patient has got one surgery, even if it is opposite side, it is important?
Yes, yes. It is definitely important. The dictum which is followed by now, because of the various legal cases which has happened, because of not doing MRI, we should do MRI.
Either it is a recurrence of the same site or some opposite sites or immediate of previous surgery and afterwards, there are some indications for either MRI or transrectal or transperineal ultrasound.
Agreed.
Perineal ultrasound. Transrectal or perineal? In dynamic perineal ultrasound is also very good. Very few people do it. If you have got a good sonologist, they will do it.
Now I will see at what level. No, the rectal wall is aware. Rectal wall is still aware. Sir, असर resting नका करू. असंच पाहिजे. Resting. No, okay. This tissue. Yes, yes. आणि suction लावून द्या. Suction करा. Gosh, please. नाही, पुन्हा resting गेला तुम्ही. रेस्टिंग गेला की हा इकडे येतो ना, इथली स्पेस कमी होऊन जाते. मला हे पाहिजे रिट्रॅक्टर. Section. This is तुटला. काढा काढा. नाही 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 तुटला, नाही तुटला. Here is the ischial tuberosity, so there will be limitation of retraction from this side. So it will be better if I go from down. Don't give much traction, otherwise it will break up. Are you seeing anything inside? जिससे उड़ा ना. So which is this artery? Artery. No, we mosquito है. ए दादा उड़ना. ठेवला ना आज? तर याला पकडा. हे काय आपण. नाही नाही, तू नाही पकडायचं. So I caught hold of that artery and going to fulgurate it completely because it is a big artery and that is at the level of the, it is beyond the ischial tuberosity, so that might be a branch of pudendal. Yes. For getting access, I am enlarging the wound. जा दादा और सर तुम्ही इकडे या. नाही इथे 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 इथे. If you can retract this. नाही तुम्ही तिथेच थांबा सर. तिथेच थांबा तुम्ही.
नाही अजून चाललं त्यात मध्ये. हा काय म्हणाला? अरे बापरे.
सर सांगा ना आम्हाला मग. Just a gauze piece there. Okay, now we have got the MRI, which was previously done. There is no connection with the anal canal, they say. नाही पॅक करून ठेवा ना सर.
थोडं थांबून 2 मिनिटाकरता. अजून चाललंय ते आतमध्ये. है ना
सर? आता चांगलं दिसत आहे मला.
येस येस.
बेटा असं असं ठेवा.
आता हात
बस
बदलला
बस
माझा.
बस बस.
माझा डावा हात.
होते आता या वयात.
या वयात काय काय होतं राजा. सक्शन सक्शन लागेल खाली.
दोन्ही हात फुल काम करा.
सर इट इज गोइंग डीप.
असं ठेवणार रे.
अरे बापरे. इट इज
ऐसा
असं. हां
ओढ जोरात. सर इसको अंडा लावून देना.
नहीं
हां
नहीं.
और ट्रैक्शन.
नो ट्रैक्शन.
This is part of the fistula which will go in for.
ग्लैंड पूरा क्लोज है. पण थोडी पालपेट फ्रॉम इनसाइड ना.
Yes, yes.
पालपेट करून आपण नाही त्याची.
I think I will do curating there.
Yes sir.
So curate there.
Sir, have you done PR examination, sir?
PR examination is not helpful. It is See, this is the rectal wall.
Okay, sir.
It is going posteriorly into the rectal wall.
Sir, so this is pararectal space, sir.
You know the anatomy better.
Rahate sir, can you try and put a probe there and see?
I think I have gone above now.
Yes, sir.
Above the fistula, yes. हे ब्लड गिरा ना फटाफट सब करून टाकायचे. एक I have kept one gauze piece. Please remind me. Yeah.
Okay.
Yes.
Sir, is there any cavity inside, sir?
तू यांनी दोन्ही काम करतो, सक्शन पण करतो, ट्रॅक्शन पण देतो.
Last part, sir.
So now you can see that I am above the upper level of the fistula. Are you appreciating anything seen inside?
Whitish tissue, sir. No blue or red is seen.
काढलं ना आपण पूर्ण काढलं आपण. कधी कधी रेफरन्स होतो आपल्या हातात.
So this complete excision is final. You can see this was the external opening. You can see.
Yes, sir.
This is the external opening, skin part, the fistula, cavity, and two more little parts which were above the levator. So no connection with the anal canal. So the MRI person, the radiologist, was good in reporting.
Sir, MRI was done, sir?
Yes, MRI was done. That is what I just got information, and they told me that there was no communication with the. दादा याला कर ना याला हे तुम्ही. See, we can see the artery. नाही partially thumb. नाही वर आहे कर दादा. Okay. So Navnesh sir, what is your retrospective saying now with this type of anatomy? What should have been done?
No, this is the right thing that you have done. Nothing else could have been done in this.
Pardon?
Case. Nothing else could have been done in this case. You have done the right thing.
Thank you so much. Should I close down the wound?
Yes, sir. Loosely. Cavity to be obliterated, sir.
See, इथे ठेव retractor ठेव एक. Absolutely no connection with the rectum.
Sir, how far is the ischial tuberosity?
Very close. See, this is the ischial tuberosity here. Here, and I could palpate the complete inferior rami and the ischial spine from here. Because you have seen the pudendal artery bleeding, no?
Okay, yes sir.
So hemostasis is there now. So what is the opinion of the house? Should I close it?
Sir, you should obliterate the cavity, sir.
Partial closure we will do it. Obliterate the cavity, keep the outer wound open. Just approximate. That's all.
Yes, sir. Sir, one of the question is whether the past surgery was done by bilateral septa block or spinal anesthesia.
See, this is the scar here.
Yes, sir. Scar is on the right side, but if they have done in under local anesthesia, so that needle may cause this infection.
No, it was around 2 years back. So I don't know whether that is contributory factor.
Sir,
What
are you
that, sir?
hearing the applause, sir?
Okay. Saline betadine wash. Kanekar sir has suggested how? That we should give a proper wash.
Yes, sir.
See, I could palpate the prostate here.
Sir, so how is the lobe?
Prashant,
Yes.
Prashant.
Yes.
You have palpated this prostate from the neo-anus.
No. No. I will give, I will ask Dr. Ladukar sir to tell whether what is sir prostate pa. Right. Straight and up.
Sir, please confirm the bleeding.
Please confirm what?
Bleeding.
Bleeding. See? No bleeding now?
Yes, sir.
Okay. I am not going to disturb the rectal wall.
Yes, sir.
And that was the reason why I am reluctant here to give stitches.
Because nothing is running from inside. है ना? This could have gone for
Scissor
Sir,
lobe.
very nice audio visual and picture quality, sir. Thanks to Jitin, sir.
Very loose stitches, no packing. Because on medial side, the rectal wall is there.
Yes, sir.
So I don't want that wall getting into problem.
अजून किती केसेस लावता आले तिकडे अजून कोणते केसेस इधर की केस देखो कौन सी है तो बची हुई
Sir, what is the next case?
Yes, we will tell you.
See, these are called as purse string obliterating sutures.
Okay, sir.
इकडून काढून
They,
परत असा टाकला ना.
they have better tissue approximation.
परत टाक तशीच एकदा.
Sir, very nice demonstration of this difficult case, sir. Most of the time we all came across such type of cases.
Thank you very much, Vikas, for giving me some solace. So these are the purse string obliterating sutures.
Yes, sir. Double. Shanti madam want to say something, sir.
Ask her, don't ask difficult question.
No, sir. It's very nice demonstration, sir. It's enough, I think. No need of putting another sutures or anything.
Thank you so much. Thank you so much.
So, Jitin, we want to go to next voting.
Yes, that is what I also want.
Jitin is Gayab.
Audio visual, the second case is ready or not?
Case is ready.
They are saying that there will be
Sir, Rahate sir, how often you see only sinuses without communicating with the
very
anus?
rare, very rare.
Very rare, yes.
प्रायमरी हे केलंय का स्पिंटर रिपेअर करतो का बरं आता कधी?
हो, हो,
हो ना?
हो.
जेव्हा स्पिंटर पण काढतो तेव्हा विथ PDS or 20?
PDS 30.
पण काहीतरी ओपन ठेवावं लागेल.
Rarely. Rare situation, rarely. Rarely right. Common things are common.
ओपन होतं चालू बरं जमा.
Only 2 or 3 stitches I will be giving to, so that the pain and the volume of the
Volume
wound
already
decrease.
reduced it, sir, with your
Yes, already
stitches.
reduced. इसको दबा. नहीं, वैसे नहीं,
Usually
वैसे नहीं.
taking of the skin stitches you prefer, sir?
Yeah, I am just approximating it.
Not here, regularly in your practice if you do any
No,
open...
no, open, I keep open.
Yes.
I think that will do.
Yes, sir, enough, sir.
Enough. Thank you so much.
Thank you, sir, thank you.
Thank you.
पण त्याला हे चौकन संबंध नाही की हे
नाही,
आपण जेव्हा
काही नाही,
मगाशी
काही
टाकलेलं
नाही.
ते
हां.
आलं कुठून होतं आतमध्ये?
काहीतरी असेल त्याला कनेक्शन.
ते त्या केसेसमध्ये ते कळतच नाही त्याच्यामुळे सेकंड बेस करत आहे.
Anyone from Voti?
Yes.
What are the other cases now planning?
It's not seen. आवाज भी नहीं आ रहा उसका पिक
Yeah, Jatin?
इंटर
Nothing,
जा नहीं रहा
So, what procedure you are planning for this case?
हाँ I'm doctor first
Yeah?
And massage this patient. Give a steep head low position. I request you to give a head low position, little steeper one. Yeah, that's fine.
Suture hemorrhoidopexy.
Yeah.
Stapler.
Now I'll put this. हाँ लेना पड़ेगा. Yeah. I'll keep this in position for a minute or so. It'll empty the external component of the pile mass. थोड़ा सा और नीचे कर लो. टेबल थोड़ा सा नीचे कर लो.
टेबल और नीचे करो.
Yeah, that's fine. That's fine.
Dr. Jitin, do you strap for your stapler hemorrhoidopexy or not?
No, I'm not doing stapler hemorrhoidopexy, and as such, I don't strap in that cases also.
Okay, so you don't do strapping of buttocks for any of your cases?
I do for pulmonal sinuses. हाँ नहीं पकड़ नहीं रहा हूँ ये. हाँ थोड़ा सा और प्रोक्टोस्कोप डालता हूँ थोड़ा सा और अंदर. हाँ निकल जाएगा. Yes. Yeah. I'll just keep it for another minute. हाँ उसका ट्यूबिंग.
This eye position I want. You learn this position. This is my position. You have to learn this. Give it to every patient. If I don't need, I don't the skinning.
तो व्हीकल रेडी है जरा लोड कर ले. हाँ एक बार लाइट आने दो कर लेता हूँ. हाँ रेडी. लाइट ऑन. कितने पे लाइट सेटिंग. धीरे छोड़ना. Yes. See, now you can see that pile mass has got reduced. ये दूसरे का है.
So do you need it surgery?
It will come again if I do not do that surgery.
With the hands of Jitin sir, pile mass has been already reduced.
It's basically the trick. The trick is basically to make the patient steep head low and keep that pile in the inside position for 2-3 minutes.
Everybody thought you are a surgeon, you are a magician. Doing tricks.
See the big pile masses you can see. नहीं एक मिनट सर ये इसका पकड़ना ये केबल ठीक से लग नहीं रहा उसमें. क्यों नहीं लग रहा. I'll come again. ये इधर लेके आ जाना उसको. एक बांध दे किसी चीज़ से. गॉचपी से बांध देगा तब भी चलेगा. बांध देना. I'll start. Savannah. Again. ऐसे ठीक है ना. ऐसे ये पोजीशन में दिखाना मेरे को. ठीक है ना. कैन यू शो मी लाइक दैट. हाँ या. Is the image clear?
Yes.
Yeah. Vehicle 20. ऐसे ऐसे ऐसे, ठीक है ना, दबा के नीचे ना, हाँ देख ना, ऐसे ऐसे, like this. So we are well above the dentate line, so I'll just start from here itself. My bite basically taking the mucosa and some mucosa.
So you are taking the first upper row.
No, 6 o'clock. I am starting at 6 o'clock.
6 o'clock.
I hope you are not doing Shirsasan.
No. 6 o'clock. Upper row means, is it 2 centimeters line or 4 centimeters line?
This
first
is
line
this
or
is around,
second line?
This is around 3 centimeters.
So you are going, you are coming from upwards down.
After this I can take little this thing, another line which will be upper.
More than that.
Yes.
Okay, if you are 3 centimeters away from the anal verge, how come it is very near to that pile mass? It will be, usually the prescribed thing is roughly 2 centimeters, no?
No, see, the thing is, after I am done this procedure, we'll reassess whether I have to go above or below. I am just giving in this thing.
So then you will decide whether you will go up or down.
I have just taken a stitch.
Okay.
I'll complete the circle and then I'll decide and then do this thing. So
usually we start roughly around 3 to 4 o'clock.
Yes. No, this bite, if you see, I'm taking just going just behind the first bite, and my hand is doing, my wrist is moving. I'm not pushing it anything. And this is coming out, and I'll do double interlocking. Clean करते रहे हर बार ना. Yes. Mop.
Half circle needle you are using, no?
This is 2317 I'm using. Which Dr. Chivte uses. I think Dr. Ladukar uses a different kind of needle. See, हमारे पास enough space है. We can take a second line beforehand only. है ना sir? Dr. Kanekar sir. है ना? We can take second line here in the मतलब above below that. जहाँ पे ले रहे हैं ना? हाँ, काफी ऊपर है ना? 4 centimeters, है ना? Almost 4 centimeters.
Yeah, almost it is 4 centimeters.
Yeah, almost
so
4 centimeters. So another line will take nearer to us.
You have to come down.
Yeah, I'll come down. One throw, second throw, and just press it again.
Usually taking too much inside is also not advisable. It won't.
It is not too much inside.
No. Whatever you are doing is correct. No, usually.
Yeah, that is there.
The purpose of devascularization won't occur in a proper way if you go too much higher.
Yes, you are right.
You are in proper distance. This is the first row and you will come down for the second row.
Down for the second row later on, yeah.
Yes.
ऐसे नहीं, एक मिनट देखना, देख ऐसे हाँ, जल्दी घूम के भी कुछ फायदा नहीं है ना.
No, ma'am, you are doing very
Kaneka sir, if I am wrong, so you can guide me. Yes.
So always holding the needle 1/4, 3/4.
Yeah. So we just keep on pressing that needle, not the knot. After taking double interlocking knot, we just press it. And the basically we have to ensure that we are not leaving any part behind. So this suture, I just pull it and try to tent it, and then I'll go just behind that.
Jiten, the proctoscope which you are using, this one,
yes,
is the older version of Chivte's proctoscope, and sir has recently come up with new kind which has got the initial collar is more wide, so that it covers the cushion mass of the hemorrhoids, and while rotating this proctoscope, the edges, open edges of that window does not damage the hemorrhoidal mass. Have you come across that? Do you have that proctoscope? But not in this case, but in some bigger pile masses, the bleeding is there. Yeah.
Yes, yes.
एजेस से ब्लीड होना चालू हो जाता है.
हाँ, this is near model.
Yes. And for that you need to have some retractor or tongue depressor like instrument to.
Otherwise we cannot see that bite where it is
You
going.
cannot see beyond.
Yes.
Yeah. Yes.
Yes, yes. I'll do that, Abhi. Abhi, we are just at around 10 o'clock, na? You know, dilate करते रहते दूसरे ना some on this thing. एक ऐसे. So we are up now approaching the 11 o'clock. So here we have to basically, it's mainly a wrist work now here. See? I'll go just behind this. And my I'm trying to be gentle so that there is no injury to the mucosa. And pushing the knot here to make it tighter.
Hello, Jatin.
Yes, Shanti.
How many cases are there left over?
I think 3 more cases are left.
What are those?
One is pilonidal sinus and the rest 2 are piles. You want to operate any of them?
Only we are completing those 3 cases.
No, you want to operate any of them?
No, no.
ऐसे.
Are you going to do pilonidal sinus today?
Yes, pilonidal sinus today.
Okay.
Yeah. So every knot is a double interlocking. And knot I push like this. Yeah. Dr. Shanti, any suggestions?
Yes.
Dr. Kanekar, any suggestions? Good. ये कौन सा सूचर है? कुछ है ना दिख रहा है? इधर का नॉट घूम के आ गया. हाँ. ऐसे 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 ऐसे. Just behind the suture I go and take it. Please mop, please. Mop, please. करने का सर आया नहीं क्या? पकड़ना. घुमा. इसको ऊपर से ले लेना. हाँ. ये स्कूप नहीं लिए क्या? नहीं स्कूप नहीं, स्कूप और दिखाने के लिए ना ऊपर का लाइन लैप्रोस्कोप रहता ना. This is the largest pile mass, that is why it is bulging out here. एक बैबकॉक देना. क्या? ऐसे रखो. या. Mop. नो इसका सूचर का लेंथ कितना है? हाँ 90 सेंटीमीटर। हाँ लेना ही पड़ेगा। सूचर छोटा पड़ रहा है। दूसरा धागा कहाँ? हाँ या देखिए आठ है ना। तो यहाँ पे बंद कर सकते हैं ना। या वी कैन जस्ट टाई द बोथ द नॉट्स हियर। क्लीन कर ले। आई एम जस्ट गोइंग टू टाई बोथ द sutures. Mop. That completes my first layer at almost 40, that was at 4 centimeter approximately. I'll be taking the next layer, something little more proximally, rather distally from the, ऐसे. दूर से नहीं. या नहीं ये भी हटा ना, अभी हटा ले इसका.
Hello, Jatin.
Yes.
So, can we move to next OT?
Yes, please.
You tell that.
I've done with the first layer, and I'll be repeating the same.
Yeah,
on the second
already
side.
same
Yes.
repetition, no? So
Yes,
we'll go
same
to
repetition,
another
yes.
OT.
Yes, yes.
Tell that audio video man to go to another OT and
Yes, yes,
start from that OT. Anybody is there inside with you? Tell that cameraman to go to that OT.
नहीं कौन है? हाँ. अच्छा शांति.
Yeah.
वो second OT में there is little time for the preparation.
Time लगता है.
हाँ हाँ 10 मिनट लगेंगे.
Not yet ready.
Not yet ready.
Okay.
कौन है बताने देखो.
So now you are taking the first layer. Second layer.
Second layer, yes.
So when you will going to discharge this patient?
Tomorrow, same time. A little, yeah, by 12 o'clock also we can discharge.
Usually after doing suture hemorrhoidopexy, how long?
See, I like to keep my patients overnight. Tomorrow morning we can discharge him. So
Okay.
normally I come to the hospital for round at around 12 o'clock. At that time, I see the patient and discharge him.
Okay.
Uh-huh.
How long you will going to give the laxatives for this patient?
Laxatives, basically I like to give them for at least 15-20 days.
Oh.
But advise them to maintain soft stools for at least a month.
Okay.
It's not that like when the laxative is over, he has the liberty to get constipated.
Vicryl.
Uh-huh.
You are using Vicryl only, no?
Yes, I am using Vicryl 2O on round body.
Yes. With half circle you are using.
Yeah.
What were the complications you faced earlier with this surgery? Frankly, from your side, what were the complications you have observed?
Yeah, see, complications.
Complication or otherwise
yeah,
any problem?
Yes, of course. See, initially while the complications which I faced while operating, and there are complications which I faced after the surgery.
Yeah.
In the post-op period.
After
so
the surgery.
While operating, initially what used to happen is like the pile muscles used to come in front of my field,
Yes.
and while going inside, the needle used to get the pile muscles used to get injured by needle, and then they used to bleed.
Yes.
Then they used to bleed, and then I used to cry.
Yeah.
it.
So now the newer version is having that advantage of compression of that masses, and our vision is clear
Yes.
to see and take the bite. Okay.
Yes.
During post-operative period, what were the complications? Because
In
many
the
people
in the
nowadays.
post-op period, I have seen this thing when sometimes initially I used to be over enthusiastic and used to take bites little more deeper. Then patient used to have little pain, and he used to find it difficult in passing motions for the initial few days. That I needed to dilate them. Put an anal dilator, gradual anal dilator. What I used to do is basically call them to my OPD, and on front of the proctoscope, I used to first apply Prilocaine jelly. It comes by the brand name Prilox. It used to get anesthetized, then I used to give a bigger dilator.
After using this much diameter, still you are using dilator?
In some cases, in some cases, what I faced in the post-op period, I am telling you that.
Okay, post-op edema.
I am not talking about my protocol. It is not a protocol. It is sometimes I have gone more deeper, and the patient had this thing anal kind of a narrowing. Or
Usually I do only finger dilatation when patient comes and presented with edema.
So what I used to do is put this thing Prilox jelly initially, and then put a bigger proctoscope.
Okay.
As a dilator.
Okay.
That gives an basically it's easy to put. Finger is basically a good thing, but it is little not subjective.
Sufficient.
Like you get a slowly. You start with a small dilator, then you can go to a bigger dilator. Dr. Shanti, what is your basically nowadays you are using more of laser, or you are using more of chip-taste procedure?
Usually less of laser and more of chivatis and stapler. And I am using Cetrol also for the second grade as a office procedure, and my results are doing good with internal sphincterotomy added, depending on the tone. So with laser nowadays I am getting lot of peripheral cases with some complications like fistulas abscesses, and once they are passing that laser probe inside, there is maybe because of the loss of control or using excessive lacing, more complications nowadays we are getting.
Okay.
But in the hemorrhoids, there if judiciously if we use it is good. But in
Is
the
it?
fistula,
You were basically known as a laser lady of Hyderabad.
not laser lady. Now I am changing my name. Yeah, I started using first.
Yeah.
So giving phone, giving mic to that.
Yeah.
Jiten?
Yes.
This suture material which you are using, this is having 30 needle.
Yeah, I am basically using a 30 needle.
We recommend 27 needle. So what you said, while entering, the tip of the needle may hit pile mass, may hit the bulged vessels, so that goes for bleeding. So if you are using 27 needle, that will, the chances of the harm will be less. Number one. Number two.
Say it again.
Yeah.
Say it
Number
again.
two. Jiten.
Yes, yes.
Number two. The maneuverability will be more easy inside a limited space. And number three, with this 30 needle, you are more tend to pierce the musculature beneath. So the chances of stricture will be more in this 30 as compared to the 27 needle.
Okay.
These are my 3 points which I observed.
Yeah, nice.
Any take from the house on this?
I think Doctor, see what I've seen, Dr. Ladukar uses a 27 needle.
Yeah,
5x8 circle.
we too use the same.
But there are people who are using the same needle what I am using. I think basically you used to get one used to get that, but I'll try with that also. And the suggestion is well taken. Mop. नहीं बहुत नीचे नहीं है क्या ना वो बहुत ये जिसको जहाँ पे बड़ा हेमोराइड है ना वहाँ पे लाइक बहुत मतलब बहुत नज़दीक आना ही पड़ेगा उसको ना नहीं तो वो है ना नहीं तो वैसे हो जाएगा दिस थिंग हाँ मेरे पास रेडियल फाइबर है ना हाँ है ना लाया ना मॉप हाँ चले ना सर क्या यूज़ करने वाला क्या करने वाला हाँ नहीं क्या केस क्या करने वाला अच्छा ठीक है करो ना सर मैं भी आता हूँ आई विल आल्सो जॉइन यू ऐड करने का यही पाइल में है थोड़ा ज़्यादा बड़ा है बेसिकली ना गए क्या एक आर्टरी देना ये जब स्टेन हो जाता ना निकाल दे उसको एक मिनट देखा ना छोड़ इसको ऐसे कर अलग फीचर से करने से क्या वही कुछ चलते सेम थोड़ा पीछे जाके करना यस एक मिनट नहीं करते थे गॉश पीस चेंज कर दो
लाइक 3711 जैसे उसमें लेते हैं स्टेपलर में, वैसा अलग लेते हैं स्टेपलर से। ऊपर लिया होगा। ऑलरेडी वैस्कुलरिटी पार्शियल ऑब्स्ट्रक्ट होता है।
Yeah. Like this.
बाहर का जो आता है वो भी दिक्कत है। नहीं लेजर का प्रिंसिपल PLPL ही है ना, तो ऑलरेडी प्रॉक्सिमल लाइगेशन हो गया है। लेकिन ये कि 3711 को अलग लेके फिर बूस्टर लिया तो नहीं चलता, पाल्पेट करके
डॉक्टर हटे
तीन लेने का और बाकी टूटे बूस्टर करके।
कुछ आप बता नहीं रहे सिर्फ यू नॉट टेलिंग एनीथिंग बताओ ना सर कुछ कुछ भी बताओ सर चलो मॉप
Jiten, whether another OT has prepared?
Yes, yes.
Which case is to be taken over there?
Dr. Sonavane is going to show pyelonodoplasty using laser.
Okay.
Mop. We are near thing. नहीं वो तो पुराना है Yeah. Mop.
और ये बात यूज करके वो थोड़ा ये निडल निडल होल्डर में स्लिप होता है वो बोल्ड हो गया, उसको और बोल्ड करके छोटा।
So this is the last.
क्या होता है कि 10 साल 5 साल के बाद होता ही होता है। अलग अलग
इसको अंदर से दिखाने का तरीका है कुछ
चल ये कैन यू सी द 2 layers? जूम कर सकते क्या?
Yes, Jitin, we can appreciate it.
That
Nice surgery, nice, nice
2 layers
results,
of
Jitin.
interlocking sutures.
You can hear the round of applause for Jitin.
Thank you so much. Thank you. And I want to thank Dr. Vaishali Ahire also for taking her time and this thing. She has come, she has, where is she? Dr. Vaishali?
Yeah, Jitin, thanks to Dr. Vaishali, Dr. Jitin, to your anesthetist, to all your team, Jitin. It's a teamwork.
Thank you, thank you. Chalo, ho gaya, it's done, huh?
नहीं sir.
Chalo. Yeah, you can just see the post-op picture. Yeah. हाँ, tremolo जनक. Yeah, you can shift the audio visual.
On? Yeah. Hello?
Yes, sir.
Yeah. This is a 28-year-old man who has been having pilonidal sinus.
Sir.
Over the sacral region. It's quite classical. There are no secondary openings in the midline, though I can see very tiny pits there, not very significant. Now I'm going to probe the sinus. It's not very deep. You can see this, it is around an inch or so.
Yeah.
Now we have been treating fistulas with waft and all. The only thing is to clear the granulation tissue, the hair and the muck. Even in fistulas, we clear the granulation tissue by scooping and washing, and then we just lace that cavity. The recurrence rate is similar to all the other methods of surgery, but the convenience of the patient and comfort of the patient post-operatively is very good. Even if it recurs, patient doesn't mind coming again to get it done. So what I will be doing, I will be just excising the external opening along with the hypertrophied granulation tissue. Cautery. Small scoop. Yeah, that one. वो है ना. Scoop. ये नहीं, scoop नहीं क्या? बड़ा है scoop. छोटा scoop नहीं है. Anyways, we have very tiny scoops available. They are not here at present. So what we'll do is we can easily clear the cavity. Sister, hydrogen peroxide betadine. One more gauze piece, thank you. So these are the small scoops which can be used for fistulas as well as these sinuses.
Have you found any hair follicles coming out?
Yeah, one or two. Very, very small sinus it is, sir. It is always advisable to get an MRI done pre-operatively so that we know the extent properly. Usually this sinus it gives you to the pit from which it originates. Now if I put it here, you can appreciate one small pit is there.
Yeah, pit
and
is there, we can see that, yes.
From there it has originated.
By the way, Dr. Sonone, what
Yes.
is the occupation of this person?
Just a minute, sir. What is the occupation? Occupation. Accountant.
Okay.
Yeah.
So he is having more of the sitting posture while working.
Sitting.
Nothing much. बड़ा hole नहीं बना रहे हम लोग.
Since this is not even a sitting area, it's almost on the high end of the natal cleft. I don't think his sitting will be affected. Even then we can give him coccyx support cushion, which is available on Amazon or in 1500 rupees or so, and patient can directly go to work. If you have a scope that is used for waft, or if you have a tiny ureteroscope, you can put it and just check the clearing of the granulation tissue.
Sir, this is a big wound. I think
Yeah.
if I have a scope, you will go inside.
Yeah. No, I had put the
Yes,
5
so 0 degree 4 mm telescope will also do.
Yeah. This, especially this one, it will do. But sometimes I find that the distal extent is very narrow. But now you can see the dimple.
Okay.
You can appreciate the dimple here.
Yeah.
Usually if the sinus is too long, what I do is, if suppose the opening is here, I take just cruciate incisions just to release the seroma that takes place after laser. So once you
take cruciate incision with the help of 11 number knife.
No, with a cautery.
With a cautery.
With a cautery.
Okay.
With a cautery, yeah. Now, what we do is, for all the tracts, fistula or sinus tracts, we use a radial probe. This is the radial probe. Can you put the light on? The lower, yeah. Tap it again. Yeah, that's all. The setting is 10.5 watts and continuous mode for all the tracks. Sister Godspiece, can I get a wash? Yeah. I like to give a wash so that rest of the muck that comes out. This surgery can be done under local anesthesia, mind you. Patient tolerance is good. You have to give a little bit of, so it's a continuous mode, and we just start withdrawing slowly. Around 50 joules per centimeter we are giving. And the surgery is done. We can just lightly pack the wound and leave it for
Sir,
healed.
The place where you could see that there is a dimple.
Yeah, but there is no particular pit I am seeing.
Okay.
So there is no use opening it up. And it's already closed.
Okay.
That's how he didn't have much hair there. एक pack देना betadine. So total energy I have used is 210 joules. Joules is watt into seconds.
You used 200 seconds.
200 joules.
200 joules means?
200 joules means watts into 10 watts into, that means
20 seconds.
20 seconds.
Sir, just 20 seconds you have done the surgery.
No, I'm not done the surgery in 20 seconds. We had to open, scoop, give a wash.
Okay.
It's the same thing that we do for waft.
Yes, sir.
Yeah. As I said, the patient tolerance is very good after this surgery. And the recurrence rate is absolutely comparable. Thank you. ये बंद करिए सर लाइट बंद कर करूँ टाका सर फॉलोअप बताना इसका फॉलोअप बताइए मुझे हाँ हाँ प्लीज no you please let me know the follow-up. Yes, it will be good. Nothing, just antibiotics, some anti-inflammatory for 5 days, that's all. The position is prone, I would say semi jackknife with the buttocks retracted.
Dr. Sonamane,
Yes,
any post-op instructions?
Yeah.
Like can patient lie on her on his back?
Yeah, patient is very comfortable. It's not a very painful process, so he can lie on the back. On the contrary, it gives some pressure.
Okay.
Yeah, and he can go back to work within a day or two.
Excellent,
Yeah.
excellent surgery, sir. ये इसको एक चिकन को लगा दो.
एक लगा दीजिए. Thank you, sister. Thank you.
Rajendra.
Yes, sir.
Very nice procedure, well done.
Yeah.
Congratulations.
I thought some longer sinus should have come. I would have demonstrated the release incisions along the way, and I wish next workshop we will show the result. Thank you very much.
I think we will search longer pylonidal, don't worry.
Yeah, thank you.
जितेन कोडवानी हियर हाँ फोन करिए फोन पे बात करते
हेलो
हाँ फोन करिए जितेन जस्ट कॉल मी
ओके फाइन
योर फोन इज स्विच ऑफ जस्ट कॉल
Hello, sir. Jiten, sir.
Yes, sir.
How many cases are pending now?
I think 3 more.
3 more today.
Acha, only 1 more.
One more, right? So
Yes,
that
sir.
we have left
That
your
Dr.
foot
Kanekar
here.
is going to show Dr. Transanal suturectoplasty. Chief test procedure.
Dr. Kanekar, sir, na?
Yes, Kanekar, sir.
Okay. We'll be there till that time. Okay. चालवतं का काही सांगितलं तुला वो ऐसे रहता सबका पुन्हा पुण्याला ठेवलं कंपनीने केलं रजिस्ट्रेशन मी करणार आहे तो राहण्याचं करू शकतो रजिस्ट्रेशन जास्त नाही रजिस्ट्रेशन कमी असतं का
10,000
तू कोणा केलं तू नाही
10,000 मैं बताता हूँ ना
तू नाही करणार तुलाही करावं लागेल सगळ्यांना कंपल्सरी हो नाही तर मग आपण आपण करू. मला इथे पुन्हा एकदा येते. ते दिलं. चालू केलं लाईट ऑन येतात.
हॅलो
हे पहिल्यांदा काढायला.
हॅलो राजाभाऊ. हॅलो
केस जातात. ओके.
हॅलो
एक गॉस पीस दे आणि हे द्या. हा लांब ठेवायचा. हा आणि एक फोरसेप दे मला. बॅककॉक दे एक.
हॅलो 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 राजूभाऊ.
प्लेन फोरसेप पाहिजे मला. आणि जरा लांब द्या.
हॅलो हॅलो थांब जरा सरांशी बोलतोय मी.
दे नीडल होल्डर, नीडल सुचर मटेरियल.
हॅलो
नाही हा बहुत खूप छोटा आहे, जरा मोठा द्या. हा बरोबर. चल हा खूपच लांब आहे पण चालेल. हा ह्याच्यापेक्षा मीडियम, ह्याच्यापेक्षा मध्ये काही नाही ना ह्या आणि त्याच्यामध्ये. जेली लावून घ्या. काय झालंय हे. देयर इज ट्रॉमॅटायझेशन.
हॅलो राजूभाऊ. हॅलो
हां बोल ना.
स्ट्रीमिंग ऑन ठेवायचे.
हॅलो
हॅलो
हां बोल. काय आलं.
बोल स्ट्रीमिंग ऑन ठेवायचे की स्ट्रीमिंग चालू बंद करू.
एक मिनिट मी सरांना फोन करतोय. मी
ठीक आहे सरांना
ते बघायचा प्रयत्न नाही करायचा. हा फक्त मी तुला रोटेट सांगितलं की तू रोटेट करायचं. हा घे काढून माझा.